might put into practice. I'd like to start by thanking UCG for organizing this wonderful collaboration and collection of global experts. I'm humbled by the privilege of addressing such an exceptional gathering of healthcare professionals from around the world. It's an honor to witness the power of collaboration and knowledge sharing that this event represents. I am a nurse educator, late of the academic world. I've returned to the acute care setting now to work with nurses already in practice in the ICU and emergency department. As I was preparing for this conference, I considered what healthcare truly was. In 2018, Braithwaite described healthcare as the product of a complex adaptive system, people, equipment, processes, and institutions all working together. And as I read this definition, I envisioned gears working together to move patients through a system. And I thought, well, that seems fairly simple. But what happens when one tooth on one gear fails? A devastating, or actually, as Ms. Stephanie El-Khoury reminded us yesterday, that patient safety and outcomes are at risk whenever human error, limits of the system, or severity of a patient's condition alone or in combination exist. A devastating example of all three of these that come into play is that of a 42-year-old timber worker who was injured while falling a tree. At 9:20 in the morning, he suffered direct knee and proximal trauma to his leg as a large log fell on him. The clock starts to tick now. Because the site of the accident was so remote, it took 60 minutes for rescuers to reach him, extract him, and bring him to a local small hospital. At that hospital, they x-rayed the limb and they found a multi-comminuted fracture of the proximal third of the tibia due to the trauma. X-rays showed, debridement and suture of the anterior superficial wound and splint immobilization were performed, and it was determined at that time that the injury was too complex to care for in that setting, so they transferred the patient to a higher level of care. He arrived there at 2 p.m., 4 hours and 40 minutes after the injury, where an orthopedic consultation was performed, and they noted a missing distal pulse in the limb. They noted sensory and motor deficits in the foot and the wound in the popliteal fossa with a potential artery injury. Without an available vascular surgeon in the hospital, they performed a cardiologic consultation followed by a CT angiogram, which demonstrated interruption of blood flow to the limb distal up to the injury. 6 hours and 40 minutes after the initial injury at 4 p.m., the vascular surgery consult was performed. Now, the optimal time frame of 6 hours for vascular intervention was exceeded, and the prognosis was not good. All this information was relayed to the patient and to the family, and despite the odds, the surgery was performed on the leg. Debridement, lavage, suture, and popliteal artery prosthesis were performed, and the tibial fracture was stabilized by means of an external fixator. Postoperative evaluation was unfavorable, and because of the vascular compromise to the limb, the patient underwent an above-the-knee amputation. As healthcare professionals, we acknowledge and understand our responsibilities in providing care and supporting the well-being of individuals and communities in often complex and high-risk situations. Our roles have never been more vital than in the challenging times in which we find ourselves today. We strive to develop and maintain organizational cultures which promote blame-free environments so individuals can report errors and near misses without fear of reprimand or blame. We encourage collaboration among staff to identify opportunities for improving patient safety and have an organizational commitment to provide resources that will help address safety concerns and further prevent system failures. This is why we're here today, to learn about the research, best practices, and systems that promote safety and well-being for those individuals whose care we are entrusted. I hope everybody learns something new today from this conference that he or she can integrate into practice. Once again, I'd like to welcome you to today's session. And without any further ado, we'll go ahead and get started. It is my distinct pleasure this morning to introduce our first speaker for today, Dr. Wissam Khalid Abdul-Jabbar Al-Janabi. I hope I pronounced these names correctly. I am passing the stage to him to deliver his speech on surgical safety in Iraq, challenges and solutions.
طيب استأذنك بس تكون على أنزل معك عشان الأونلاين attendees مع حضرتك ويشوف.
Good morning, ladies and gentlemen. Really, I came from Iraq in order to explain our experience, poor experience in surgical safety in Iraq, because of the whole circumstances and the political situation there. The storm that put the Iraq in the middle of the lobby of these circumstances. First of all, we should know that about 234 million major surgical operations done annually, and 7 million of them have surgical complication. 1 million of them has mortality rate because of surgical interventions. This is annual, worldwide percentage. First of all, we should know why surgical safety is important, and then we will talk about who is involved in the surgical safety. After that, we should know about what are the issues that should be addressed to achieve surgical safety, and what are the challenges that need solution in surgical safety. After that, how can we apply or ensure surgical safety in our institutes? Now, surgical safety has a main goal, is to prevent the adverse event or error during the surgery. This is the main goal of surgical safety. Surgical safety, of course, is a part of the patient safety. But in the surgical world, it's different, because it takes care of the patient when he's going to the surgery, or during the follow-up monitoring, or in the pre-operative preparation to the surgery. So it's somewhat different from the patient safety itself. We have elements in the surgical safety. Most of these elements are also sharing during patient safety also, like communication. So communication between the surgical team, between the anesthetist, between the nurse, between the surgeon, all of them are very important in achieving the patient safety during the surgery. Checklist, WHO checklist and other checklists ensure that to put a tick on what you need to ensure patient safety or surgical safety before, during, and after. That's why we have the WHO checklist, and I think one of my colleagues will talk about it in pediatric age group, I think from Mexico. Let's talk about the pre-anesthesia period and pre-incision period, and post, just prior to the departure of the patient from the operating theater. Teamwork. It's very important that all the team work, know what is the case, what is the procedure, what is the surgical site, what is the patient ID. All of these information should be known by all the teamwork in order to reduce or make the error zero. Standard operating procedure. They are written instruction that make the patient safety or the surgical procedure in a consistent way or pathway to decrease the adverse event. Monitoring is very important. Intraoperative monitoring of the patient during the surgery. Did the patient receive blood? Or was there any complication during the surgery that need to be followed up after the surgery, or certain instruction that the surgeon write to monitor after the surgery? So this is the teamwork about ensuring the surgery safely and efficiently, and the standard operation procedure. This is a global checklist can help and ensure all the information steps. And I'll show you an example of the checklist. The monitoring throughout the surgery and address the potential problem. So surgical safety is an important priority for healthcare provider. And by implementing evidence-based practice we talked about yesterday, such as the use of checklist, standard operation procedures, healthcare provider can help to reduce the risk of error and adverse event of surgery. One example of our surgical safety checklist was used in Iraq, and I told was used because from 2010 till 2012, we had in Iraq a revolution of using checklist surgical safety in Iraq. So it was published throughout the whole hospital in Iraq, the government hospital and the private hospital. But unfortunately, it just lasts for 2 years. You can see by this that before the induction of anesthesia and before incision, it's called sign in, time out, sign out. The anesthetist is involved, the nurse is involved, the surgeon is involved. All members, all the teamwork are involved in such checklist, just in order to reduce errors and adverse events. And I will mention to you 3 examples from my country, what happened to the patient when the surgical safety didn't apply. In the United States, the Joint Commission Universal Protocol is applied. It's the same as the checklist, but here you can see to add patient name is very important, surgical procedure is very important, surgical site is very important, because these main 3 making the about 60 to 65% of the whole surgical error in patient safety. So they take care about these points. Also, the surgical care improvement project regarding the antibiotic prophylaxis just before the incision done, and the thromboembolism prophylaxis regarding the use of compressive stocking or the use of anticoagulant just prior to the surgery. All of them are very important also and added to the Joint Commission's Universal Protocol. Standard operating procedure. I think even in the standard hospitals, still there is a deficiency in the resources of the standard operating procedure, because for each hospital or for each health institute, they have their own rules in applying the standard operating procedure being written. That's why we don't have nationalized or standardized standard operating procedure for as a guideline for the whole world. So some of the areas of the current research, from time to time we see a new checklist is developed. From time to time we see that a new technology to reduce surgical error and to maintain surgical safety, like the barcode. So the barcode, when the patient put on his hand his barcode, the barcode is checked triple. First of all, at the ward, second, just before the admission to the surgery, and third, on table. This will ensure that the patient had the surgical site correctly and the ID correctly and the procedure correctly, because the information will be applied on the monitor. Now, what is the goal of the surgical process? Also, we will return to Dr. Noor yesterday said about evidence-based practice. These evidence-based practices should be collaborated together in order to reach the maximum level of patient surgical safety, because sometimes it is not forgivable to have error in some cases, as I will mention to you at the last of this lecture. What about Iraq? Iraq is a complex situation. It's a very complicated matter. Neither the 310 governmental hospital nor the 180 private hospital applying any of these benchmarks standardized. It's a big issue. That's why from time to time, as a surgeon, as we have multiple groups, we heard regarding surgical unsafety. We heard about surgical error. We heard about adverse event. That is preventable. That's the problem. So in Iraq, we lack for resources. We don't have data. All of our hospitals, unless some few hospitals which have been held in the last few years on investment program in Iraq, there is no standardization to have the resources on collecting base data or systemized base data or automated base data. We don't have. All the governmental hospital still using the paper files. Lack of training. We should learn the staff. All the staff is not well trained regarding the surgical safety. They don't know what to be checklist. They don't know how to do the ticks on the. Also, we translate the WHO checklist in Arabic, but still the staff neglect this point. And sometimes they are doing ticks without even asking the patient, just to fill the form, no more, no less. Lack of standardization. You know, if you want to apply something globally, you need guidelines. Even this is, I talk international. When you are going to talk about this nationally, you need a national guideline for your country to apply in order you can judge or you can justify this checklist or this national checklist to whole of your hospital, whatever, if it is a governmental sector or the private sector. Despite all these challenges, but we have small numbers of private hospital applying the WHO checklist, which is very good, but still the data is on papers, not systemized on computer. There is still a long term in Iraq, and we need a lot of issues to do. The best last thing in the few last years, as I told you, that improve or start to build up a real surgical safety in Iraq is the investment. And I saw as the Marino Hospital, which I worked for, start to build up the idea of surgical safety through having the accreditation. Because, you know, the accreditation system in Iraq is still not applied even in one hospital of the 500 hospitals present in Iraq. There is no accreditation. So in our hospital, Marino Hospital, which is one of the hospital in Marino Group for medical service, is now signing contracture with the HCAC, Jordanian HCAC, in order to have accreditation for all the system of the hospital. All efforts of the government applied to have surgical safety in the hospital failed because of the minister, the MOH policy is changing from 6 months, 1 year, 6 months, 1 year. And every every in charge male or every in charge man or responsible man coming is changing the plan before. So there is no continuity in the planning in Iraq. That's why this changing from time to time fail to show us real surgical safety in Iraq. This work is being done by the Iraqi government and other organizations, and the examples of surgical safety measuring in Iraq. I just want to talk to you about 3 examples from my country. And I remember when I was a senior house officer in general surgery about 2009. One day we were called on Wednesday, and we have 2 patients with the same name and name father. They are different only in the grandfather name. One of them has a cold case of right inguinal hernia, waiting for his surgery the next day. And the other one was acute appendicitis, waiting for his surgery on the same day. We call the patient through an information staff, not through the nurse. The nursing system in Iraq is very retarded. Sorry for this word, but it's retarded. They only use to give medication. This is the meaning of nursing in Iraq. So they call for appendectomy patient, and during the surgery for appendectomy, they told us that this patient is not for appendectomy, this patient is for right inguinal hernia. And it was really a major problem. Another fact or another accident happened in Al-Fallujah hospital. It's a few years ago. There were 2 children, one of them need to be circumcised, and the other have a foreign body in his foot. They share the same name and the name of the father. The child with the piece of a glass was the second on the list. The first was for the circumcised child. So when the child with the circumcision go to the surgery, the surgeon saw that it's really incomplete previous circumcision or something, because the surgeon said that I saw he might be circumcised already. So he doubted about that. Anyway, at the end, the change was happened, and the child with the foreign body in his foot has been circumcised. Unfortunately, he was a Christian. So it was a big problem. I think at Fallujah hospital. It was a big problem. Really, big problem. Third of these, 2 days prior to our coming here, patient with appendectomy, female patient with appendectomy, and all appendix in Iraq sent for histopathology. You know, because 1 in 250, there is a risk of underlying or occult malignancy. So that's why we send each appendix to histopathology. The report come from the histopathologist said, normal fallopian tube. Please check your surgery. Surgical safety is not a written things. Surgical safety is a mindful things. They should be applied as a teamwork. They should be applied as a continuity of the work. They are standardized. They are not jokes. It's very important to have surgical safety in our institutes. It's very important to build up a system for surgical safety in our hospitals. Because really, if we are going to continue on such circumstances, it will be a mess. Now, I think, and thanks God, we have the investor. The last thing to think about in Iraq is money. That's why now the investors start to think how to improve, because this creates competition. The increasing of the private hospital or the private health institute in Iraq create the competition between the investors. So they finish the building, they finish the good surgeon attraction, they finish other things, but they start to think about quality assurance, quality control, accreditation, surgical safety, patient safety, which will be the field of the competition in the next 3 to 5 years, inshallah. Thank you very much for the listening. Thank you, Dr. Barba. Yes, correct.
You gave some wonderful examples due to the confusion of having the same name. Do you also now have use a second identifier to identify patients so that this is avoided in the future?
Okay. I'm going to talk about private hospital and government hospital because doctors in Iraq can work in both. You can work on governmental at the same time you can work on private. In my governmental hospital, no, we just rely on the information staff. We say to the information, bring us, for example, bring us this patient. He will go and bring the patient. What do you have surgery? Okay, go on. On the private sector, no. We have double or even triple check from the nurse on the surgical ward, from the nurse in the operating theater, from the anesthetist, and lastly, the surgeon on the table. Because in the governmental hospital, all the people in Iraq know what is the situation there. That's why it become for the low and mid socioeconomic status. For the high socioeconomic status, they always go to the private hospital and even mid socioeconomic status. That's why the risk of patient unsafety in the private sector is less than the governmental hospital.
Thank you.
Thank you very much.
Excuse me, according to Joint Commission of Accreditation, actually there is a set and guidelines for the accreditation of the patient.
Yes.
We should not use only the name. That's why I'm wondering why there was a confusion. At least you have the name, you have the age. I think this should be why you are using only the name.
Of course, no. I just given an example for the name. Yes, it's because surgical site, surgical procedure, that's also an important thing to know about. But I am talking to you about the governmental hospital. In the governmental hospital, they depend only on the name. That's it. That's it. Yes, that's it.
Who is the information person?
Information person, the person who is the joker guy between the surgical theater and the surgical ward. No, of course, no medical background, of course, no medical background. No. But this is again, this is in the governmental house. Yes.
Hi, good morning.
Good morning.
So it's as you mentioned that there is no specific criteria, so it means these government hospitals are not following through any of the accreditations or any of the standards.
Definitely no. Definitely no. Pardon? Yes, of course. 75% of the whole population of Iraq, you know, we are 40 millions are going to the governmental hospital, and all of them are sorry, all of them may have the same surgical unsafety or the same surgical effect when they are going to the governmental hospital. So now the people in Iraq deprived from the surgical or from the governmental hospital and going to the private sectors, because the private sector is now, after the competition investment, they start to receive even with low cost. You know, when there is competition, there will be a fall of some hospitals and rise of other hospitals. So the fall of some hospital, they will start to decrease the cost of the surgery, the cost of admission, the cost of that's why the people with low and mid socioeconomic states are going to go to these hospitals, because the governmental hospital, really, whatever you hear, I'm here to tell the truth. It's my country, and I love my country. But it's the truth. It's the truth. Really, it's mess in the governmental hospital. There is some governmental hospital I can count on my one hand all over the Iraq. I can. Yes, there is, and applied with the WHO checklist. But still, the application of the WHO checklist is not informative. Is not. You know, when you are a medical staff, you should feel the importance of filling the checklist. This importance is not felt by all. I'm not going to decrease the matter of my staff, but no. Yes, sorry.
Thank you.
Thank you very much. Yes.
Thank you, Doctor.
Still getting organized. Thank you so much. Now I'd like to introduce our first keynote speaker today, Professor Annegret Onawa from Switzerland. I'm passing the stage to her so she can deliver her speech on horizons of safe communication. What have we not yet done?
Morning, everyone. I'm going to put my clock up here so I keep time. It's very nice to be here. Thank you so much for having me. So I guess when we talk about patient safety, we like talking about, you know, the joint commissions, and the checklists, and the WHO things and so forth. So I'm coming here as a communication scientist, as a professor who's been studying patient safety for the past 15 years and who also has become a patient. So I wanted to actually do a little bit of a field study, and that ended up being me being in the hospital for 2 years and navigating through the system and being able to extend my perspective. Okay, extend my perspective from that sense. And I'd like to share some of these things with you today. So there would be no healthcare without communication. And also actually without communication, there would be no humanity. Because since the day we started breathing as a humankind, we've used our communication as a safety mechanism. We used to sit by the fire, let's see them, sit by the fire. We used to have communication as a means to keeping us safe. We sat by the fire telling each other stories about safety. Still today, we sit around the dining table or lunch table with our parents and they tell us fairy tales, they tell us myths. And what do these stories tell us? They tell us about threats, about dangers, about things to avoid. How we burn our hands on fire. I'm sure all of you have stories in your mind how your parents used to tell you things of what to avoid to prevent getting harmed. So this is one of the fairy tales that we tell in Switzerland as well. So my question is today, to what extent do we practice such communication in patient care, where safety keeps coming up on the top of our priority list? So some of you may know Samuel Chem, who in his book, The House of God, reminds us that everything we do to patients or we give to patients is subject to the limitations of our human fallibility. And that doing less or doing nothing at all sometimes is safer or better for the patient than intervening in the first place. So sometimes less is more, because every action also comes with mistakes and risks. Does this advice also apply to how we communicate with each other? So on average, we know that one physician has about 200,000 consultation hours with patients in their lifetime of a career, and many more with colleagues. It's by far the most common of all clinical activities in the daily routine. But how are we doing with that? And do we ask ourselves that question enough? Is there a quality indicator for communication in healthcare? Like, there are also guidelines and milestones and yardsticks for far less frequent activities that we conduct in the healthcare system. And to what extent do we use our communication with each other as a safety mechanism, which is one of the most common primary functions, as I said before, and purposes of our communication in the first place? Do we use this strength enough to ensure safety during care provision? So as I mentioned before, I've asked myself this question in my scientific work for the past 15 years. As a communication scientist entering this field back then as a doctoral student, I've been seeing our interpersonal communication as a fundamental factor that either unites or divides us. And that reaches far beyond the healthcare sector. Of course, that also happens in our families, in our schools, at the workplace, in our marriages, any conversations that we have with loved ones or more distant ones. And the COVID pandemic has shown to us how important that communication is in most visual ways. So, but I said, what about our communication and healthcare, returning to that field? So again and again, we hear estimates that about 80% of avoidable harm in healthcare traces back to communication breakdowns, communication failures. But what exactly goes wrong? And what causes these failures? This is only looked at superficially and unfortunately treated even more minimally. So if we look at the interventions that we've undertaken against this enormous source of harm and error in relation to the size of the problem, we've really only looked at the tip of the iceberg. The question is, what lies beneath that surface? So let's look at some data together on the successes of previous communication tools that we've, in most countries, implemented so far. So the first one is IPASS. You may have heard that before, a structured process that keeps information clear and accurate sharing between team members. So what has IPASS done today? We know that the best study has shown a 30% reduction of preventable adverse events at 2/3 of the investigated sites. We look at SBAR, which is just to ensure that content is not lost during handoffs, right? So this comes from long chains of information, particularly if you look at an aircraft carrier, for example, you need to make sure that the information from the engine room passes to the command bridge and so forth. How has SBAR done? Well, there's limited and actually contextual constrained evidence. There is no experimental studies we can look at, and those are limited also on, for example, contextual context, such as information exchange over the phone. So also not much we can talk about in that sense. And also the WHO has led a big speak up program. So speaking up against harm is a good theory, but in practice we see that it's actually not worked just as little as checklists for interpersonal reasons, for hierarchical reasons. And also speaking up has led to side effects that have, some studies have shown, actually brought up additional issues such as collective vigilance, where we just kind of count other people to say something since the Speak Up program is implemented. So going back to the iceberg, communication errors we've looked at only in risky situations, but what about all the others? We don't treat anything else. Now, we can start with that, but this is not the place to stop. So if we look at the communication processes, and there's just a quick video here to show you how does communication look like? Well, there's 3 processes to that, right? The first thing is we share information. So I encode information to you, then you decode that information. And what you see here is we all make sense of that within our field of understanding. Everybody has a different field of understanding. And the purpose of the communication is to overlap those fields of understanding, right? So that's an active process that has to transpire for communication to be safe, so that we actually attain a shared understanding. So where are we challenged in those processes? So I've conducted a lot of studies on this, analyzed thousands of patient safety events line by line, going through seeing where those issues are lying. As you can see, we're actually not doing well in the sending process in the first place. So we're not over communicating. A lot of the errors are happening in how we send information. Then discussing that transactional process where we make meaning with each other, it's the second most frequent source of error. And the last one is the actual reception and the decoding, the interpretation of messages. What about looking at the competencies? So you can see here, our biggest issue is sufficiency of information exchange. We don't communicate enough. Now, this may be a misperception because we think we all have so much information around us, but information is not communication. So when we have a lot of information, the data imply we're not communicating enough to an extent that we actually make sure the information was received, the other people have understood that information, we've attained a shared understanding. The second one is contextualization, relational barriers, hierarchies, timing issues, delays, those kind of things. Third one is the extent to which we use our communication to ensure accuracy. We don't really do that enough. Then we get to the lower frequencies as interpersonal adaptation, to what extent we actually recognize the person we're talking to is not following us anymore. Do we ask that if they have any questions and so forth? And then clarity is the least frequent error that we find, but most often the fatal ones, which is ambiguous or vague communication that is not clarified. So we've conducted a study also because the question comes up again with the quality benchmark, right? So where is that benchmark of safe communication or good communication that we should be measuring, given that it is the most frequent activity in clinical care? But the question also arises, by whose perspective? Is it the perspective of the physician, the perspective of the nurse, or the perspective of the patient? So we conducted the study where we gathered hundreds of descriptions of high quality care and low quality care from physicians, nurses, and also from patients, and then we analyzed them, what they came up with. So you can see that here's some of the data that we categorized the data into structured processes and outcomes with the donor obedience scheme. You can see that, not surprisingly, half of the data actually fell within the process category, and within that process category, more than half of them fell into communication issues. So breaking them down into how they played into good versus poor quality descriptions, you can see that particularly when things went out poorly, communication was blamed. So what did these stories look like according to the perspective? So you can see here, the red ones are the poor cases, and the green letters are the good descriptions. I'm just briefly going to mention some of this data. So the patients, with respect to good care, mentioned things like this. During the 5 days that I was in the hospital, I felt treated, comforted, and cared for in a loving manner by the medical staff with endless commitment. This helped me recover and not drown in fear. Your exceptional care prompted me to write a thank you letter to the entire team. Things such as nice and polite healthcare workers who expressed extreme sympathy and courtesy. The nurses said things such as, we responded to the patient's concern, we talked to family members, we accepted the patient's wishes to die at home. And the physicians raised issues such as, the clinicians have used every opportunity to look after the patient, the palliative patient on the ward. The patient was ready to die, but he was waiting for his son. Scores of healthcare workers have stepped in, and there was very little time to arrange for the son's immediate arrival. Fortunately, the son came on time and the patient was able to say goodbye. About 30 minutes after his son's arrival, the patient died peacefully. Now, looking at the poor quality care cases, what did patients say? I was almost afraid of the nurse. She treated me like I was a nuisance who hindered her work. The nurses said the patient's symptoms were not properly managed because the physician assumed the patient was pretending or exaggerating. Or when clinicians discharged the patient without considering that the patient did not have the resources at home to perform to follow the dismissal procedures that he was told to do. Physicians said the patient was insufficiently examined, particularly with regard to his medical history, omitting a syncope that led to the oversight of an acute coronary syndrome. Or despite the parent's explicit request, no urine analysis was carried out on the child, and later the parents' suspicion of a urinary tract infection was confirmed. So as you can see from these examples, 4 eyes see more than 2. But that's useless until we successfully bring these perspectives into alignment. So how do we bring these perspectives together? Because there's really no safety without successful communication. So if we look at the communication that we teach and that we learn in the clinical field, so physicians have 2 dead languages as a foundation of the medical vocabulary. Now, what kind of language do nurses use and what kind of language do patients use? So if we look at the Maslow's hierarchy of needs, some of you may be familiar with this. We all have different needs and wants, of course, but needs that we actually pursue. Now, if you think of the physician, or if you think of the nurse, or if you think of the patient, which category of needs are they walking in? Very discrepant, right? Very discrepant. The patient's question is going to be, is this a person with whom I want to share my most intimate concerns? So what we see also is not just the conflict between these needs, but also conflict within us, right? So we know from the most ancient times, errare humanum est, to err is human. But then the problem is, well, that was the other way around here, errare humanum est, but the first one says primum non nocere, first do no harm, but also errare humanum est means we make mistakes. To make mistakes is human. So how do we befriend that need of safety with our natural tendency to do harm, right? The battle against our human nature. It's a battle against ourselves, battle against who we are and who we want to be. So the secret lies between us. Only our communication with each other can help us fight our individual fallibility, can help us keep each other safe. It's the collective strength between us that can defeat our individual weakness. It's the math of safety. More eyes see more when they are successfully aligned. So we see this particularly in teamwork. These are pictures that currently are all over the news. We know that in rescue situations, in emergency situations, bumpy teamwork costs lives, fluid teamwork saves lives. Very simple math. And I actually spent a year with a rescue company in the Swiss Alps, flying along to rescues, saving patients in critical situations, both patient critical situations as well as geographically critical situations. And this was a situation where a helicopter had crashed overnight. There was terrible communication going on because it was at the border to Italy, so people were not really sure if they should be going on. It was close to 5 p.m. in Italy. Close to 5 p.m. means it's time to go home. So there was a code elicited by the helicopter to say there was an emergency, and the Italians figured, sometimes they just go off. So let's have the Swiss people handle it. And then the weather conditions were terrible. So we didn't get the signal until 5:30, weren't able to head out, didn't really know where we're going, didn't get clear geographical coordinates. So what happened here is 3 of us went out in temperature of about -7 degrees at 1,600 meters of elevation. And they went up to 4,000 meters elevation, because somewhere there should be the wreckage of that helicopter. And the visibility was terrible. They were themselves in life endangering situations, just trying to find the wreckage where they didn't know where it was located, but they knew there must be somebody hurt up there. They struggled through this until 2 o'clock in the morning. On the way there, on that 7-hour rescue, they were about to give up 3 or 4 times, but one of them always said, no, we're going to keep going. So what they ended up finding was, you can see there is one person who was dead, the pilot was dead, but on top of the wreckage was a living patient. And the patient was brought to the hospital and survived with hardly any injuries, but, just having frozen almost to death. Had they just stopped and waited until the next day, that patient would have been dead. Would anybody have blamed them? No, but they rescued that patient. So how did they do this? One person alone wouldn't have done it. It was their teamwork. It was their communication with each other that made them do this superhuman and become more than they would have been than the sum of their parts. So this is just one of those many situations I've witnessed in that setting that have shown to me, yes, mistakes are our greatest weakness, but our communication can turn our greatest weakness into strength because we see better, we learn from them, we grow, and we reduce our mistakes. So basically, we're helpless under stress. Our communication with each other comes in and gives us delight, saves the day, protects us from a world filled with that fear and anxiety associated with that profession, particularly in those high-risk contexts. So what do we need to look out for? Well, it's the red flag moments. It's the red flag moments. It's those moments where we see our inability to communicate in that situation can cause harm, right? So that's the one thing. Communication creates safety. We put in our communication to create safety, but another thing of that situation is it safe to communicate? So communication creates safety, but also, is it safe to communicate? And this is where we go back to the issue with the speaking up problems, speaking up and so forth, hierarchical problems, cultural issues that we need to be dealing with. So how do we encounter these moments, particularly these red flag moments? It is with safe communications. I keep talking about safe communication. Let's just briefly look at what the safe communication looks at and kind of describes as a definition. It includes all verbal and nonverbal behaviors that maximize the likelihood of a shared understanding through quality and also quantity. So quantity would be sufficiency, and the quality we've defined as accuracy, clarity, contextualization, interpersonal adjustment or adaptation, to promote safe and high quality care. Now, this definition came from those data analyses where we've analyzed all those cases, and I'm just quickly going to go through them together. What does the S stand for in Sakya? Sufficiency, and that means of the 100% available information, how much was a provider able to extract from discussions with colleagues, patients, and also care companions? So this is the quantity of information. Then we have the A stands for accuracy. So to what extent have we used our communication with each other and with patients and with companions to ensure accuracy of information and also to ensure an accurate understanding? So communication is our vehicle of an accuracy validation process. Then we have the first C, which stands for clarity. As I said before, not so often an issue, but if it happens, they're typically fatal problems. To what extent have care participants used their communication with each other to eliminate uncertainties and ambiguities and to ensure shared understanding, and not just click away that screen because we don't know what it means, or not just assuming they've communicated because we see them on the phone, those kind of things that we've read across those safety cases. The second C stands for contextualization. To what extent did care participants use their communication with each other to neutralize contextual barriers that stand in the way of shared understanding? Contextual barriers are the goals we pursue may be discrepant. Hierarchical barriers, barriers imposed by time constraints or by timing when we communicate with a patient and so forth. There was a lot of issues we've had also with when things were communicated, things ended up changing and then the communication wasn't corrected and so forth. And then last but not least, the IA stands for interpersonal adaptation. To what extent did we respond to spontaneously expressed needs? This means you're talking to somebody and you see they're emotionally distressed, they're not following you. They're not really comprehending what you're saying linguistically. They're not cognitively processing the information you're telling them. And what do you do in that moment? You don't leave the room. I've heard particularly in oncology, physicians saying, once I say the word cancer, I just leave and come back in 10 minutes because they're not even listening to me anymore. Well, what does that leaving mean? It's communication. So we talk also about nonverbal communication. I would like to take a minute for story time, but I'm running out of time. So unfortunately, a story I would have loved to share, I have to leave up for next time. But I'd like to briefly summarize. This was the tilt table story. What does that place look like here? It's a place to gather. It's a place of safety. Well, communication in healthcare, when we say communication in healthcare, we talk about ever new technology that burns us out, for which we have no more time. Going back to Samuel Chem, sometimes less is more. What if we had to do less rather than more when we talk about communication? What if we just have to do it differently? Maybe more simply. Maybe less quantity of information, but better communication. Now, everybody values information greatly. Sufficient information, however, is not successful communication. Information is just the tip of the iceberg. It only becomes valuable when it runs through the assembly line of the interpersonal meaning-making process. So we need to find ways to reactivate that interpersonal space between us for our safety to take place. So those 5 competencies I've talked about are the 5 triggers that will help us stay on that safety path. Our communication builds that bridge between us again. It serves our safety. So let's recreate that fire and gather again by the fireplace to share our communication. Thank you very much. So very brief questions.
Thank you, Dr. You talked about communication between physicians and nurses in your example, and it almost seemed as if they were passing responsibility from themselves to the nurses and the nurses passing responsibility to the physicians. I have found that in the US, when nurses try to stand up and speak directly to a physician, that sometimes the physicians are offended, may feel threatened. Do you find that also in your work?
Yes. So we've had, and I wish I had more time to share cases because there's cases that sing songs to that problem. Yes, there's definitely, especially in Switzerland too, we actually have separate electronic health records for physicians and nurses to avoid that communication. Things where we've had fatal cases, also patients, lots of stories to tell where that failure to communicate because you like to pass it off to assume other people were doing it, but also the fear of actually addressing that hierarchical issue. But yeah, so we definitely have that same, we've seen that quite frequently under contextualization in the data.
Thank you so much.
Thank you so much for this interesting presentation. So, is there any application done on this acronym research? Something similar like TSTEP, even built in IT, clinical information systems.
Yeah.
Do you have any experience with this?
So in the process of actually turning Swiss hospitals into safe communication hospitals now. So this is the new part. So we've done mostly the retrospective analyses and using Sakya to analyze events and so forth. But now we've created training programs to turn the weaknesses into strength. We have to actually turn the failures into competencies. So we've done that. It's been applied also in Korea. It's been applied in the US also. I'm working with the emergency department in Texas now and implementing Sakya, and they're receiving the ambulance kind of handoff communication. So a lot is happening in that sense because it's really the first, a lot of the communication tools we've talked about, we've just kind of imported from the military, from the airline industry, and haven't really validated in the healthcare system. And I think culturally those contexts are so different. So this is the first time we actually have patient safety data from which we derive the communication failures, turning them into competencies in an evidence-based way, measuring impact over time. So we're now starting this fall to transform one of the cantonal hospitals of Switzerland into a safe communication hospital, looking at IT, but also bringing in the competencies from teaching and so forth, and revolutionizing sort of the whole thing with a low minimum interference, because as I said before, we all communicate all the time anyway. And unfortunately, communication is often seen as this Mount Everest of things that we don't have time for to do anything else, but we do it all the time and we do it very inefficiently. So we're actually measuring also to see if we're using Sakya, how much time can we save? How much frustration and burnout can we save?
Because when I came across, HR or literature, communication stands alone like a very vital element. And I've seen multiple tools like validate, feedback, SWOT. It's the first time I see this stuff. So it's very interesting to see literature application.
Yes, and these are really structuration protocols. That's the difference. That's why I keep talking about information is not communication, because they're not competencies. They're just protocols to help structuring information. So they're not really, getting at the communication part that's missing. So for me, yeah, we'll hopefully be able to share those experimental data very soon. Yes, yeah. You're welcome.
Hi, can I share some comments, please? Can you hear me?
Oh, online.
Hi,
Yes.
sorry. Okay. Thank you very much. Again, it is, of course, communication has been like this for a long time, and whether it's Bar or Sakya now or whatever, we're trying to structure and standardize how we actually communicate. But I think we can see the errors still really rising, and the miscommunication is still an issue. My point here is we have done well. We standardize ISPAR or SAPIA or whatever it is acronym we have and structured it. But the issue is we haven't really invested or standardized healthcare providers themselves. So we try to look at physicians and nurses as a one homogeneous, people that where their personality is the same, their understanding, their communication skills. So really, should we not as well look at people cannot be standardized just by an acronym like SAPIA or ISPAR, and we need to invest as well on individual differences between the team as well.
Differences between the team. Did anybody? It was hard to understand the question. So the differences in the teams.
Meaning, I'm trying to say, for example, your SAPIA, whatever the S or A stands for, right? Yeah, the healthcare providers can give you maybe 10% of the S, and some others can give you 20% or 100%. We standardize the structure or the environment, but can we standardize people?
So if I understand the question correctly, so for me, what we're doing is as you're implementing the SAKYA's competencies into teams, for me, I don't discriminate between nurses or physicians in any ways, because what happens with the SAKYA is what happens between us, right? So it's basically every participant in that communication episode contributes to SAKYA happening to 100%. So the question is, to what extent are we able to achieve that successful understanding? So the measurement that we're trying to do is the percentage of a shared understanding that we can attain by implementing those skills. So I'm not sure if I understood the question correctly. That's as close as I could understand.
Yeah, it's not about discrimination, actually. It's a negative word. Can you hear me? It's not about discrimination. It's about understanding differences between physicians and nurses, and even between nurses themselves, in the way they actually understand and communicate and their skills. So people are different in how they communicate. Even if you give them a checklist or an acronym, they will not actually deliver that acronym in the same
right. And okay, I got it now. By discrimination,
to.
I didn't mean by discriminating them. I mean discriminating in terms of how we treat their communication. So yes, there will be personal differences in how we communicate, but we've also found in the literature and communication science over hundreds of years that communication is something we can learn, right? So we're not born as communicators. We are, we were brought into the world. We learn communication from the people around us, role models and so forth. So we all have communication deficiencies, of course, but we all can learn. And the thing with the SAKYA is that we can focus on what skills are deficient that are causing harm, right? Because we communicate all the time for different purposes, and communication can be effective or ineffective for different purposes. If I want to compliment your dress today, I could use, if I find it ugly, I could use polite communication, say, you look beautiful today. That's lying. That's not accurate communication. It's not clear, but it serves the purpose of me maintaining my relationship with you, right? So communication is very complex. We have multiple functions that we communicate for. When we talk about safe communication, the function of the communication is safety. So to attain that safety, the SAKYA things are the 5 things that are happening causing harm. So we need to fix very precisely those things that are causing harm all over and over and over again. So this is why we don't need to say, well, of course, everybody communicates differently, but everybody can learn those skills, has to learn those skills. And this to me is why we're here today. If we talk about safety, it's a dedication to your profession. We're here today because we have a responsibility to provide safe care. It's not something we do as a nice to have. So focusing on those 5 skills in particular, I have zero doubt, and I've given a lot of talks like this, teaching workshops, having a rescue video show. People end up coding out of an audience just like this with 100% accuracy, the Sakya problems after a 20-minute talk. So we're not talking about rocket science here. We're talking about something we already know. It's just about focusing our attention precisely in what needs to be fixed, what the problems are that are causing harm that need to be fixed. So to me, I don't know if I answer your question, I hope, but I know there's differences in personality.
I know.
Yeah.
I know the time but to be honest, rocket science is much easier than it's less complicated than healthcare. Healthcare is a complex system, and the problem is, I think, in my opinion, that we are limping. We creating these acronyms, but we're limping because we are eliminating. We're not really investing on the differences in personality. We only concentrate on the system per se, and trying to actually fix and force everybody to be actually in line with what we actually create for them. Anyway, thank you very much.
Thank you. Yes, okay.
Thank you for this interesting presentation, ma'am. My question is, actually, I face a lot of problem with the communication. I'm working in Saudi Arabia in the ER department. So my question is, there is some limitation for sure for the communication. For example, we can talk about the language, even the accent. Sometimes if we are talking Arabic or we are talking English, both of us, but still there is some, maybe the accent is different. So for example, since if I am getting order from the doctor, who is, for example, who is Saudi, and I'm Tunisian, we are not talking the same accent. So his accent is different than mine. So I might understand a different medication order. So, and this happened. So I need to use, for example, the closed loop communication to make sure about the order that he gave. Maybe he has different accent and I didn't understand if it is epinephrine nor epinephrine what he's saying, the order. Or otherwise, there is a lot of patients, other nationalities, who don't talk even Arabic or English. So we are getting a problem to understand even the chief complaint that they are coming to our ER with. So even I think here in this case, the verbal or even the non-verbal, it's not enough that I want to understand, for example, the pain scale of the patient, what he is in need, if he have even insurance or no, what is his name, all his details, even the history that he's coming with. So we are facing this problem in the ER department. So what are your recommendations for that? Thank you.
Good point. I live in a country where we speak 5 languages and each of them have multiple accents. So, and then we have, all the countries bordering where we do the rescues internationally. So I'm very familiar with that problem. So for me, it goes back to where's the red flag situation? And Jesus named it, right? So recognizing the red flag situation to make sure that's where communication can cause harm. So we're going to make sure we use safe communication in that moment. So if you want to call it closed loop communication, for me, closed loop is again just the structuration. It means we need to close the loop. But did we attain a shared understanding? That's the question. That's the question. Closed loop doesn't mean shared understanding. It just means closing the loop. So see the red flag moment, bring in those safe communication skills to ensure a shared understanding. And I'm telling you, shared understanding is not something we can do as a checklist. It's in us. We know when we have a shared understanding with the person next to us, and it's the honesty and looking to that person's face and having the courage or the responsibility to make sure we don't leave this conversation until we are sure we have 100% of a shared understanding. We're overlapping those fields. So that's, let's not make communication too technical. We're making it very technical and calling things IPAS, SBAR. Our medical students don't know which acronym to use in what situation anymore. There's too many of them and that's too confusing. We need to go back to who we are as people. We've used our communication since the beginning of our time for safety. And so going back to that and taking the stress out, taking the technicality out, looking into, each other's eyes again and see, did we understand each other? So for me, the important thing is, where's the red flag moment? This is where we have to raise a flag and put the safe communication in to make sure this is where communication could be causing harm. but it's not because we're going to make sure it doesn't. That if we start there, we're going to prevent, I don't know, I'm not going to put a number to it, a lot of the harm that we're currently causing. Yes.
Yes, morning. Thank you. So, just two particular comments. Firstly, is I know you're in the Middle East. We all come from different cultures, different backgrounds. We speak very many different languages. So, in our facility, it's important to have a policy that there are certain languages that are spoken. There can be a lot of misinterpretation when people are speaking, particularly around a patient bedside. Making sure that there is a common language that is spoken around the patient, that there's a shared understanding of what the procedure needs to take place with regards to a particular patient. So for us, it's really Arabic and English, and those are the only two languages that are allowed or spoken with regards to patient care. My second comment was yesterday I conducted a talk on peer support, which involves plenty of communication. And it is very interesting with in stroke rehabilitation, patients have a shared understanding of their experience. So they kind of operate on that same level, correct? There's no hierarchical relationship, there's no expert versus non-expert, but in that sense, there is that shared understanding of their experience. And people can come from different backgrounds, different cultures, but because they have had that shared experience, they're able to communicate their emotions, their feelings of hopelessness or sense of that they've lost control of the situation. But in that context, it's amazing to see how people can communicate their experiences in those ways. So that's really the two comments there. Thank you so much.
Thank you. And just really briefly, I was a stroke patient at age 39. So I walked through, and that's one of the stories I was going to share with you today. Maybe just a very brief, I have to do it because it's a nursing story. The story time I wanted to bring in is the power of nursing and patient safety. And the one experience I've had is being a stroke patient in the stroke unit, lying next to a construction worker that I spoke the same language with, although I would have probably never met that person unless it would have been in that room, because it's the shared fears. In that moment, we're all back on the same denominator of being human. And it doesn't matter what language you speak. It's the shared fear that you have at the end of life, where you think, when is that thrombus is going to start loosening itself up? We woke up in bloodbaths in the morning, and there was no dignity left. There was no dignity left, but there was full humanity. And so in that moment, he had visitors coming in. I was 2.5 hours away from my kids, didn't know if I'd ever see them again, didn't get a chance to share those lessons with them and what they need to know to keep each other safe, because work was just too encompassing. So into the 7th day, weekends are worse because you're just kind of left alone. Nobody cares for you, don't have anybody to talk to. The nurse brought a coffee because I have low blood pressure all the time, so the opposite of what I should be having for a stroke. So they bring me coffee all the time. So she brought me this cold brewed coffee, and I just said it, kind of whispering, "Oh man, what would I give for a cappuccino?" It's like after 7 days of cold coffee and dry bread, you're just kind of losing life in you. And she left, and after about 10 minutes, the person next to me was gone, the construction worker. She peeked in. She said, "Mrs. Hanawa, don't tell anybody." And she snuck in. She unplugged me from all these cords and cables, which you're like kind of in jail, right? And she said, "We're going to get you a cappuccino." And she took me down that hallway towards those double doors at the end, which I thought I would never trespass again. And we went through them into the elevator, and she took me downstairs. And once those elevator doors opened, there were people dressed, walking around with nice clothes. There was this door that led out to nature, which I didn't think I'd ever go out and breathe air again. And next to that was a cafeteria. And she brought me up to the cafeteria, and she said to the woman at the counter, "A cappuccino for my patient, please." And she said, "Would you like a cookie with that?" And I said, "Sure." And she said, "Well, here are 2. So she brought me back upstairs into my room. I had to drink the cappuccino upstairs, and I drank the cappuccino. And that nurse, she didn't have to say a word. We didn't communicate a word. What she had done is give me a will of life back, a sense of hope, and a small sensation of happiness, which in that moment, no medication could have done. No medication could have done. And that's the power of nursing. So if you look at the medical effects that gesture of that woman who actually broke the laws, what that power of nursing is, when we reactivate the humanity in us and get away from the technicalities of things, that's where we save patients' lives. And that's what I've seen it in the rescue scenarios, reading through those cases, that's when we save lives. And that's when being human becomes supernatural, is when we reactivate that thing between us. And that's why I'm here talking about this, because it's a very important profession. So I'm sorry, I know we're going way over time. Thank you. Questions? Okay, thank you.
Thank you so much. Our next speaker is Dr. Essam Hamid Amin Ali from UAE. I'm passing the stage to him to deliver his speech on patient safety culture.
Good morning, everyone. My name is Dr. Essam. Today I will speak about patient safety culture. Actually, we have to have to know that when I was working for GCI, and it's required to have this survey, we give the staff before the staff satisfaction survey. After a few days, we give them another survey. So the staff confuses. You give us survey for satisfaction. And what is this now? We want to measure the safety culture in the hospital. Okay, we're working for GCI and we have patient safety goals. And for each goals, we have KPI. And for each KPI, we have collecting data and making analysis. And we measure up to what level in the hospital we reach to patient safety. Okay. I told them, we not measure by this survey up to what level we reach to a patient safety, but we want to measure the culture for the staff, the culture of patient safety. How you understand, what is the concept with the staff for patient safety? So I start to going around in all sections, in all departments, and to start orient the staff what we want from this survey. What is the meaning of patient safety? To have culture in the hospital to can reach to the point that every staff and each staff in the hospital aware how to implement the standard to save the patient. So actually this presentation, it's two parts. I make it in one presentation and I summarize in 80 slides only. Okay. So to measure patient safety culture from the perspective of staff can provide insight that leads to improvement in care. This is what we say. Each staff has to be aware and oriented what is the patient safety to can reach to improve our patient care. Okay. If we want to define the patient safety culture, first, we have to know that it's 3 levels. First one from organizational culture, second one from safety culture, third one to reach to patient safety culture. So first, the organizational culture. Organizational culture, it's a start from the leadership. till the junior staff in the hospital. So I want to go through fast. It's a set of values, expectation, formal and informal practice, and behaviors that define the unique corporate environment. Culture is deeply ingredient in the fabric of organizational life. It determines how the organizational conduct its business, treats its employees, evaluate its leaders, service its customer, and handles productivity and performance. And a common interpretation of culture is the way things are done around here. So let's start, as I say, from the leadership. How they evaluate the situation, how they understand, how they treat the staff. We want to speak now for the patient. We speak about the staff, how they deal with the staff. Does they recognize the staff work? Does they can treat the staff when they have something good, or how they deal with them when they have something bad? Because there is one question in the survey for the staff. If he has any problem, if he has mistake, how the organization or how his leader or his manager or how his supervisor deal with him. Does he still thinking and afraid and he has fear from this mistake and that it will not forgiven or what? Okay. From safety culture. Safety culture, we speak about safety, about the standards for safety, like health and safety standards. So we have procedures, we have standards, we have implement these standards, we have policies, we have procedures, and the staff know these policies and know these procedures, and they implement all this one. And as I say from beginning, we have for each standard, we have KPI and we're collecting that and blah, blah, blah. And we measure up to what level we implement this standard. So this is the point that we have to know that these standards for safety, it must link in our mind with the main objective for the patient safety, that we're not doing only this one for our safety. No, we have to aware that we have to implement these standards to reach to keep the patient safe. Patient safety culture, it's focused on the aspect of organizational culture that related to patient safety. It's defined as a pattern of individuals and organizational behavior based upon shared belief and values that continuously seeks to minimize patient harm. This is the point which we have to reach. And in the end, we will see, does we reach or does we success as a hospital to reach to this point or not? Which may result from the process of care delivery. Positive patient safety culture. Positive patient safety culture have a strong leadership that drives and prioritize safety, communication, commitment from leaders and managers is key. Their actions and attitudes influence the perceptions, attitudes, and behavior of the wider workforce. So the attitude of the managers with the staff, it's very important. Does they communicate with them? And now we have long lecture for communication. Does they communicate with them? Does they speak with them? Does they understand what they need? Does they solve their problem? Because if that staff under pressure, he cannot work. And he will forget everything, even for his safety, not only the patient safety. So he will not focus in his work. He will not focus for anything. So it will reflect negatively for him, for his work, for his safety, and for the patient safety. So the communication between the manager or the leaders and the staff, it's very, very important. How they deal with them, how they solve their problem, it's very important. Okay, positive patient safety culture. Other important aspect of positive patient safety culture, shared perceptions of the importance of safety. As we say, that there is a lot of standards for safety we have to implement it for health and safety, for a lot of standards for GCI, for infection control. So all these standards, it must be a perception for the staff that they have to implement it, not only mandatory for the required for the accreditation body or for the government authority. No, for your safety and for patient safety. Constructive communication. We speak about this too much. Mutual trust. This is very important. I have to trust my staff. To can my staff trusting me. When I tell them to do something, they have to have trust to do it. If they have this, any discussion or they want to discuss or communicate or to understand, they have to come to me to ask me. So they will trust that there will not be conflict, there will not be problem. So mutual of trust between the staff, it's very, very important. When I tell him this one, it happened like this, yes, halas, it's finished, it's happened like this. And when he tell me that this one, it's going like this, yes. So the trust or mutual of trust between the staff, it's very important. A workforce that is engaged and always aware that things can go wrong. There is nothing standard. So when we do something, we have to understand that maybe, yes, something going wrong. Maybe some mistake will happen. It's not the end of the world if something happened or if some mistake happened. When we work, while we work, we have to understand that, yes, there is something maybe happen, but we have to be aware and we have to be ready. There was one before, he's a owner for the hospital. He will say one word that's very nice. He say, if somebody coming and say that this is tough, he not have any mistake, any wrong, for me, it's meaning that this is stuff not working. Anybody work, it's okay. Yes, but our work, our job to minimize this mistake or these errors. But if we say that this is stuff not have any mistake, I'm sorry, it's meaning he's sleeping, he's not working. Acknowledgement of all, at all that mistakes occur, ability to recognize, respond, to give feedback about and learn from adverse events. We have to learn from the mistake. And this is an improvement, and this is a quality, BDCA cycle. We have to know what happened, we have to know why this mistake happened, we have to make investigation, and we have to correct and to go on to improve to not happen next time. When things go wrong, patient safety inquiries provides insights into the potentiality catastrophic impact of dysfunctional workplace culture on patient care. A review of inquiries identified the following common deficits. Limitation in the standards of clinical governance. Sure, to improve the workplace or to improve our work or to improve our performance or to improve our care for patient, we have to implement the standards. First lecture, it was very nice about surgical error or surgical side problems. That the problem or the main problem at this time, when he speak about, there is no standard they implement. And when they go only to one organization or World Health Organization, WHO. And WHO, it's not enough, especially that when they make standards, they make it separate, and we have to understand and to connect and to link all the checklist for the WHO. But they didn't go to the main standards, the proper standards, to avoid all this problem or all this mistake. So we have to implement the standards which is fit and required, not only to have standards and to implement, to have certificates to put in the world. No. What we need as an organization, it's regarding to our specialty. We are hospital, we are medical center, we are one-day surgery. And which specialty you have in this hospital? Maybe you are oncology, maybe you have only general surgery, maybe you have OB-GYN, pediatric. So we have to see which standard we need to can start implement. The more standards, which is improve and develop our work and our performance, the more improvement of patient care. Already I 15 minutes. Okay. Okay. Measuring patient safety culture, measuring of patient safety culture enables the identification of strengths and area for improvement. This is what we say. We measure the patient safety culture to improve our performance, our patient care. This information can be used to develop appropriate intervention patient safety. Culture measures can also be used to evaluate new safety programs by comparing results before and after the survey. Patient safety culture can be measured through surveys of hospital staff or qualitative measurement focus group. So we can measure the patient safety culture by survey or focus group interview for each group, but it takes time and it takes a lot of time from the work. So we're going to most of the hospital going to the survey just to save time. Survey for hospital staff are the most common way to measure patient safety culture. Measure patient safety culture. Patient safety culture forms one component of a comprehensive measurement. This is a form which we use. It's content about 8 category. This survey, it was electronically in the network for the hospital, and we announce for all the staff to start fill this one independently. And if any point in the survey he not understand or he didn't like to answer, okay, leave it blank. If you don't want fill this survey, okay, it's okay. But if we leave it like this, it was be terrible because less staff will go for the surveys. For this, I say, as I make from beginning, I make orientation. By this lecture, I make orientation to explain to the staff what is the patient safety culture, what we measure, for them to understand what is this survey and why it's important and why everyone must fill it. Actually, the total for the staff for the hospital it was 349, around 307 filled this survey. Percentage was 87.9% for the patient. Mainly, this is the category for the staff. Mainly, it was for, or the high percent, it was for the nurses, and then the doctor and the admin. And the admin, which is direct contact with the patient, like reception, like admission office. Overall satisfaction for this survey, it was 88.7%. Section 8 was for work area. Here we asking, here's a question and it's long, so I just going fast also for the time. What's your primary work area here? Identification for the staff to his work area. And as we see, mainly it was nurses which participate in this one. Here, please indicate your agreement or disagree for this sentence. people support one another in this unit. So it was around 63 disagree and 25 approximately agree. So total around the total it's 88, which is a final result also for the this survey. We have enough staff to handle the workload. Also, there is agree by 64, and the other department they have shortage of staff. So everyone say his opinion. But anyway, let's go through first section. It's for identification for the work area and the staff if cooperating together or it's enough to handle, and if somebody need to support as a teamwork, does it can go to the other department or not, and also if we accept the staff from other department or other section or other hospital to come to helping us. Also, this one of the question. Section B, it was supervisor manager. My supervisor manager say a good word when he or she sees a job done according to established patient safety procedures. And this result 73%, it's indicate one very important point, that the supervisor or the manager was helping the staff to fill the survey. For this, it's coming 73. My supervisor or managers seriously consider staff suggestion for improving patient safety. Yes, it's also high percentage. Whenever pressure built up by supervisor or manager want us to work faster, even if means taking shortcut. It was also little confused between the staff. Everyone say a different perspective. Okay. Section C is a communication. We have presentation for communication, and this is a result. By the way, this presentation, it will be available, I think, the conference organizers can send to anyone need, and it's welcome. If they not send, just communicate with me, I will send it to you. So for the time, let's go. Section A, patient safety grade. The staff measuring or say their opinion for grade. The hospital, about the hospital as a general. But okay, this is the result. Let's go to the most important section. Here the number of events reported. This is the last one, and just can I take 3 minutes? 3. Please feel free to write any comments about patient safety error or event reporting in this hospital, in your hospital. There is a lot of things, everyone say something, but the success for this survey, some 3 or 4 opinions for the staff, which here, patient would be safe in our hospital. This is it summarized. All what I want to say, that I success to reach to the point that the staff start be aware, start fully understand that it's important for our patient when coming to our hospital to be safe. So it's very simple. He feeds a survey and his comment that he assured, he confirmed, he promised, not only he, it's also there is some another case like hospital very keen in patient safety. This also showing up to what level the staff start fully understand what is the meaning of patient safety. So it's coming as a culture for them. It's coming as a promises from them to keep the patient safe in our hospital. Thank you. This is my email. If anyone wants the presentation, I can send and I can share with you. My telephone also, if any question, because I think you not give. Thank you.
Sorry. Ladies and gentlemen, she will introduce you.
Ladies and gentlemen, I'm sorry, I'm neglecting my duties and I've lost some time. So if you'd like to get a cup of coffee and come back, we're gonna go ahead and start with our next presenter. Our next speaker is Dr. Nina Mahmood from UAE, and I'm passing the stage to her so that she can deliver her speech on science of healthcare delivery in MENA region, optimizing care delivery, current and future challenges.
Yeah, I need this. Yeah. Thank you so much for the introduction. So we're gonna have like a small coffee break or after? After. Yes, okay. Yes. Yeah, hello, good morning, everybody. Very happy to be with you at the 12th International Conference, Nursing, Healthcare, and Patient Safety. First of all, I want to introduce myself first. My name is Bin Mahmoud. I'm a general practitioner based in Abu Dhabi, and I'm a master holder of Science of Healthcare Delivery as well. I want today to talk about, let's start first. Healthcare is very complex, okay? And it's a huge puzzle. I want to ask all of you, I want it to be, first of all, interactive presentation, okay? So I want to encourage everybody to just participate with me. So what do you think the most important part of our puzzle in the healthcare? If it's not present, it doesn't mean that we're not working. So anybody can respond? Yes, patient involvement. Okay, any other response? Okay, so the puzzle of the healthcare is about our patients. So if our patients is not present, it means we are not working in our healthcare system. Okay, so we want to talk about healthcare delivery, but first of all, I will give you like a glimpse about story. Just a little bit hectic. Last week, my mother was admitted for coronary angiography in Egypt, okay? And it's a small procedure, or we can say a fast procedure, and after that it will be discharged in the same day. That she developed a high mortality and morbidity complication, which is internal ritual peritoneal. And then she spent it, rather than discharging in the same day, she spent 9 to 11 days in the CCU. And after that, she was facing some struggles as regards her care delivery. Because she, after the surgery, the patients can develop, because she entered, because of the bleeding, into a vascular open surgery. And because of that, that the open wound in the abdomen, there is a lot of factors that can affect the lung capacity after that. And her lung capacity actually was affected, and she needed a high flow oxygen and all of those but thank God that this is the only issue she encountered. But thinking back to what happened to her, we have to think about delivering the healthcare delivery in a proper way, and that those events can be preventable. But how we can prevent it is what we are talking about, which is the science of healthcare delivery or the healthcare delivery. And I will tell you why we can call it science, okay? So my agenda of today, we're gonna talk about the concept of the science of healthcare delivery, okay? Number two, we're gonna talk about the MENA region, healthcare delivery. Like we're gonna have like small glimpse about that. And then we're gonna talk about how to optimize the care delivery as well. And to talk about the current challenges and the future opportunities. Okay, before this. Yeah, okay. I want to ask all of you, before talking about how to optimize the healthcare delivery and our healthcare services, let's go into the macro picture of our healthcare systems. What are the components of our healthcare systems? Can anybody start to answer that? What the component of our healthcare delivery? What encompasses the healthcare delivery system we have? The treating team. Sorry? Softwares. Okay, what else? Resources. Evidence-based practice. Okay, what else? Infrastructure. Core values. But what are the main components? Like to have a system. Okay, healthcare professionals. What else? Teamwork. Okay, what else? Okay, so let's talk about the components. The components of the healthcare system encompass many stakeholders. Okay, we have the stakeholders, which can be policymakers, which can be different workforce, encompasses our, for example, different healthcare professional teams, doctor, nurses, any other professionals that they play a role in our healthcare system. And then we have the governments, the rules, policies, the regulations, all of those encounter into our healthcare system. And then we have the health information system. It's very important. Although there are some healthcare system that doesn't have the health information technology, and they are only paper-based until now, okay? And we have the access to medication, the finance, so all of those encounter our healthcare system delivery. And it's very important for us to have a glimpse about that, because if we are practicing on the macro level, okay, we cannot understand what's happening on a macro level without referring to how our healthcare system is delivering. Okay. Now, before talking about this, why we can say science of healthcare delivery? The concept of science of healthcare delivery, because we want to study the different interrelated facets of the healthcare delivery to be able to optimize our care, to be able to present certain services to our care. So why we call it science? Because there was a concept behind that we need to study different fields, okay? We need to have a different understanding of the different factors that play a key role in our healthcare system, because we cannot depend on one thing. Have a healthcare system. We cannot depend on the workforce alone. We cannot depend on the policies. Who will run the policies? Who will put the policies? Okay. We cannot depend on the health information system and the information exchange, the data of the patient, who's gonna use the data, and so on. Okay. So here comes the science of healthcare delivery, which is a field of study that study different fields, okay? Because at the end, we want to enhance the patient safety, we want to improve the quality, and we want to decrease the cost, which are the triple aim of the science of healthcare delivery. And as we see here in our diagram, that the core of our work is the patients. And then we have the care teams, the different healthcare professionals, where we can say that they are the frontliners, and then we have the organizations, the infrastructure for that, and then we have on the macro level the environment, the public health. Okay, we have the preventive medicine, and we have the policies, the markets, regulations, the insurance as well. So talking about the MENA region, that after the COVID, that all of the healthcare system seems non-prepared, okay? And it was very obvious. Even the most developing countries they were facing a lot of challenges. So talking about MENA region, we can classify them into low income, middle income, and high income countries. Okay. So for example, low income countries, that countries are really have a poor healthcare systems. Okay. And they cannot face such challenges like the COVID, okay? And then we have the middle income countries where most of the reforms now are occurring. For example, we have Egypt, Jordan, okay? So we have different Tunisia, and we have some countries who are really, we can say, out of the reforms now because of the many environmental, political issues. They have wars and so on. So all of those are affecting the healthcare system and the atmosphere. And then we have the high income countries like Saudi Arabia, like United Arab Emirates, and the GCC. We can see the GCC countries. Actually, we can say that the high income countries, they are depending on their infrastructure. They have good infrastructure. They are utilizing the health information technology, and this can accelerate any change about that. Okay, and then they are, we can say, different countries, they have different models of the healthcare system. Like if we are talking about who will pay for healthcare system, so for GCC, they have like, we can say combined models, okay? Combined models between we can say collaboration between the private sectors and the public sectors to be able to fund the patients, okay? So this is like a glimpse about our healthcare system. So it's very important for us to be able to understand this. And then we're gonna talk about how to optimize healthcare delivery and tertiary hospital in acute setting, okay? Because this is my practice where we can draw some lessons into and apply to different settings. So here is a diagram. We can talk about the journey of our patients from the start, okay, from the awareness, where we can talk about preventive medicine, community medicine, like, and this is very important, this is the primary care level, okay, that most of countries doesn't emphasize on this. And this needs to be emphasized later on. I will talk about it in the later slides. And then consideration, access, the gatekeepers, where we have like the primary care services, where some countries are having some great efforts. For example, UAE, and especially in Abu Dhabi, they're starting to focus about the primary care services, and especially in the specialties as regards mental health, okay? And then we have the service delivery, so in the settings, okay? So I want to ask you, what are the current challenges do you think we are facing as a healthcare professionals in our systems? What are the challenges we have? Okay, lack of finance errors, system errors. Yes, lack of access to care. Yeah, access to care, for example, in low, middle, low or middle income countries, and integration in the healthcare system. Okay, so some of the challenges we have actually, and it was very obvious after the COVID, is the healthcare system preparedness. Are we prepared for such challenges or not? Our healthcare system started to expose to different challenges like the COVID, and it started to emphasize on what shortage we have. And then we have the current system, like even the most developing, they faced a lot of problems. Okay, so this draws us to what we can do, and this is what we have to do in the post-COVID era. Okay, and then we have the burden of the chronic disease management. Okay, so because it's a double burden, especially in countries like low-income countries, they have a burden of the non-communicable disease, which is the chronic and the communicable disease, the infectious disease as well. But also, most of the countries have the chronic disease management problems because there is a rise, there's a strike about the chronic disease. For example, can you think about what we have about chronic disease, the strike of those diseases? Diabetes, okay. Cardiovascular, yeah, COPD, respiratory systems, sorry, cancer, yes. So, and then we're gonna move to the preventive medicine, that most of the healthcare system doesn't focus on that, because we are working in just a very limited level of healthcare, that we are working on disease management. We don't focus on before disease, maintaining the health, checking for disease, preventing the disease, and so on. So this is like a glimpse of what we can do to improve and to optimize our care delivery. And then we have the mental health crisis, which is what were very obvious during COVID, okay? And it hit everybody, from the normal people up to the health professional workers. Okay. So there is a diagram. This is like a chart about like the current journey for our patients in acute setting, starting from the admitting the patient, either a direct admission or a referral, for example, from different facilities. And then we have the care delivery, the care design, how we can design the care to be delivered in a proper way, and the continuity of care, especially if we are talking about referral of patients from different facilities, for example, long-term and so on, because this is really a problem, how we can continue the care the same and so on. And this is really encompassed a very challenging, and it was very challenging for us and internal medicine and during the COVID, because we want to maintain the same quality of care and we want to care for the patients if they are infected with COVID as well. And then we have the care management if we have complex disease cases, okay? And then we have the discharge phase, okay, if we are discharging the patient. And this is also provide like a chance we can improve the care, because this was happening during the COVID, because during the COVID, everyone is pressured, okay? And so there was like some teams in our hospitals. I was working in Sheikh Khalifa Hospital, internal medicine. I worked in different facilities during the COVID, but my work was in internal medicine. So how we can make the turnover very fast, because all the hospitals have a full capacity. So this like some areas of improvement we can do. And then we have the recovery and rehabilitation. And this is very important because after the discharge, what about the follow-up if the patient is okay? So we'll have to follow up in the outpatient or the recovery and rehabilitation, which will have another speaker also talking about this. Okay, so how we can optimize our care? Like there is two levels to optimize the care. We can optimize our care delivery on the macro level, the healthcare system, and we can optimize the care in the setting itself. So we have a horizontal and we have a vertical. If we are talking about, for example, let's say vertical, what we can do to improve our care delivery? Improve leadership. Leadership. Okay. What else? Decentralized. Okay. And rather than being centralized to a certain regulation. What else? What do you think? Central access to the system. Okay, yeah. Any other answers? Okay. So I think these are good answers and they are related more to the macro level, which is the healthcare systems. Okay. If I'm talking about optimizing the care delivery in the setting itself, okay, the vertical, we are talking about communications, and it's very important, okay? And communication we can play in the macro level, communication between different categories of healthcare, communication between private, public, between government, between the schools, for example, between research centers, how we can communicate all of those together. And this was very obvious during the COVID, especially in UAE, because of the health information system, okay? So we can integrate the files of the patients, transition from a care to another, okay? So how we can communicate this without a health information system, okay? So this is what's very important. Another way of care communication is care communication inside the hospitals. If we have a multidisciplinary teamwork, how we are communicating that, how we can improve our communication with different teams. Because if we have, for example, complex cases, like there's multiple teams, they are managing the case, how we can ensure a proper communication between them. So there was some, how in our practice, some improvements about this and some efforts. For example, in the electronic health system, we can put like, for example, order that you have to consult, for example, if you need a subspecialty, so you have to request a consultation. But this is enough or not, because you can do this, and you cannot consult the actual physician, okay? So there's some improvements about that, but what we need is to implement it on the real action. And then we have transition of care. Transition of care also, we can play it on the macro level and the micro level. The macro level transition of care, for example, from ambulatory outpatients to the acute setting to the rehabilitation. So how we can have a smooth transition So this is will be happening by having accurate regulations and policies to regulate the transition between different healthcare systems, okay? And then to ensure the smooth transition and exchange of the patient's data, okay? And transition also in the care itself. For example, if we have a tertiary hospital, how we can downgrade the care delivery. If the patient in high dependency ICU, how we can downgrade to regular bed or to monitor bed, and how we can ensure the smooth transition. This would happen by having equality improvements about the care coordination. So case management and care coordination, these are very important because without those, we cannot work. Like everybody will work in isolated island, and we will not able to have a continuity of care. Okay, so this will happen by quality metrics that doesn't only focus on the standards, but how we really can coordinate the care between different teams and how we can coordinate like we can on a macro level. So for example, during COVID in Abu Dhabi Emirates, we have like a command center which can coordinate all the care and the transition of the patients in between different facilities, because we had like many organizations. For example, we have a field hospitals, we have an institutional organization for isolation, and we have the tertiary hospitals, and we have also outpatient. We can, for example, have the screening of the patients. So how we can coordinate this? For example, they can centralize the coordination through, for example, having a command center. And then we have some ethical considerations and lowering the cost. But I will jump to the, because of the time, I'll jump to lessons learned during COVID. Okay, during the COVID, actually, Abu Dhabi was one of the first countries all around the world to be fast responding to COVID. And what happened because of what they did in the Emirates. So we have a capacity building because we have faced a lot of problems during the COVID, and it was very obvious that we need everybody to stand for the COVID and to be front. So there was a shortage. So they started to pull out the workforce, okay, from everybody. And they started to pull the workforce from the country itself or from outside. And then we have the upscaling workforce. And this was discussed yesterday also about the continuous professional education. And this is especially if we have a crisis like COVID, how we can teach those people, how we can, for example, bring ophthalmologists to work and COVID work to work and internal medicine work. So they were introducing like an online digital platform to upskill the skills of the healthcare workforce, where they can access those educational content after the work. Okay, and we have the utilizing telehealth, of course, and mental health services was one of the specialties that can be used by the telehealth. And then we have the health technology, and it's were very obvious that, for example, they use Al-Hassan, which is a mobile application to show us the status of the person, if he's infected with COVID, if he's negative, if he is vaccinated or not. And we have the wearable devices. Those were given to people with, for example, if we want to isolate them in institutional organization for isolation. So those are important lessons we can emphasize and we can utilize in post-COVID era. For example, using the wearable device, we have now a smartwatch, if we are wearing any of them, and using the different app technology to optimize our care delivery. And then we have the public health and the media importance about it. Okay, so what are the future opportunities? Drawing back to the challenges or the lessons drawing from the COVID, the growth of the telehealth and the artificial intelligence, and then we have the post-pandemic era, and then we have emerging markets. For example, the middle income countries, where they have a lot of opportunities, a lot of startups, a lot of ideas, initiatives that can be implemented in such countries. For example, Egypt, Tunisia, Jordan, and so on. And then we have the young workforce, because we all know that the med school, the nursing school, there's a huge number of graduates every year. But where are they going? And we have the problem of the brain drain. So if we can get benefit from those graduates, really, we can improve our healthcare system. And then we have a healthcare atmosphere. So now we are in baseline, back to baseline. So what we can do in post-COVID era. So let's flip the game. How we can flip the game? So we can flip the game by different points. building the leadership capacity. Like I can emphasize and recommend for every healthcare worker, if they are supervisor, any seniority level, and any managerial level. And this was a talk also from Dr. Ahmed yesterday about quality sustainability. But I'm not talking about sustainability. I'm talking about continuity and building capacity. Because every leader, your role is not leading today, but your role will extend after you move from your role. So your role today is not just to lead, but also to prepare the next leader behind you. Okay, so building capacity is very important. And then we have preventive medicine and public health. And those are very important in our healthcare systems. And unfortunately, like not all the countries have a focus about that. And if we have some efforts, they are isolated. So we need to integrate this in our healthcare system to be able to prevent the disease and to be able to provide sustainability for our care. And then building alliance in healthcare, yes. Building alliance in healthcare, a different collaboration and partnership between different different stakeholders, the private, the public, and the government. Okay. So I want to introduce this because this was a model of education in my clinic in US, and it was introduced in 2013 because they faced that the US, even the US, the most developing country around the world, they're facing a lot of problems in their healthcare system. So they think, okay, what we can do is try to train the next generation, for example, and they introduced like this model of education between my clinic and Arizona State University, which encounter like incorporating like the curriculum and the medical school, which are 4 years, and they started to move on to different colleges. For example, Arizona State University was one of them. I'm a graduate of that. They started to implement the science of healthcare delivery for undergraduates alone as a solid program and as a master, and which encompasses many different subjects. For example, they teach leadership because it's very important, and they teach team-based care, and they teach politics, healthcare policies, economics, technology, health information technology, how you can utilize that, population-centered care. So at the end, this is like a model we can use because this is our aim, integration of healthcare system, how we can integrate, because some countries, they have the multiple components of the healthcare system, but they are working in an isolated way. So we have the extended care, which encompasses the rehabilitation, we have the acute care setting, which our focus mainly is about this. And then we have the ambulatory care, which is the outpatient, and our improvements in the primary care settings, because we are the gatekeepers if we are talking about primary care. And then we have the community health, the public health initiatives, where we can prevent the disease, where we can promote health awareness, where we can educate the people, because really the health disparity we have is really challenging for us. And even it was very obvious during the COVID, because the people were hesitant about taking the vaccine, for example. They don't understand, they don't trust, okay? So building those information and building those bases is very important for us. And this will conclude my presentation. So a call of action. And this is a question for everybody. What do you do in your care or in your organization to improve the care delivery, although on a macro level or in a micro level? Okay, so this is the end of my talk. I hope you get benefit from this, and I'm welcoming to any questions and any comments about that. Thank you so much for your attention.
Thank you, very, very informative for me. I have 2 points. First one, during COVID, all of us know the importance of healthcare provider. So I think we need to invest in human resource more than resources. The human resource and sectors, nurses, because during COVID, Gulf region, they contract in nurses for 3 months without orientation, just bring them and put with patients. And this is the first challenges for patient safety. because in emergency situation, this contract just for 3 months. Which education, training, policy, country, I don't know, but this is the real. So we need to invest, if we can, to doing polling for healthcare provider to be ready as emergency situation. The policymaker need to put policy in this situation, what to do, not just on the point. The second one, I think, this is complex system. We need to focus more and more to integrated system. Mainly, we need to focus in primary health PHCs, primary healthcare center, because during COVID and till now, all the country focus on the hospital. If we manage it from the beginning, from the PHC, I think it will solve the problem more and more. Thank you.
Yeah, thank you for your comments. Yeah, I really agree with you. There was some, because I worked in multiple settings during the COVID, I agree with you that short-term contracts, we faced a lot of like shortage from the healthcare workers, and those short terms really play a role into hindering the safety of the patients because they are not trained, and especially if we have like different even about physicians. They bring a different physician. They are not working with patient care or acute care or medicine, but they started to, they have a lot of efforts, as I mentioned, about the online platforms which can optimize the learning during such pandemics. And what about after the sustainability or after, which will be encompass our work, that we need to prepare our healthcare workforce. And Abu Dhabi also launched the platform for the healthcare workers where they can find a job and so on. But the problem would be, are we able to face such a challenge now or not? And this is will be our main is because I feel that we are focusing on individual efforts, like everybody have to complete their continuous professional development credits because of the licensing issues and so on, because this is the reality. But what about having a centralized body which will focus about the training and preparing those workforce? And for the second point about the complexity, yes, we need integration. And yes, this is what I said about the preventive and public health, because our healthcare systems are focused on the tertiary and the secondary. Okay, so if we try to move, and this is like also like there's a models where we are talking about value-based medicine, and value-based medicine will try to shift the focus to the primary care, but it's about policy, it's about funding and so on, and that will take some time. And there are some actually institutions in US, they started to have like some models of care which will focus on the primary care and so on. But if we can talk those models and try to implement it, because otherwise if it doesn't come from the policymakers, it will be a challenging for us. So there is some countries, and here in UAE, they started to focus about and having importance or gaining some insight about the importance of the primary care delivery as well. So any comments? So thank you.
Regarding what you said, that our focus will be in the primary healthcare center. Now, in our country, we have a lot of waiting list in the ER, and this will make the patient more eager, and they are complaining too much to the Minister of Health, the hotline. And now they are focusing on the primary care center, opening UCT, it's called urgent unit, urgent care unit, and many of our primary they developed this unit, and now they are working on it.
So yeah, this is a great initiative.
In the ER.
The waiting list. And I want to add to your point also the importance of classifying the patient.
Yeah.
And the ER, if we are, because sometimes the ER will be like we have an overflow, but if we classify the patients, we will find that there are some cold cases, and cold cases can go to the primary care centers or urgent care as well. And we try to focus the care into the people who are really in need of this. So any other comments or questions? Okay, that's it. Okay. Yeah, thank you so much for your understanding. Thank you.
And now I would like to introduce our next speaker, Dr. Sahar Mohamed. I had the opportunity to meet her last year at a conference in San Francisco, so I can feel free to call her my friend. She's going to speak to us today about rehabilitation. Who is the leader throughout the recovery process, and what do we need to know?
Okay. Good afternoon, or should I say good morning? Good morning. Okay, are you all still awake? You feel that you need an exercise now? Or I can start. What do you think? You want to stand and take a deep breathing? Should I start? Okay, thank you very much, Ms. Barbara, for the warm introduction. Okay, and I'm very happy to be here today to present my topic. And I noticed from yesterday and today, many of you mentioned already very important points that will be discussed today in my presentations. I hear some people talking about the rehabilitation, the care of patient after spinal cord injury or after stroke. Also, some of you are talking about communication, the role of the nurses, the hospital system, and communication. Really, I was very impressed about the topics yesterday and from today. I think there is something wrong with the mic. It's fine. Can I use this one? Yes. Okay, let's start. So I just want to ask you a question before I start. What do you know about rehabilitation? What is rehabilitation? I need feedback from you. What is rehabilitation? Yes. Continuation of care, right? Continuation of care. What else? Recovery. Yes, recovery. What else? Yes. What else? Part of physiotherapy, yes. So, rehabilitation is a Latin word, okay, which means restoration, regain, recovery, optimizing, maximizing best possible, okay, outcome after injury or a disorder, okay, and also you are taking your patient towards independence. Imagine that you have a patient who develops CVA after stroke. He used to be a patient who's walking, who's eating, doing everything by himself. Suddenly, he becomes disabled. So you have to take this patient back to his baseline. Okay, you have to give him the best outcome as you can. This is what I mean by maximizing, optimizing, taking your patient back to normal life as much as possible. Of course, this depends on the level of injury, about his background, his age, multiple comorbidities, and so many factors. But you have to bring the patient to the hospital and do your best to take him back to his life, to his normal life. Okay? So, do you think rehabilitation is physiotherapy? Physiotherapy? Is it like that? Okay, how many of you thought that rehabilitation is physiotherapy? How many of you? Honestly. Yeah, good. It's part of it. It's part of it. Okay, I want to ask you a question. Some of you have, for example, a father or a mother or a relative who's an elderly with, for example, osteoporosis or knee pain. There is definitely. Okay.
Yeah, I have my father, yeah. He's suffering from, he have a morbid obesity and he's suffering from knee pain. And actually, he have to go through a knee replacement surgery, yeah.
Before going to the total knee replacement, it was your father, right? Okay, he tried the conservative management before going to the surgery.
He tried the conservative management.
That's great. So I'm trying to say, rehabilitation, with rehabilitation, you have the chance, you have the choice to try the conservative management before going to the last stage of management. Like, for example, a patient with osteoporosis, he has to try conservative management before thinking or going to do bilateral total knee replacement. Another thing, if the patient is having osteoporosis, by the way, osteoporosis will not lead to pain by itself. Unless if there is associated injury or fracture, that's at this stage, this patient should go to the BMNR, to the outpatient rehabilitation clinic. Help. Okay.
I will define what is rehabilitation, how it is connected to physiotherapy, how physiotherapy is part of it while I'm giving this speech. Okay, rehabilitation is an active, time-limited collaboration of a person with disabilities and professionals, along with other relevant people to produce sustained reductions in the impact of disease and disability and improve quality of life. Intervention focus on the individual, on the physical or social environment, or both. Key aims of the service are to provide rehabilitation to patients with complex needs in order to assist them to achieve their maximum potential for physical, cognitive, social, and psychological function, and to be able to participate in the community and have a better quality of life. So, how can we divide the rehabilitation service? You can get the rehabilitation service as outpatient and also as inpatient. Okay, the inpatient service can be further divided to post-acute, long-term, outpatient, long-term, then outpatient service, then a home healthcare service. So, what are the range of disorders that will need the help or of the rehabilitations, ranging from trauma rehabilitation to cancer rehabilitation? Most commonly acquired brain injury like trauma, stroke, meningitis, encephalitis, post-surgical tumors, other long-term neurological conditions like cerebral palsy, multiple sclerosis, motor neuron disease, spinal cord injury, traumatic and non-traumatic, spina bifida, post-poliomyelitis, and other disorders. As inpatient, again, any kind of significant medical condition that would cause a significant change in function. Some of common ones, as what I said, stroke, spinal cord injuries, orthopedic injuries, brain and neurological injuries, and this orthopedic injury might be single injury or both multiple traumatic, like after a traffic accident. And also rehabilitation can help with the patient with chronic disease like cardiovascular diseases. If they will receive an adequate rehabilitation, this will improve the quality of their life. If the patient is having heart failure, it's not the end of it. The patient can still be involved better with exercise. With rehabilitation service, the patient can have less shortness of breath, less stress, and he will be active more and can be involved with his life and with his activities, and he can manage well with his work and be engaged well with his environment, right? What about that patient?
The outpatient cover a variety of broad spectrum of disease processes and complaint, mainly covering musculoskeletal disorders like hip pain, back pain, neck and knee pain, and sometimes headache. Yeah. Do you know that sometimes we can go to the outpatient clinic to ask for help for a patient who have vertigo? Did you know that? Yes. Some patients, they have benign positional vertigo, and they can make use of the vestibular exercise. Did you know that before? First time? Yes. And also can help you with managing your headache. But provided that before going to the rehab department, you will of course go to their primary provider, primary physician, who will try to help you with a primary medical treatment. You will take the pain management, you will take the medications, however, you have to go to the rehabilitation to have the exercise and to be able to cope with the disorder that you have. Yes, now, some of you mentioned about COVID already. Yes. Okay, you know that at the time of COVID outbreak, there was so many complications associated with COVID. And so many people, they suffered from respiratory problem. And now, post-COVID, they have problem with their breathing capacity. Yes, so many complications. And we know that it's a state of hypercoagulation. It's a very well-known complication of COVID. And as a sequence of that, we'll be having the complication of CVA, ischemic stroke, of course, as well as other complications, especially in the elderly population. So, after admitting the patient to the hospital, if you are talking about the inpatient, if you are talking about, for example, the post-acute rehabilitation, who should be the team involved to manage this patient? What is a member of the team? Yeah, let's read together. Physicians, nurses, therapists, lab technician, pharmacists, social worker, excellent. Okay, now a professional multidisciplinary team should manage this patient to take him to the best outcome, to best possible quality of life following the disorder or the trauma. We have the consultant who is a BMNR, who will be the one who leads the group, who diagnose, who decide to admit the patient based on his background. Then we have the rehabilitation nurses. I will talk further about the role of the nurse. So what do you think? What is the role of the nurse? Anyone can help? Interact. Care. What else? Surely. Yes. Coordination, monitoring the patient 24 hours, right? Help with his daily activities, help with his feeding, help with to apply the plan which has been decided by BMNR, the type of exercise, right? Really, the nurses are doing the major and a very great job with the patient at the level of the rehabilitation. And I'll give you more details about it. So we already talked about the nurse. Can I go back? How can I go back? Yeah, it's okay. Yes. Okay. Nurses, physiotherapists, occupational therapists, speech and language, the SLP, the neuropsychologist, the dietitian, also the discharge planning, everything, all these things should be involved to have the best outcome for the patient. So, did we miss any component? I think there is a missing member here. What is the missing? Yes. Excellent. By the way, the role of the family is very important in managing patient at the rehabilitation stage. But do you think the patient, I'll tell you and ask you a question. What if you have a patient, like for example, an elderly with confusion who doesn't want to do the exercise? How can you achieve and give the best experience and best recovery experience to this patient? How can we do that? Yes, the family can help. Okay, at the level of the healthcare, the treating team, what they can do to help this patient.
Have to discuss the plan even before pre-admission stage.
Yeah.
And to engage the family in the care, continuity of the care. It involves even the pre-plan and intra-plan and even post-plan. So they must be involved from the very first moment, and they must be discuss all the risk factors and all the caretaking, and they must be involved in the day-to-day activity of the patient care. Yeah.
Yes, yes, yes. You should involve family from the start, from day one. They have to know everything about the disability, the disorder. If say the patient is having, for example, stroke, they have to know everything about this problem. What is the anticipated time for recovery? What is the chance this patient might have another stroke? How we should control the risk factors? How can they help the patient with daily activities? Sometimes we ask the family to take the patient for exercising around the hospital at the time when they are able to start to walk. They are helping with that. Of course, we have our physiotherapists and they are doing the job. They are having certain hours, like they're having more, maybe 3 hours, 4 hours per day giving exercise. However, we most of the time encourage the family to take the patient in the evening to walk around with assistance, depends on the level of the patient. For example, he has to work with assistance or without assistance. What is the level of assistance he has to need? We have to explain everything. And sometimes we ask from the help from the patient, for example, we have a patient who is incontinent, right? But sometimes there is a better communication between the patient and the family. And they are letting the family members know that they want to go to the bathroom at this stage, or they have the urge to pass urine, for example. So at this time, I will start to think to train the patient to go to the bathroom and use the commode, right? So they are helping as well. Because, especially for the elderly, they communicate better with the family. Okay? And for us, as a healthcare provider, we have to build the trust with the patient. We have to make them feel safe, feel supported. By this way, they will be able to communicate and let us know what they have, what they need. And most of them, sometimes they are aphasic with low cognition. They cannot express themselves. But sometimes when they trust you, they find a way to let you know what's going on. I'll tell you one story. Back to Easter. One day, I was in the medical ward, and then one patient, post-CVA, with low cognition, a patient who always closes her eyes. It was difficult for us to let her do the exercise properly. Then one day I was fasting. And at that time, it was difficult also for us to assess her cognition. But one day I was fasting, she grabbed my lab coat. She was pointing towards someone. Then I was looking to which direction she was pointing. And it was a nurse assistant. So I called her. I told her, why do you think she's pointing towards you? She told me, maybe because I'm the one who's changing her diaper. And she was pointing to her and pointing to herself. So I was able to understand the level of cognition that she's having. And at the same time, she's telling me, I want to go to the bathroom. And she was able to identify the person who is doing that and who is helping with that. That tells a lot about cognition. So we already talked about the patient and the family. So yes, great job. You were able to identify the missing group. Patient and family are active participants of the management of the patient. So let's talk again about the role of the nurses. Nurses support basic body function, such as respiration, cardiovascular function, skin function, as well as neuromuscular function. Nurses take care of adequate nutrition and perform early mobilization and training of self-care function. Nursing take a key role in ensuring mobility and self-care. This includes advice to the patient and their relative. Nurses also support specific intervention, such as a bladder and a bowel regimen, stomach care, tracheal cannula management, and the use of assistive of technological devices, cognitive behavioral treatment, like, for example, if the nurse, the attending nurse is very close to the patient, she will be able to understand at what time this patient needs to eat, at what time needs to go to the bathroom, at what time. I'll tell you something. When I go to the room of the patient, I always take the feedback from the nurse because she's always around and she's always attending. She always gives me an idea about the level of consciousness. Do you think the level of consciousness is fine? Is the same? Is it the same? She is seeing the patient every day. Yeah, and I'll tell you another thing. So I want to reflect for you. I want to reflect for you to what level we depend on our nurses, because this is a very important point. To the extent, sometimes I'm receiving a call from the nurse and she's telling me, doctor, I have a patient with hypertension. Okay, what do you think? If this patient is conscious, is she vitally stable? She's telling me, no, doctor, I think she's vitally stable and this is her baseline. So no issues. I will be managing this patient until you come and see her. We trust our nurses. We trust their assessment. And sometimes they're telling me, oh, doctor, yesterday the uncle doctor, he prescribed baclofen. Maybe this was the cause of hypertension. She's sometimes suggesting we depend on our nurses. So we have also the rule of physiotherapist. Okay, we have a physiotherapist here, right? Okay, let me ask you. I'll give you just one scenario. I'm trying to talk about the main important concepts. If, say, we admitted a patient after CVA, with a CVA, okay, all the team will come in the first day. Each of them will assess the patient to set the plan of management. And each of them will have the role, and this will be discussed with the patient and the family. So, can I ask you a question? Approach your patient as a physiotherapist. What is the first thing that you do with your patient?
I speak to them. I communicate with them.
So, how gonna talk to you? Tell me about your management plan. Okay,
Oh, we're role playing?
yeah.
Role playing. Yes?
Yes.
Hello, good afternoon. My name is Robert. I'll be your physiotherapist for today. How are you feeling? You feeling okay?
Okay, that's why.
Well, my name is Robert. I'm your physio, as I said. Today I'm here to have a look and assess your condition. So I'll be looking at your range of motion, your strength, and determine what kind of care I can provide for you today. Are you happy for me to go ahead with the assessment? Fantastic. So let us go ahead.
Okay, what you are going to do to me? What we are going to do?
My dear, what I'm going to do is I'm going to move some of your arms and your legs, and I'll assess the movement. And I will see if we can try to get you out of bed today. We'll sit over the edge of the bed, and I will assess your balance. And then if you're able to, we will get you into the chair.
Excellent. That was a great feedback from you. Thank you very much, really. So the first thing we have, yes, great job. Yes, clap hands for him. Great job. Yes, this is the first thing that should be done by the physiotherapist. He has to introduce himself, give the plan, all the management plans should be discussed, how the patient will be managed, the anticipated recovery, how are we going to do that? how we can improve your balance, the level of walking, how can we go step by step, taking you to the wheelchair at the first level, then helping you to walk. Each one should be done systematically and in a specific consequence. Thank you very much. Then the doctor will come and explain the treatment plan, and also the nurse will do that. We have also the SLB. It's the rule of SLB. Do you know what is SLB? Yes, yes. This is the person who's assessing. Of course, you know, after CBA, the patient, he might be having dysphagia. So he will not be able to swallow. So this is a person who helps with speech, with swallowing. He will assess the patient in daily basis, doing assessment and reassessment if needed to decide what type of food is suitable for the patient. Is it liquid fluid? Is it thick liquid? Is it puree diet? Is it regular diet? Then who else is there? The occupational therapist will help with the daily activity of the patient, performing the daily activity, the daily task. And only that, he will help inside the hospital and also outside the hospital to make the home environment appropriate for the patient after he will go to perform his activity. Okay? And I have a very important member here. The neuropsychologist. Of course, the neuropsychologist. He is the person simply who will help with the disorders that connect with the brain and the human behavior, right? He will assess in injury and age-related disorders, and most of these and other, he helped with other also, help with concentration and memory. Most of those patients are elderly with cognitive issue, with memory problem. Imagine you have a patient, and of course, after stroke, most of them, they have depression, which is called post-stroke depression. So at a certain level, you have to give those patients antidepressant. They have to help with their concentration, with focus, with their memory. So this person, the neuropsychologist is very important member. Okay, the social worker with help between the team, arranging, and by the way, the team should always meet together and discuss and see how the patient is progressing. Initially and subsequently, they are meeting 3 times per week and more frequently. So I think it has already mentioned about the ICF, the International Classification of Functioning, Disability and Health. And known more commonly as ICF is a classification of health and health-related domains. And this is the standard language between the healthcare facility. There is so many components for that scale. We'll assess the patient when he will be admitted to the hospital. So many factors, those factors are connected together. Activity, the primary disorder, the activity, and the contextual factor. I just want to give you examples of that, just to make life easy for you. Imagine that you have a patient with cerebral palsy. Okay, and this patient have a problem with walking, with balance. Okay, so the primary disorder is cerebral palsy, right? Okay, then the other components, the function, the body function and structure is how the body functions. This is clear, okay? Activity, the child should, the activity is the ability to walk, the ability to play and perform tasks. The participation, of course, this patient should be involved in the community. He should go to the school. He should go to the garden and play with his colleagues, right? Then the contextual factors, including personal factor, the patient should understand his age, his background, his gender, and the patient should understand why he should walk, why he should go to school, right? And also environmental factors. The environmental factors is how the community will interact with your disability, positively or negatively. So those factors are connected together. If one part is affected, the other factors will adapt according to that disorder. 2 minutes, okay. So I already explained that. I already explained that. Okay, so just a definition, what is the post-acute rehabilitation? Is a clinical service are defined as a short-term intervention aimed at the restoration of skills by a person who has had an illness or injury to regain maximum self-sufficiency and function in a normal or a near normal manner as possible. So this is a list of disorders can be managed inside the hospital. I will not go through that. Go fast. Long-term is defined as a non-acute treatment, care, and support delivered over the long term in an inpatient facility and provided at one of the 4 levels of care. So this is a sort of intervention should be done. Okay, this is how, when you admit the patient, you have to work on those factors because this is the most important complication that will be encountered after CVA, like working in the cognition issues, try to support the patient and gain the strength, communication, help with mobility, activity of the days, which should be assisted and by the occupational therapist, care for the bladder, bowel, and sexual function, spasticity, neuropathic and chronic pain. Okay, let me bring the last one. This is a very important slide. I wanted to talk about the home care, however. So I will define home care and 2 more slides, please. The patient is home bed bound. So can anyone read for me this slide? You have a patient who is homebound, receiving a home care service. At what level he has to go to the hospital? I want someone please to read this slide. Any of you?
You want me to read?
Yes, read it. Loud, loud.
Okay. At home, overall decline in health and functional mobilities or an increase in falls or confusions. Inform your primary physicians for evaluation.
Yes. So we already divided the scope of service to inpatient service, outpatient service, and also the home care service. But at certain level, those patients should be monitored. If at any chance there is a decline in healthcare or functional mobilities or increase in falls or confusion, this patient should ask for help and the family should ask for help, right? So now I want to ask you this question, one last question. You will answer it. Who is the leader throughout the rehabilitation or the recovery process?
Patient. The patient.
Yes, excellent. The patient, excellent. More answers. Any more answers? Patient and patient family. Yes, yes, yes. Very important. If you have a patient with low cognition, patient with depression, you have to build the trust. You have to find a way to communicate with the patient and give him the support to move forward. You cannot do that. You cannot help him with exercise without having a common connection, without building the trust and finding a way to let him do that. And of course, you have to work on all the limitations. Like, for example, if the patient is having sleep disorders, he is not sleeping at night, maybe he is having obstructive sleep apnea, maybe he is in pain. So many things. You have to relieve all the limiting factors to make this patient as much as possible healthy and able to perform the exercises. Thank you very much.
You can't open.
Really, I wanted to say a lot about it. It's a very, very, very big topic. No questions? Thank you.
هلا بس بدي اتوقع انه ما في شو اعطيك البوينتر بس انه الاونلاين سبيكر يكون شايفين كل الاتندي. And did you take the photo for some
No.
Okay, أنا مش جوز دكتورنا أنا مش بنقول
Ladies and gentlemen, our next speaker is going to be Dr. Naham Abu Shakra from Jordan. I'm passing the stage to her to deliver her speech on From Concept to Action, Establishing Jordan's Maternal Mortality Surveillance and Response System.
Thank you. Thank you, Dr. Barbara. Good morning, everyone, and thank you for the introduction. I also want to add that I am a family doctor and specialized in women's health. I work in the private sector, and also I work with the U.S. Agency for International Development as a senior project management specialist, designing and implementing projects. USAID gives to Jordan government around $40 million annually. It's the largest health donor in Jordan, and we use this fund to improve the quality of services, to strengthen the health system, and to construct health facilities. So today I will be talking about USAID support to Jordan to establish Jordan's maternal mortality surveillance and response system, and I'll walk you through the journey we went together. So I'll talk about the importance of maternal mortality, the establishment of the system, and then share some key findings and responses and lessons learned. Do you know that as we are sitting here today, every 2 minutes a woman dies from causes related to pregnancy and childbirth? Is it shocking? Yes, it is. And I wanted to share this information at the beginning, not to shock you, but to underscore the critical need to provide safe, maternal and respectful maternal care to all women who is going through pregnancy and childbirth, and also to emphasize the importance of having a strong health care system that is well equipped to manage childbirth and to in a high level of competency to meet the needs of these women. As we said yesterday, quality is about providing the right care at the right time, every time. So this is really important because we are talking about saving lives. And before we go forward, I just wanted to remind everyone about maternal mortality. Can someone help me define it? Without looking at the screen. So as you can see, it's defined that it's a death that happens to a woman, and it is related or aggravated by pregnancy or delivery or within the 42 days postpartum. And it is not related to something accidental or incidental like a car accident or something. It's usually measured by an indicator, we call it maternal mortality ratio, and it is calculated by dividing the total number of women who die over the total number of deliveries for the same period, divided by 100,000 lives. I also wanted to share the burden of the problem worldwide. So as you can see, maternal mortality ratio is 223 per 100,000 live birth worldwide. So it means that, as we just mentioned, every 2 minutes a woman dies, a total of 800 per day, and most of these deaths are due to something that we can prevent. There was a lot of effort done, and it decreased the maternal mortality ratio, but it is still not enough. And most of these deaths happen in the poor country, in the middle and the middle lower income countries. This slide shows the burden of the disease worldwide and especially in the region. Sorry about the slide. It seems that the changed in the format a little bit, but I wanted to show this. Jordan has a mortality, according to the WHO estimate, of 41. And if you look at the region, it's in the middle compared to other countries. And there are other countries like Tunisia, Lebanon, Palestine, Egypt, Oman, Saudi Arabia, they are all doing better. And we have UAE, Qatar, and Kuwait, they have the lowest mortality rate in the region. Other developed countries like the Norway, Germany, Australia, they have very low mortality ratio, whereas in Africa and East Asia, it is high. I think we all agree that it's very important to save mother's life. I don't have to mention why. Pregnancy is not a disease. It should have happy ending, right? And sometimes it carries a risk. That's why it's a health problem. And because it's more common in the lower income countries, it's a development issue. And to that, the UN had the Sustainable Development Goal to reduce maternal mortality ratio. It's a human tragedy. Imagine a family who's supposed to have a happy event ends up losing the mother. It have consequences on the health of the children. It can increase the likelihood of infant and child mortality and morbidity. Not to mention, that it will affect the education of the other children and the income of the family. It's a human right. Every woman has a right to have access to safe, care and high quality care. And it's, show inequity because it's more common in the developing than in the developed countries. So in order to reduce future preventable deaths, the UN set a goal as a sustainable development goal to reduce it to 70. Sorry. The target is 70 by 2023. Currently, it is 223. So there is a lot to do to reach that target. And in order to reduce the mortality, we need to know not only the number, but we need to know the causes and work, on addressing the causes of death. So that's why establishing a maternal mortality surveillance and response system is important. And it's considered a quality improvement tool that we use to know more about the circumstances, not only the direct cause, but what were the contributing factors and work on solution. So now I will walk you through the journey of Jordan and how we established the maternal mortality system in Jordan. This is some statistics about Jordan, and I wanted to show that annually we have around 200,000 deliveries. Maybe compared to other countries, it's small, but Jordan is a lot. And most of these deliveries, they occur at health facility. 98% they occur at the health facility. 100% are attended by skilled providers. These two, facts give us, an idea about how important to work on improving maternal health, because most of these deliveries, excuse me, I will switch this one, happen at the hospital and are attended by skilled providers. So there is, a lot of things that we can do to improve the outcome. And for the last 10 decades, Jordan has made a lot of progress to improve maternal health. For example, we worked on improving the infrastructure by renovating 20 departments in the public sector. We also provided a lot of state-of-the-art equipment and trained, providers, established state mother health committee, and worked on improving the system and providing confidential increases. However, the results were still showing that most of these deaths can be prevented. So there was a need to decrease the ratio.
So we looked at the data that we have at that time, and we found out that all the data were coming from WHO estimates. And Jordan only conducted 2 local surveys, one in 1995, and the last one was in 2008. So it was a long time ago. And as you can see the data, there was discrepancy between the result of the local survey and the result of the WHO in both surveys. So that's why, we were, questioning the results and wondering, what's going on. That's why we needed like more robust system to, give us more accurate information. And this is where the idea started, like to establish the maternal mortality certificate system. And that is known to have other, strong system, like we have a really good death registry, cancer registry, thalassemia registry. So we have the experience with registries. That's why we started thinking of establishing maternal mortality registry. We wanted a system that, covers the deaths nationwide. That means in the public and the private. A system that counts all the cases and will produce a report annually with, assigning cause of death and the factors, we call it underlying factors, something that you cannot see on the death certificate. Underlying factors that will, also help us with the preventing these deaths, and also the report will have recommendations about what is needed to avert future deaths. So this is where the idea started in 2015, and we developed a concept note to understand what we need for inputs and processes and outputs. So Jordan was committed to establishing the system, and that was, evident in 2016 when His Majesty the King decreed by law number 10 to mandate the notification of the deaths of women of active age group between 15 to 50 to 49. So all these deaths by law, they have to be notified. The law also called for establishing a national advisory committee to review the cases and also to establish a unit at the Ministry of Health for the death registry. That was the first step, to have a legal framework. All these are, they published in the newspaper, the Bible. Then we started working on design this system. And the political will was there, the legal framework was there, so we started working on the capacity. Roles and responsibilities were defined, people were trained, infrastructure was improved by providing IT equipment and developing information system. And then we developed tools and forms to be used in collecting the data and guidelines for implementing this. So we had all the inputs and we started working on the process. So the process of the system starts by notification. It has to be within 24 hours of the death. And because all cases can be captured, because in Jordan, if you want somebody dies, he has to get a notification to bury the dead body. So this notification comes from the hospital. So at the hospital or at the forensic medicine department, if a woman doesn't die at the hospital, if she dies at home, she still has to go to the hospital and register. So we captured all cases. After that, the system, will provide information to the health directorate. They will send someone to identify the case. Was it maternal or not maternal? It could be someone who died at reproductive age group, but from accident, something not related to pregnancy. So this is not considered maternal. So the first step, notification. The second step, identification, has to be done within 72 hours. And then it will be reviewed. It is confirmed maternal death. The first level of review is done at the directorate level by using 2 checklists, one at the facility level and another one at the household level. This is all, based on the WHO technical guidelines. And we learned from Egypt because Egypt had a system similar to the one we developed. After that, the committee will identify the causes And then a national advisory committee will again review the cases and confirm the diagnosis, the causes of death, if it's avoidable or not. And the national advisory group is usually experts of obstetrician and primary healthcare physician. Then we will use the data to analyze it and, produce the report that will be submitted to the minister, and all the information is de-identified. So there is no blame culture. We use it just for the sake of, improving health, not for, medical legal purposes. Then, the national advisory group will recommend some responses, and then we will disseminate the results. All this process is monitored by indicators to, see the progress. So, as I mentioned, there is an information system, and it's web-based. All the information is secure and confidential. We also use the 3 delay model. This is the underlying causes of death. Why the death happened? Because delay 1, the woman did not go to the hospital, or delay number 2, she couldn't reach to the hospital because of access issues, or delay number 3, she went to the hospital, but she didn't receive the care properly. In 2018, we launched the system. We started reporting, and all the stakeholders participated. In 2019, we issued the first report under the patronage of the Prime Minister. He attended the event, and we wanted to get the attention of the high-level decision makers. So I will share some of the key findings. As we are sitting here today, we produced 4 reports annually. They cover the period from January to December. And these are some of the results that is also shocking, because you see that in 2021, the ratio increased drastically. And the only explanation was due to COVID. So the committee decided to, analyze the data with COVID and without COVID. So without COVID, we see that, there is some kind of plateau. Maybe we still wait to have the 5th report to see the trends and do more in-depth analysis. The most common causes of death for the first 2 years, postpartum hemorrhage, and then COVID. But again, postpartum hemorrhage was the most common cause, direct cause of death. It means related to obstetric causes. And the reports also showed that most of these deaths, they happen in the postpartum period. And most of the diseased women received 4 or more antenatal care visits, but we don't have information about the quality of these visits. And all these, analysis is descriptive. It's not a causal relationship.
Normal delivery or?
I will tell you. So I was going to just say that when we look at the mode of delivery, more than 65% on average delivered by C-section, and most of the C-section were emergency C-section compared to the delivery. And you can see that there is increase in the trend in the C-section. Most of the cases were related to obstetric causes, except for the last year because of COVID, and more than 70% were avoidable causes, as the committee decided. So this is, the important point, that most of these cases are avoidable. Some people say, but the ratio is low. But we say it's low, but it's avoidable. Delay number 3 was also high, and it was because they didn't have protocols to follow, they didn't have specialists, or there was a delay in deciding the diagnosis and providing the right care. So this was not enough to know the number. We wanted to have an action, and the action is at different levels. It could be at the national, at the facility, at the community. It could be short, immediate, or long term. These are some of the responses that we already worked on, is to provide some protocols or safety bundles to train providers how to manage postpartum hemorrhage, about vaginal birth and trying to decrease unnecessary C-section, emergency obstetric care, and family planning, because just working on the unmet need can decrease the ratio by 1/3. During this journey, we learned some lessons. There was a lot of challenges, but we also learned some lessons that the legal framework was important, standardizing the process was also essential, but still the response was poor. So one of the reasons was the lack of coordination, the integration. We've been talking about it yesterday and today. The response is fragmented because of the structure. The hospital belongs to one department. The antenatal care is to the primary health care, and the obstetricians, they follow the head of specialty. So it was fragmented, and there was no accountability. No one was held accountable to take a role in, following up on the response plan. Quality of service, we don't have information about the quality of services, so we need to know more and to address these issues. Provide evidence-based protocols was important in reducing the ratio, and most of these women died from postpartum hemorrhage, so there was a problem with the blood and blood products. So also we need to make sure that they have access to safe and adequate blood and blood products, and documentation in the medical shop. A lot of information was missing, and we didn't know because the documentation was poor. So we want the provider to make sure that they document everything in the medical record. We wanted enough number of health workforce to go and do the visits and do the reviews. So the capacity building needs to be ongoing to train all the people to collect the data and analyze it. Impact of COVID affected, the result, as you saw. It didn't affect the data collection, but the access was disrupted and the mortality increased because, the vaccine was still new. Women were not, pregnant women were not convinced that it's safe to take it. And some doctors, were afraid to care for pregnant women. That's why also the C-section rate was higher. We will continue our journey. We have a lot of things that we can work on and sustain it. I conclude by reiterating the importance of maternal mortality. It is still a public health issue worldwide. Jordan, it is still important. USAID is committed to continue supporting the government and decreasing maternal mortality. And we will, plan the phase out gradually so that they can continue to manage. And thank you so much for listening. I'm happy to answer any questions.
Very, very interesting information. Thank you so much for the presentation. Is the reporting an electronic system, voluntary or non-voluntary? Is the system meant to integrate maternal deaths automatically, or is it reporting? Or when you do the data collection for maternal cases, is done through reporting, and voluntary people will go into the forms automatically, or?
Yeah, it's all electronic. They have tablets and laptops and iPhones. They can enter the data بسجلات المرضى from their patient medical record. So they enter all the information, and it with the information system automatically, electronically, it will notify the health directorate, so they will, send someone to review the case. So it's all electronic, digitalized, secured, and confidential.
Thank you, Dr. Nara. Yeah, very interesting. During COVID, I had experience with a big high mortality rate for the big women on the offensive relating to recruiting factor for the big all cases, the young cases, not chronically ill, just 37, 32, 32. This is died during the COVID because of PE. That's coming to ICU, just was a death with even stay in the hospital not long. So I think there's a relationship, yes, between compliance and publication and other physical and physical disease and mortality, not related to pregnancy itself. So during the COVID, we reported all the diseases. So pregnant woman, yes, go with you in your reports, but definitely it's not related to pregnancy itself. This is the first one. Second one, I think delay during COVID. You know, there is a guarantee. There is a cards, even a pregnant woman itself as a patient, the community there's a fears. They didn't go to the hospital directly because she their fears she will get the virus. So this is one reason to the delay in the seeking the care, I think. Thank you so much. Regarding the delay, you are right. There were delay in going to the hospital or in delay number one and seeking the healthcare and number two. However, delay number three was more common. It was the most common among the three delays. And regarding, you know, your other part of the comment, as I mentioned, the COVID increased the maternal mortality ratio, and it was considered as a respiratory infection, indirect cause of death, not obstetric. But any disease that happens during pregnancy or aggravated during pregnancy, and it's still pregnant women are at risk of dying of COVID. So it was considered maternal mortality. Pulmonary embolism has different diagnosis criteria, and you know, some of these cases they did autopsy, but others, you know, didn't. But pulmonary embolism was the third common cause of death during COVID. And we still need to see the fifth report, and as I mentioned, do more in-depth analysis. These are just observational. We don't have control group, and that's why we cannot disclose the relationship. But this is what we will do in the future. Thank you so much. By the way, I have some copies of the report. And well, I have certificate in it. Yeah.
Yikes. Okay, please join me in welcoming Dr. Badria Mohammed Al Riyami. Thank you so much from Oman. I'm passing her the stage to deliver the keynote presentation, Doctors and Nurses, Views and Experiences of Workplace Violence in the Emergency Department, Results from Oman.
Thank you.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Still, we are in the morning. Yes. Good morning, everybody. Glad to be one of the speakers in this major conference. Thank you, Dr. Barbara and Dr. Badria Riyami, senior nursing tutor from Oman of Nursing Science in the Sultanate of Oman. I'm glad to be one of the team members who had been working on a research, funded research regarding workplace violence among the healthcare workers. And we started this since last 2 years. We had a series of quantitative research studies. One got published, still the others are coming to the site, inshallah. What we are actually, what I'm going to be presenting today is a slight piece only of one of our quantitative research, which was majorly about the workplace violence, specifically among physicians and nurses. The coming research, we are going to focus more on the other type of healthcare workers or healthcare professionals. So let us define first what is violence. How do you define this? Accuse, abuse. Of what? What type of abuse? Physical, verbal, non-verbal. So yes, we are defining this, and this is the definition of the US National Institute for Occupational Safety and Health. And you can see it's a physical, non-physical, verbal, non-verbal assaults, which can happen actually among the healthcare workers. The impact of workplace violence can range from a psychological, as you can see here, to a physical abuse. From where the violence is coming to the healthcare professionals? Who are the source of violence?
Patient family.
Patients,
Patient family.
patients' families, relatives, colleagues. Yes. So it's either from the outside or it is within the healthcare workers. The focus today is the patients, mostly the violence which is coming from the patient side. But in the coming future research, we are going to focus more on the violence which is coming within the healthcare workers from their colleagues, from physicians to a nurse, from physicians to so and so, to the other health, or also it's vice versa actually, from the nursing department, from the nursing staff to the physicians or the other healthcare professionals. Searching the review of literature, or also one of the things we did in one of part of our project, we did a review of literature. I was leading a team doing a review of literature. It was a narrative, not a systematic review, and it's going to be published. Let us hope so by next year, inshallah. Where we did a review of literature on the healthcare, of the violence among the healthcare workers also. And what we found that it is really very common in all of the disciplines, but it is really overrepresented among the healthcare workers. Although it is, the statistics is showing that it's overrepresented among the healthcare workers, it's underreported. It's really underreported by the healthcare workers themselves. And we found lots of reasons why they were not reporting the violence, assaults, and the physical, non-physical, that is unfortunately coming in another study also. 62% of healthcare workers have experienced the workplace violence, with verbal 58 and physical 24, and this was a systematic review done in 2019. All of the reference or most of the reference used, you will find it at the end of the slides. Among the healthcare workers who were facing the violence was those who work in the emergency department. Why do you think? Yes, we came up with several reasons or several causes why, and we will discuss them when we will go to the findings. Why we thought to do this study or to this project? Workplace violence was not being studied specifically in Oman. We got lots or several studies actually from Saudi Arabia and the other countries, but within Oman itself, it was not studied at all. The cause and consequences of violence incidents as perceived by the emergency nurses especially was not explored at all. Most of the workplace violence studies which has been done, it has been done within the Western countries. I think you are well enough knowing that such guidelines and recommendations which is coming from Western countries. It may not suit our culture, our context. So that's why it is very necessary to conduct our own and then to see if we can benchmark also, or to how extent we can implement those. Understanding, we started with the emergency department nurses, but as I said, the coming the next studies we did among the other healthcare workers, because it came from the previous study we did when we did the emergency department. Among the emergency department staff, we came to know that it's not only actually within the emergency department, it's with all of the healthcare workers, and then we expand actually the scope of the study to include the healthcare worker, the other type of healthcare workers in the coming studies. As part of a large study, and this is what I'm saying, what I'm gonna present today is the analysis of an open-ended question, which was only one question in a survey. And I was leading the analysis of this using open text analysis kind of, because we wanted really to know. It was a survey, part of a quantitative study. At the end of that survey, we included an open question where we asked the participants to tell us about their experience and what they think the causes and the consequences of the violence. And then we took that question and we started analyzing. So basically, the study was quantitative and it was a survey. As I said, we had a comment question, and it was the sample of 117, which is very low. Had a very low response in this study. Actually, it was open enough, although it was among 8 secondary and tertiary hospitals in the Sultanate. The response was really still low, but we had to go with it as a start. All of the ethical consideration has been taken into account. The data was collected using the survey, as I said, and we use the software RedCap to manage data, and we use the effective thematic analysis as being proposed by Brown and Clark, which had 6 steps where we have to go through all of the response, and then we had to identify them, we have to classify them, and to group them into team, and then making the report. This is just to give you a flavor of the socio-demographic data of our participants. This is not all of the socio-demographic, but as you can see, most of them are nurses, female, married. These are the most indicator-like, and most of them are working in a shifted duty. When we analyzed that single open question through the thematic analysis, we came up with 5 themes, which is shown in the slide, in regards to their perception and attitudes, causes, consequences, suggested solution, and how do they deal with violent incidents. The first one is their perception, and what is really it's not shocking. I mean, it's something which we expected, all of us, that they expected it part of their work. It's not something they consider it like something which is wearing. It's part of our work because we are dealing with people, because we are dealing with humans. We make it's part of our work. It's part of our daily life. So that's could be one of the things, because they expected it as part of their work. They were not reporting it. They didn't feel that they have to report it because it's part of their day, it's part of their routine. It's almost happening daily. So this could be one of the reasons why it's underreported. Causes of workplace violence. This is the sub-themes which came actually under the causes. Long waiting time, lack of resource, increased workload, lack of effective communication, lack of preventive measures, and patient satisfaction of it. And we understand that we are working here in ED, an emergency department, where all of these are really very obvious and very expected, and these were the causes. I will not go through the details because of the time limit. So the result of this study reported disinterest actually. When we came, we thought this is very interesting because when we came to the lack of preventive measures and we tried to go in depth in analyzing the question, that open question, this is what came with us, which is the disinterest that the hospital management is actually not interested in protecting the staff. They said they are not interested. One of the other thing also we identified that there is a policy against the violence. In the hospitals we were recruiting, there was a policy against the violence, like on violence itself, but none of the staff knows about it. And it happened, some of the staff, they told us that when we had we had been attacked by a patient or relatives or whatever, we went, we report, nothing happened. It stopped there. So they didn't know that there is policy, and there was a policy, but it was not implemented. So this is one of the issue we find it also. In regards to the consequences of the workplace violence, when we analyzed this one, it was like within the staff level, where they got sad, they got fear, they felt anger, why they were going through this, but at the same time also they were caring of their patient, and they said it's not the impact of workplace violence was not only on us, it was on the patients, because when we are really getting kind of attacked by the patient, that may overall affect the patient themselves and the overall system. Team number 4 suggested solution, and they suggested, or they grouped this, or we grouped the solutions they suggested into 3: organizational level, staff level, and patients level. Within the organizational level, they want the hospital management to work on the policy, on the guideline, and implement. There's a policy to show them how they are implementing it, training the staff, as I said, and within the patient's level, they want awareness. Because none of them, like most of the patients, they are coming to ED and they think they need to be served within few minutes and they should be out of ED. And they said this is the essence actually of ED, because it's ED. We're supposed not to stay here for half an hour or 20 minutes. Sometimes they don't know that some of the lab investigations are really taking time. Some of the diagnostic tests, other radiography is taking time. They are not the only one there. So they don't understand really the routine or the culture sometimes of the emergency department, and this is where it comes. How did they dealt with the violence? We group also, or more according to their statements, we group the strategies they used into 2. So either they were using, or it's a combination of debriefing technique or de-escalation. So either they minimally what they do, or something, the most common things they said they want to do, they will do. They were go to one of their colleagues or like somebody in another department or a relative, and they will just state the story they went through. The others, they were going to the de-escalation, where they started whenever any patient coming with anger or like attacking them, they would try their best to stay calm, to try to listen, to try to absorb the patient's anger, and then to relay back to the patient and try to make him understand why the late, for example, why he's taking long time in ED and so on. So either two or a combination of these techniques or strategies they were using. What we got, because as I said, this is only the analysis of one open-ended question, which was at the end of a survey. We thought that we need to go in depth, and now I'm leading another qualitative study, but it will not include only the emergency department staff, with the nurse and the physicians. We are including all of the healthcare professionals who are in those hospitals. We need to look at the techniques the staff used and see to how effective and how we can help. We need also to look at the measures the hospitals, the different hospitals and the sultanates are using against the workplace violence, and see to how extent those measures are really effective and helping of the staff. And as I said, the last one is the policy. The policies existed. The only thing they don't know that there is a policy. I don't know whether they were not oriented, and this is for sure it will be one of the question or one of the scope we are gonna investigate and explore more in our qualitative study. Really, we want to know exactly where was the missing point. There is a policy. Why the policy was not implemented? Why most of the staff they didn't know about it? We need to know more on this and investigate more. As a conclusion, cooperation between healthcare professionals and management of healthcare facility researchers, decision makers are vital. And I think this is why the most important or the most significant issue why we need to conduct workplace violence, studies on workplace violence, specifically in the Sultanate of Oman, because there are lots of things missing and we need to know about them. And we need to include all of the stakeholders in our healthcare system in order to solve or at least reduce the risk of the healthcare professionals in this regard. Providing free violence and safe working environment should be one of the principal aims in our hospital management. Developing clear policy. There is a policy, but I think the policy needs to be reviewed, need to be seen, need to be rechecked, need to be matched with the reality, and we need to know also the input of the staff, including all of the care professionals about these policies, and see to how extent these policies are actually practical. These are the reference, and thank you very much.
Do we have any questions?
Thank you very much, Dr. for the informative information. I have a question for you as a researcher who has a deep look to the issue. From my point of view, that we can stop violence only by policy. Yeah, we have policy, like if you do harmful actions or something, you will be pay a fine, you will be behind the bars, jail for this number of years. Is there any way to prevent violence rather than using policy or regulations?
I think it's a combination, and it comes actually from the participants themselves. When we want to work on workplace violence, we need to work on the which is actually the policy, which we need it for sure, though it's not enough. And then we need also to involve the healthcare workers themselves, and then we need to involve also the patient, because or the public itself, public awareness is very, very important. They have to understand the culture of the healthcare workers' life, the healthcare system. How is it working? What is the burden on these people? What they are actually taking into consideration? Why they have to know also the reason. And part of the things is the communication. I mean, if the patient in ED, let us say, is waiting for 2 hours without anybody coming to him and say, sir, we are very sorry. We know that you have been there for 1 hour or half an hour, but I have to tell you why you will have to wait. They have to be informed, but just to keep like that, waiting for 1 hour, 2 hours, it's not. So there is a combination of factors need to be taken into consideration. For sure, the policy, as I said, policies existed, but it didn't help to stop the workplace violence. Why? One is the communication. It was not being communicated. It was not being communicated at all to the staff. The staff, they don't know how to process. When I face violence within my duty or during my duty, where should I report? To whom should I go? They were going to their in charge, they said. In charge, they said, you know, this is happening everywhere. Don't bother yourself. It's a headache. Lots of process may be there. They will investigate. You will go for so and so. And it's not the truth. It's not true. It should not be like that. The policy should give us, after the policy, we should have a guideline saying, these are the steps we have to go through. So this is part of policy is very important, but the other factors need to be taken into consideration. The support of the healthcare manager. They actually, some of them they said, we spoke to the in charge said, don't bother yourself. Then we crossed her and we went to the head of nursing in the hospital and we got the same answer. And this is not the way it should be. We should feel also safe for the patient. Most of the lecture which has taken in this conference from yesterday up to now, it's majorly focused on patient safety, which is the theme of the conference. But this is not also, this lecture is not going away from the conference theme, because if we are not safe as a healthcare professional, if we don't feel that really we are working in a safe environment, then how we ensure that safety to our patients. I think this is very important. Excuse me.
Yeah, sorry, no need for this. Actually, I think it's just not a question, it's a comment. I think that not only the policies are enough, but for me, as I experience in ER, there is a lot, especially in my country, Tunisia. But since I'm working in Saudi Arabia, the government is responsible for this one. For example, in Saudi Arabia, they are putting like a penalty. You should pay if you are a patient or the patient's family, even if you are a colleague and there is some abuse, verbal, non-verbal, anything, there will be an investigation and it will be costable for him. So the patient and the patient family, since they are entering the ED department, they saw, as I mentioned, what are their rights, what are their duties, and it's mentioned by the government that there will be a penalty that they should pay if there is a violence.
I assure you, we have the same thing in the country.
Same.
The issue is with the staff. They don't want to report.
Yes.
It's there. It's there.
Can I ask? We have the same things, and we discovered that the quality department, they're conducting meeting with the leader. I mean, with the head nurse, for example, of ICU, medical, surgical, and the staff who is working contacting with the patient, they don't know about this policy. And when she is coming to the department, back to her department, she is not informing the staff about this policy. So the staff really, they don't know. So what we suggest to them, that go to the department, conduct the awareness session there in the department, and the staff nurses who is caring the patient should know about this. Because if she came to the charge nurse, the ward head nurse, and she ignore her, she can't come up to the next level, and she will not close her mouth. Not like she will go there and she will tell her, no, it's a long process, and just left it. So this is what we just want to
I think preventing workplace violence is really difficult, especially at the level of the ER. Because I'll tell you, when the patient will come, because this is a multifactorial, because there is so many factors related to the patient background, his attitude, the level of respect, the level of his knowledge, and this is one part of it. Another part, when the patient will come to the ER, of course, the ER is a busy place. Who is the person who should be responsible to give education about the situation in the ER? I mean, is it the nurse? Is it the doctor? Is it the nurse assistant? So it's a busy, dynamic place. So I don't think the patient will come to the ER. One person should be assigned to explain the process. He should know that the process will take this and that time, the labs will take time, that he has to wait because they are prioritizing the patient. The acute patient should go first, then you come next. You have to give details that the lab investigation, the result will be out in 1 hour. He has to accept it. But beyond that, if he will not accept, he should not be aggressive. Always, in the hospital setting, they have to put the rules and regulations because he has to be punished. Why? Because if he will be punished, this will not be repaired, and we have to protect our staff. Like, for example, the nurse is trying to explain, and of course, she will try to help, but this is not her duty. She has to be attending to the patient and serve him. So this is deducting from her time. She should not just leave a patient who is comatose or having drop level of consciousness or acute injury and stay and explain to the other patient who doesn't have an emergency situation. This cannot be done this way. So this stuff, for example, I am busy managing one acute case, then another patient, he came to me, no, you have to see me, you have to see me. Then he will start to fight. She will be, maybe he will use bad words or something like that. This stuff should be protected. That's what I want to say.
Okay, what's your proposal? Who pays patient?
Yes, I understand, but I do believe someone should be assigned and explain the whole process for him. He had the right to know. He will understand everything, you explain everything. But after that, if he will misbehave, there should be a rule to stop that. Because sometimes there is some sort of patient, whenever you explain, whenever you discuss, they will never accept. I know that because I work in the emergency and in the ICU as well. We always encounter those patients, those kind of patients. Yeah, this is really difficult to control.
Yeah, so we just started recently in military hospital in Saudi Arabia, like called infidelity culture. We teach and educate the staff all about the work violence, and we have like the policies, how to go through the process. And we have incivility cultures committee. So if there's violence between the healthcare providers, to who they have to inform. And if they will like there's formal and informal reports, and if they will like keep it in the hospital or escalate it to the like senior committee. So I just encourage to search about incivility culture to can help a lot in this issue.
Just a point actually, before we started, when we proposed this research to be funded by the Center of Studies and Research in which we got rejected at the beginning. And the major reason why we don't have workplace violence in our healthcare system. So we said either we proved it in our review of literature, and unless you give us something like rigid, and we know why you are saying we don't have workplace violence, then we are going to proceed for this project. And then we got accepted. But they said first they don't. Although we started this project around like 2019, Later on, we discovered that there was a policy on violence, which was issued from the Ministry of Health, 2017. So if you thought that there was no workplace violence, why you issued a policy? And that was one of our reasons why we got later on also excellent. So yeah, we will. Thank you very much.
Thank you, Dr. Brown.
Okay, moving right along. Please join me in welcoming our next speaker, Ms. Haila Nasser Alou from KSA. I'm passing her the stage to deliver her speech on advanced diagnostic imaging techniques, alternative to intervention procedures.
Good afternoon. Thank you for attending this session. I'm Haila Nasser Alou, radiology specialist working at Prince Sultan Military Medical City in Riyadh City. Today I will talk about advanced diagnostic imaging technique alternative to interventional procedure. So as introduction, imagine that the patient come to the AR complaining of left flank pain. So the AR physician suspected kidney stone. So let's take a look about the kidney stone suspected. Here's the outline, type of stone, CT scan, the GSI feature, chemistone spectral imaging for stone analysis, role of CT scanner in the treatment of kidney stone. So type of stone suspected, we have calcium stone, uric acid stone, strobite stone, and cystine stone. So the most common type of kidney stone are the calcium stones. We have two types, calcium oxalate and calcium phosphate. Calcium oxalate, is mainly made by the liver. It's taken from the fruits, vegetables, and chocolate. And the kidney stones, calcium oxalate kidney stones, can occur from high doses of vitamin D from your diet. The other type is calcium phosphate. It's happened due to metabolic conditions such as renal tubular acidosis, or certain medication can cause calcium phosphate. The other type of stone, strobite stone, it's usually from urinary tract infection. It's rapidly increased in size and it's really dangerous. So this needs direct treatment from the AR physician. And here we have uric acid stone. It's usually happen with the patient losing plenty amount of fluid from like chronic diarrhea or malabsorption. And we have the last one, cystine stone. It's when the kidney producing a lot of amino acid, causing this type of stone. So the patient coming to the AR and suspected kidney stone, of course, the AR physician ask the patient to or order the patient to do imaging to diagnose the patient. So CT scan is the radiology modality using ionizing radiation, is the most accurate imaging technique to diagnose kidney stones, even the small one. And here we have GSI, is chemistone spectral imaging using dual energy. It's with artificial intelligence technique. It will give the chemical component of kidney stones. Okay, so we image the patient. We have here the images, coronal and sagittal and axial. As you can see, the kidney stone appears as bright in the image, or we call it hyperdensity. As you can see here, this is in the axial imaging, and the sagittal here, and the coronal. As you can see, it's now conventional CT can diagnose the kidney stone, but we can't know the component, the chemical composition of kidney stone. With the GSI feature, we can do this. So analysis of kidney stone after applying GSI feature, here we can know, we detect the chemical composition of kidney stone. So we know the type of stone. Here we have Here's the star. It's GSI. So we know the type of star. Here's keratocyte acid. It's causing X-ray. So this patient suffering from calcium oxalate kidney stones. Here's other patient also complaining of kidney stone. As you can see here in the diagram, the line cutting. So the patient suffering from calcium oxalate kidney stone. And here's the last one. So this patient, do you think which type of kidney stone the patient suffering from? According to the diagram, you can see, or it's not clear. As you can see, the line here cutting the diagram refers to strobite stone. And so rule of CT GSI scanner in the treatment of kidney stone. CT with a GSI feature can be used to find the best available treatment method on a stone composition. GSI allows the physician to quantify the kidney stone chemical composition and make use of the data in a way conventional CT cannot. And in the conclusion, CT scan can be very accurate at identifying kidney stone. Studies have found that CT scan can correctly identify kidney stone more than 95% the time. CT scan is important diagnostic tool and initial step in deciding which therapeutic option to use for the management of kidney stone. Thank you for listening.
Is there any question? Thank you for your speech. It's really informative. That doesn't have like normally we would detect kidney stone with X-ray or ultrasound, especially ultrasound is used to be like less expensive. We CT scan in my country, somehow it's not covered by insurance. So I'm not sure if like the CT scan's price in the country is according with the insurance as well, because it's a big part for the health professional patient to decide to choose CT scan. It's like on the technology. Yeah, thank you. Yeah.
We have other modality to detect kidney stone, such as ultrasound, but it's not accurate as CT, sorry, for kidney stone analysis and kidney stone diagnosis. So that's it. Okay.
Insurance covered.
We are here in government, we don't pay for the diagnosis for CTs. It's for free. Thank you.
Okay, والبوينتر تمام. بالعكس عايز يكون يعني. Yes, sure. بس لا دكتورة بربرة بتجي introduce you first.
Moving along. So it is my honor to introduce to you Dr. Zakur Al-Kayami.
Kaimani.
From KSA. I'm passing her the stage to deliver the presentation on individual perceptions related to fall risk among older adults in an acute care setting in Saudi Arabia hospital.
Thank you. It's close to your topic.
Yes.
Good afternoon, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh.
My name is Dr. Zuhur. I'm working as a nursing education director in a military hospital. I did my master's degree in nursing education, and I did my PhD degree in nursing science. And now I'm doing my postdoctoral fellowship program in nurse executive leadership. How can I move the video? Okay. So I believe in Nelson Mandela, what he said, education is the most powerful weapon which can use to change the world. So I graduated with a diploma degree in 2006, and my thinking was the nurses is only bit by the skill. And then I moved and I studied my bachelor degree, and then I was like thinking out of the box. I was able to be think critically and be a decision maker. Then when I moved to use the evidence-based practice to do my master's degree, I said that what is the nurses beyond the bedside? So the nurses, she can be educator, she can be a researcher, she can be like innovative, transformative leader in healthcare organization. So my personal brand, everyone has personal brand, like what's the value and experience you have to bring it at the table. So I didn't know my personal brand. I just know it recently when I did my postdoctoral fellowship program. I noticed that my personal brand is I want to change what the people think. The nurses beyond the bedside. Nurses, she is not only the bedside skilled that we need to focus, but she can be a researcher and she can be a transformative leader. And I hope I will be a transformative leader in the future. This is my goal. So my topic, it was like about the fall risk during the individual, during the elderly people in acute care setting and King Salman Armed Forces Hospital. Why I chose this topic? Actually, my topic was about the medication errors. And then I went in the summer break back to Saudi Arabia, and I met one of my colleagues. He's a physician, and he did the laparotomy. And then he told me after I have the OR, I went to the bathroom and I had the fall. And I said, you are a physician and you were about the fall, and we use the fall prevention plan in the hospital, and you are experiencing fall. So what about the patient? What is the gap that's in the literature review that we need to know about the fall risk? So this is where I worked in King Salman Armed Forces Hospital, like since 2006. The hospital opened in 1980. It was like with 129 beds, and now we have like around 1,000 beds. To provide the highest standard of quality and safety in healthcare, we are a tertiary hospital. We accredited by the GCI and Tibahi, and now we are preparation for the magnet process. And actually, in the first quarter, it's reported that there were like 37% of the fall during 2021. And when I go to the OVA system, where reported the patient fall, the main reason it was patient non-compliance. And I said, what do you mean patient non-compliance? Why the patient non-compliance to the patient fall? So background and significance, the fall is the second leading cause of death. 2 weeks ago, my CNO in Kent State University, in Case Western University in Cleveland, Ohio, she reported me that her husband, after he got the OR, after discharge from the OR, he had a fall and he died from the fall. So it's really like critical issues. It's the second leading cause of death. And there were 684,000 individuals died from fall globally. And while the fall in Saudi Arabia, they are up to 49.9% of elderly people experiencing fall each year. So when I said elderly people, it means the people who age 60 and above, and some researchers said 65 and above. So we consider 60 years old. Frailty is when the people aging like elderly, they have experiencing with frailty. They get weaknesses in physiological, psychological, social components. And we were noticed in the literature review, there is like a positive relationship between frailty and the patient getting high risk.
So those are the full prevention strategies that we have in the hospital. We have a patient fall policy. We have the OVA system where to report the patient fall. We use the risk assessment fall tool. Like there is the Morse fall scale, which is the famous one we use. There is a John Hopkins tool, and there are others. But why? What is missed? What's the item missed in this tool that we need to know? Why the patient is still fall, even if we have all of those strategies? We have the literature review talks about the fall-related factors. It could be environmental factors. It could be social factors. But what the factor is missed here? The fall prevention, we have the fall prevention checklist. When the patient admitted to the hospital, we explain to the patient, you have to keep, for example, the side rail up. We inform the patient about the pathway to the bathroom, for example, avoid the wet floor, and show them like what is the light, and all this like prevention checklist, like the simple checklist. And the patient fall risk science, we have this science for the patient who has the high fall risk. And we do education, but still why the patient still had fall. And this is like, it was like one really question to me. I need to find this in the literature review. If we have all of those strategies, why our patients still had fall. So this is the checklist that we use, the prevention checklist simply. This is all the fall risk assessment tool. It's using like around the world. And we see like they asking for the history of fall, the secondary diagnosis, if the patient able to walk or they use the wheelchair, and etc. But what is again the items that missed here? So when I do the literature review, when I read, I found the scientific gap. First, there is a limited knowledge about the individual perception. People doesn't know what is the individual perception related to the fall risk, especially with the elderly patients. The second, there is limited application of the health belief model in Saudi culture. And the third one, this is the key. The fall risk screening tool do not include the individual perception. So simply the purpose of my study, I want to examine what is the relationship between frailty and Morse fall skills, those skills, the health belief model skill that we created, and the patient fall risk. The patient fall risk is, we have two categories, either no risk or high risk. So my study variables, there is like confounding variables, we call it independent variables, the demographic variable, frailty, the individual perception. Those four, the main of my studies, those four independent variables, perceived stability, severity, perceived barriers, and perceived benefits. And we have one dependent variable, which is fall risk level, no risk or high risk. So this is the health belief model that I use, is used like widely in the research, and it has the high reliability, and developed in 1950 by the social psychologist. Is briefly, the health belief model theory is describe why people do or do not participate in disease screening and disease preventive measure. So this is my study model. As I told you, we have the confounding variables, and we need to know like what is the relationship between those and the health belief model, individual perception variables, and with the fall risk, either no risk or high risk. Am I talking fast? Sure. Okay. Sometimes my professor told me calm down. This is my research questions. It's in detail, but I'm gonna like conclude it to you by the end. So simply we need to know the relationship, but before to know the relationship, I just need to examine what is the individual perceptions that they have and during the elderly patients and acute care settings in my hospital. So the measures, I use the Morse fall scale. We use the frailty indicator because we want to avoid the confounding variables. We have to study these variables to know, to make our statistical conclusion strong. So translation process, we use like called independent translation process. We translated it from English to Arabic because this is the skill, the health belief model skill, it was only in English. So we have a permission from the authors to translate it to Arabic. And the translation was by lingual experts, Arabic and English. And then we use the content validity validations to make sure the translation was accurate and in the same meaning. Reliability coefficient of internal consistency between the items. So this is the Morse code skill. I told you again, we have some items, and then we will make the score like from 0 to 50 noted. 51 and above, the patient will have a higher risk. And then this is the frailty, what I told you about the frailty skill. We studied the physical component. For example, do you feel physically healthy? Sometimes the patient is weak, so we need to study those before know the relationship between the individual perception and the fall risk. Because the patient could be, he has a fall because he has a weak from the physical healthy, not as related to the individual perception. So that's why we need to study those before applying an individual perception. So there are three components: physical, psychological, and social. So this is the main fall-related health belief model skill. We studied the perceived severity. For example, I came to the patient and I asked the patient, do you know the fall in elderly is a very serious problem? They need to know those. What is the severity? What is the benefits? What is the barrier? What is the sustainability? Does the fall is the second leading cause of death in the hospital? When they will be aware, then they will be able to change their behavior to prevent a fall. So I'm not going to go in details, but this is the skill briefly. So the study design that I used descriptive correlation cross-sectional design. The sample size, it was rule of thumb, since we are used the binary logistic regression because we have no risk and high risk. So that's why we use the rule of thumb to determine the sample size, and it was 150 participants. We use the convenience non-probability sample in the medical and surgical unit. And our inclusion criteria, like the patient admitted to the acute care units, age 60 years and older, speaking Arabic, and cognitively alert and oriented, because they need to answer those questions. So data collection procedure, I trained the, yes, 5 minutes, okay. I trained the nurse receptionist to tell us what is the patient that met the inclusion criteria. And then the nurse receptionist came to the primary investigator, which is me. I used the Qualtrics software. I went to the patient, I explained the patient the purpose of my study, and he has a right to withdraw from the study anytime. There is no force. This is the ethical principle in the research. And then I asked the demographic questions that I show you, the frailty skill, and then Morse code skill, and then the health belief model skill. So we did a pilot study before my study with the 30 participants, just to make sure that questions is clear, there is no technical problems, for example, and we test by using the Cronbach alpha, we test the reliability between the items, and it was 0.9, which is very high. The accepted one is 0.7 and above. So after I did the pilot study, everything is good. So we start to implement my survey. So the data management, I'm not going to go into details, but we enter to the SPSS, we manage the missing data, Qualtrics data, and then we use the statistical assumption. So this is the data analysis that we used. And the demographic variables that we see, the gender is female was more than male. The age, most of them was 60 to 69 years old. The marital status, most of them married. Education, most of them had a high school education. That's why most of them, the individual perception was low. And the length of the hospital stay was less than 1 week. So if you see, this is the data, the mean rank in the no risk is high. That means the patient who is aware about those individual perceptions, they have no risk. While the patient who is not aware about those 4 independent variables, they have a high risk. So also the medications, we make a survey about the medications because the researchers saw that there is some medications is called a fall. So what's the difference between frailty? I told you, as even in my hospital, in the literature review, there is a positive relationship between the frailty and the high risk. So briefly, there is, when we run the binary logistic regression, there is a negative relationship. If the patient individual perception is high, then they have no risk because they know already about the severities of stability, barriers, and benefits. While the patient who is not aware about those fall, they have a high fall risk. This is the negative relationship we counted between them. So the strength, there is a valid and reliable instrument we used in our study, and we use more than like tools. And we informed the Saudi policymaker as they formulated the future fall risk intervention program. I run non-experimental studies because I want to study those individual perceptions in those elderly people. And then in the futures, I will provide experimental study with interventional program to see how can we decrease, I can say prevent, but decrease the fall during hospitalization. Limitation, respondent bias, because the patient, there is a self-report and social disability. Maybe the patient change their behavior or their answer based on the researcher. And generalizability, because it was in one hospital, only in Tabuk city in Saudi Arabia. And we studied the relationship, but we doesn't study the cause and effect relationship. So the importance to nursing and education, we need to educate a patient about the morsel skill, the health belief model skill and the frailty skill. And I have a plan that I will present it in the whole MSD hospitals in Saudi Arabia. And then we can start to implement it by 2024, inshallah, I hope. Because it's very important. Even me, I wasn't able to know that individual perception based on the health belief model is going to change the patient's behavior to decrease the fall during hospitalization. So the future research, this is quantitative. I'm thinking to do the qualitative research to know the lived experience of the patient who had a fall during hospitalizations. We need to increase the education session to know the social support between the individual, perception, frailty, and the fall risk, and development of fall risk screening instruments. So I do love nursing. And from bedside nurse to the authentic, transparent leader nurse, I will say I have a contact with Dr. Bam. She is the president of American Nurses Association the last 2 weeks, and she informed us, and she said that even in her article, and she said nurses must lead from wherever they are to shape a culture of health, like from the grassroots effort to the global alliance. Thank you for your attention. She's my dissertation chair in USA, Dr. Dana Henson, and thanks for her and all of my comments. Any question? To me, no questions is mean not a non-understanding. No question? Sure. It's your topic, Dr. Barba. I thought you are the one who's gonna ask me questions.
Well, your study is very much like mine. I think we found the same outcomes.
Yes.
Like I said yesterday, I just think that we need to do much more
On the prevention
to help people live, fall free.
Yes.
Nobody should die because they had a fall. It's just, in my book, unforgivable.
Yeah, I was shocked when my CNO, she reported her husband died because of cold. I was very shocked. I know it's the second leading cause of cold, but it's not it's really serious issues. And the patients need to know it's very serious issues, because if they know this, then they will change their behavior to avoid the fall risk. Anyway, thank you for everyone. Thank you.
You open it, and you open the device. I will open
Do you want the pointer?
it. Sorry?
Do you want pointer or extra?
Okay.
Sure.
And this is mouse. Look at mouse.
It's a pointer.
I've got
And extra.
mouse. I need to open my USB drive because it's locked. I need to open it now.
It's tight.
It's locked. I can give you password, but I need to open it.
This is our last presenter before we break for lunch. Please help me in welcoming Professor Rangelman from the UK.
We need the
Thank you.
questions, please.
You can stage.
But where is the caps left? Caps. Okay, now I can.
What's the presentation? This
Mhm,
one.
But give me mouse. Okay.
You have to open it.
How to use mouse?
More here. This one. Here's the presentation. This one.
No, I need to start. I need to
Okay,
start.
where's your
I need a
presentation?
mouse. I need mouse.
I
I
can
can
help.
mouse. I can mouse in my. We don't have any.
We don't have an extra mouse. We have the pointers. That's
But how? That's what we
just open your presentation, please.
Okay, I will do this now.
We kept hard drive.
Mhm.
So, is the main free module. You get recorded, you know, you get recorded. So it's not really learn how to. So we'll do.
Can you let me know your folder so that I can help you?
Yes.
Yeah.
Yes, perfect. Something like.
So.
Excuse me, can I help you, please?
Good.
So. Always be aware of the surroundings.
I think.
Is this
Yes, this one.
finally?
Yeah.
This one. Yes.
Only use one hand.
Yes. We can do it.
Yes, please open this.
Yes.
Just you need to click.
One click. Okay, let me.
Now put in full screen.
1 second. First screen. And next pointer, you can use the arrows.
Yeah, inside.
Okay. That's yours.
Thank you.
Do you need an extra microphone or
No,
not?
it's okay.
Perfect.
Take it.
Yeah, it's the
I'm ready. I'm ready. Hello, good morning. No, it's afternoon already. It's morning in the United Kingdom, but here it's afternoon. Good morning. My name is Len Gelman. I am professor of the University of Huddersfield, United Kingdom. More than welcome to be here. Thank you for inviting me. I worked in many years in the area of diagnostics, and it's covering, first of all, technical application. I work for high players like Rolls-Royce, like Boeing, and so on, for developing diagnostic technology. But another application for the same high-level technologies is to apply this high-level technology for healthcare. And this is my another, let's say, way of doing research. And I'm very pleased to be here and to present this second way of my research when I'm applying high-level technology which I developed, I with my colleagues developed for like Rolls-Royce, like Boeing, and so on, and applying for healthcare, because healthcare also needs digital novel technology. So this is like kind of introduction. We'll be happy to ask more. Right now, I'm going to present radically new technology. So it's radically new technology. Low, I will put like in red some important words: low cost, radiation free, and early automatic diagnosis of osteoporosis and bone fractures. So this is the, let's say, title of my presentation.
Yes.
Idea.
The opposite one. This one.
Can you give me the possibility to use here? Or how to just
You can speak and 4 minutes and they will.
I will do it by myself. Can you?
This one. Yes. Perfect.
Okay. I'll call to return.
This one. Start.
Okay. Yes. Okay. So no. So as you know, osteoporosis is a prevalent disease that occurs when bone mineral density and bone mass decrease. So it's a major source of bone fracture for women and older men, and it's of global importance, especially for aging population. So osteoporosis affects bone mineral density and makes bones be fragile. And fragility fracture common in osteoporotic patients. This fracture can be life-changing, painful, cause disability and independence loss. So the people number suffering from osteoporosis will increase by more than 2 times, according to study by Asian Federation of Osteoporosis Society. And as you know, osteoporosis is classified based on bone mineral density measurement by DEXA scan. It's like in the hospitals. But as you know, also maybe DEXA scans are very expensive and unfortunately not accurate. They require some kind of subjective view. They are not automatic and they're not doing early diagnosis of osteoporosis. So it's a lot of disadvantages. And also it's radiation, it's not radiation free. So, and as you know, World Health Organization defines osteoporosis as skeletal disorder characterized by compromised bone strength and increase of fracture. So therefore we have this technology which is doing both diagnosis of osteoporosis, which is like a root cause, and then you can have a fracture. This device simultaneously can diagnose fracture as well. So low bone mineral density becoming increasingly health concern. It's a lot of study between 1990 and 2019, and it's saying that its disability adjusted life years number will increase by more than 100% and 94% respectively in next 30-year period. It's a lot of study for Eastern Mediterranean, so it's a lot of different studies taken over. So now previous diagnostic studies have been conducted to address the increasing trend of osteoporosis within the population, and they study focus on relationship between osteoporosis and lifestyle, knowledge of osteoporosis and obesity, and indicate that effective diagnosis is needed to reduce osteoporosis and to make early treatment. Now we have one device, quantitative ultrasound, which is currently used instead of DEXA. But this device is not suitable for early osteoporosis diagnosis, for monitoring of osteoporosis healing process, and also is not working for bone fracture diagnosis. So this device has a lot of limitation, and it's created instead of DEXA, like in addition to DEXA, but it's a lot of limitations. So previous work are limited and mainly conservative estimating the resonance frequency of bones through finite element modeling. And this study also limited to ideal boundary conditions. They can be used to predict bone accident on like continuous vibration, and it's limited study. So when it comes to osteoporosis, little work has been reported that use vibration responses. Some studies in Greece done using vibration model damping, but this study are limited also to lab experiments only with rats, not with patients, and they not know any device today. Now we have one device which is vibrational spectroscopic technique, but it's very, very expensive and not accurate. So this is like state of the art, what we have today. So what is the aim of research which I am presenting? The aim of this research is to develop a new low-cost, non-invasive, safe technology and experimentally validate this for early diagnosis of osteoporosis and bone fracture. So again, 2 topics, osteoporosis and bone fracture. So separate 2 topics, and device which we're creating will be like working in 2 modes. One mode is to detect and to diagnose osteoporosis at early stage, and second mode to detect and diagnose bone fracture. So the technology is based on hypothesis supported by a solid theoretical foundation that osteoporosis and bone fracture induce additional nonlinear changes in vibration signal from bone. So again, we considering vibration signal from bones, such additional level of high spectrum resonance harmonics. So these changes are also time varying and require new transient signal processing technique and diagnosis technique to develop, and we develop this with this research. So the concept. So the main concept is that changes in bone quality and bone fracture affect vibrational characteristics of bone. This is the main concept, the main idea. Like I will show you some application, I will show some technology, but this is the main concept. Vibration signals from bone are affected by both osteoporosis and bone fracture. So we use this, let's say, concept by applying novel signal processing technique to vibration signal from bones, processing this signal and receiving diagnosis results. So the main scientific objective which we address, first of all, we develop finite element modeling of human bones and animal bones to study, because we need to have like theoretical background. We develop finite element modeling first. Now we develop novel condition monitoring technology based on signal processing of bone vibrations for monitoring, for healing, for characterizing healing process, and for quantification of osteoporosis and bone fracture severity. And also we experimentally validate through laboratory and clinical trials early diagnosis of osteoporosis and fracture. So now technology. So I discussed many, I put a lot of words, but now technology. So the nature of technology is to provide early diagnosis of both osteoporosis and bone fracture. It's low cost, automatic vibration clinical tool, and it's radiation free. It's very important, for example, for pregnant women, very important, radiation free. Also for children, very important. So they do not need to go through Texas country to go through this technology. So it's based on theoretical background that osteoporosis and bone fracture create additional level of nonlinearity of vibration signals. And this is the novel research approach. And what we are doing, we excite, we need to put excitation. We excite bone resonance oscillation. How to excite, I will explain. So we exciting, putting safe, low intensity excitation on bone. Like, you know, neurologists, the neurologists, let's say, tested you, they put like, they use a hammer and they like slightly excite your bone and they like, let's say, testing you, but it's neurological testing. But here we also employ excitation, low level safe excitation to excite, and then we receive response. When we excite, we receive response from bone and we process this response. This is the nature of this technology concept. So we have excitation and then we use response and we process response and then we receive diagnosis. So it's really technology which is expected to have a potentially transformative wide impact as it lies the foundation in understanding of nonlinear bone vibration response and associated mechanism of bone degradation, which can be extended to other bone disease. So, like it's like a direction. In this direction, we can do now osteoporosis bone fracture, but later on, I believe that this technology could be expanded to. Therefore, we're saying that it's like potentially transformative, wider impact. So the technology employed novel non-stationary high-order spectral correlation is like special technique, which I propose and develop together with my colleagues. And we can do, let's say, three things. We can do diagnostics, early diagnostics, quantify damage severity, is very important. And also to see a healing process. So these three, like 3 in 1. So this novel spectral correlation technique are definitely potentially also transformative, and they present a new nonlinear non-stationary concept, and therefore make major influence. So it's all this related to technology are really transformative. So now technology is based on estimation of nonlinear time varying vibration behavior of bone with osteoporosis and bone fracture. And first of all, we need to detect bone resonance area. Once we detect bone resonance area, then we excite in this resonance area, we excite bone, and then we receive resonance response. So we use 3 types of excitation. We use swept sign excitation first, go through all frequency ranges and to find resonances, excite resonances of the bone, and to receive response. First. Second, impact, low frequency and low level impact, using not hammer, we are not using hammer, we are using shaker. Portable shaker, which is much better because portable shaker will give you control of excitation. If you use hammer, it's in your hand. You can do more, less excitation, but if you have a shaker, you have everything is controlled and you can do really safe, low level excitation. And finally, we have third type. So we use in this device, we use 3 types of this, let's say, diagnosis very reliable because we use 3 types of excitation and we receive results for all these 3 types of excitation. Then we make the final total decision based on these 3 types of excitation. First, web-sign excitation with varying frequency range to see bone resonance area. Second, impact excitation, and third, white noise excitation. So all these 3 working well in order to detect both. And this is a schematic what we propose. So you can see this for tibia, like schematic for other bone, it will be the same. So what we have here? We have here excitation actuator. It could be actuator or it could be portable shaker. And you can see we have here 1, 2, 3, 4. We have 4 small vibration sensors, accelerometer. Very small. They are attached to a bone. Here you can see 1, 2, 3, 4 accelerometer attached to the bone. And then what we are doing excitation, and then we capture using this 4 sensors, we capture response, and this response is going to laptop, and in laptop we do signal processing and we making a decision and monitoring, and we see results almost in real time, So this is a schematic, and the setup consists of multiple actuators, and told or mini shaker or electric actuator, and then we have this generator, and we have 4 accelerometers firmly connected. It should be connected with preload. What the problem we have? The problem which we have is soft tissue. Soft tissue, this is a slight problem in this technology. In order to address this soft tissue, we need to put this accelerometer on board with preload. When we put the preload, this will be firm connection and it will address issue related to soft tissue. So signal obtained through electronics interface and so on will be processed in real time and will receive diagnosis results. So software, we have signal processing, artificial intelligence to diagnose, and the main signal processing technique, novel chip-free transform, high-order spectral technique, novel violet high. This is it for sweat sign excitation. This is it for novel violet high-order spectral technique for impact excitation, and novel Fourier-based technique for white noise excitation. So we have 3 types of excitation, as I mentioned, and we have 3 types of different, very effective technique which processing results from these 3 types of excitation. If you have any question regarding this signal process, I will give you maybe more insight and what to discuss in general. So the main technology is the following: excite resonance oscillation, excite bone resonance oscillation impact, excite resonance oscillation by sweat sign, excite bone resonance oscillation by white noise. So 3 types of excitation. All 3 types will excite bone resonance oscillation, and then in area of this resonance oscillation, we process data and we receive diagnostic results. So now, as you know, we have history. I already mentioned it. Neurologists using this reflex hammer. It was since 1875 to use, let's say, to test neurological tests. And this is done by creating a stimulus using a hammer and observing the reaction. So we are using exactly the same principle. That's for diagnostic purposes of osteoporosis and bone fracture. So we are using stimulus, but not by hammer. We're using portable shaker, small shaker, which is very safe and very controlled. And then we receive a reaction and we process this reaction. So as we discussed, the technology using fully controlled by shaker, because shaker is controlled by controller. A controller, we control the controller. We put a specific level of excitation, and shaker will do exactly this level of excitation. You cannot achieve it by using hammer. Hammer is your hand. Your hand today using one way, another day you use another way. But here it's automatic and done. It's fully controlled by a shaker controller, low level, which is very much safe for patient. And it's not invasive and radiation free, as already mentioned. So now, what is the outcome of this research? What we did? First of all, technology. It's radically new, which revolutionized osteoporosis and bone fracture diagnosis.
in the healthcare sector. New bone fracture model, it's very important. Again, it's like a transformational issue which can help to develop future diagnostic devices for bone. And novel field of hospitality and artificial intelligence. The proposed technology aligns with World Health Organization, and technology will be accessible for more healthcare workers, enabling early diagnosis. Because if you do early diagnosis, what does it mean? You can start early treatment. This is very important because if you have late diagnosis, you will make late treatment. It's not good for patient. But I will tell more about impact. So now, I still have time, yes? Thank you. So last few slides, impact. What is the impact? The main scientific impact is creation of radically new bone monitoring technology. This is the scientific part. What is the, let's say, impact for healthcare? First of all, reducing emergency X-ray. For example, if you go into car accident, you cannot go with X-ray machine. You cannot go. But when you have car accident, you need to see, do we have in car accident, do we have bone fracture or we have minor sprain? So if you go with this device, you can do diagnosis on time of and place of accident. Of course, if it's in war condition, if you have war condition, is also a possibility to use this because sometimes you need to understand what is the difference between sprain and bone fracture. But it's related to bone fracture. Now, X-ray bone diagnosis, ensuring that bone diagnosis is easy and easy to access. Maybe you know from your practical experience that sometimes X-ray not giving you early diagnosis even for bone fracture. For example, in food, not giving you, if you have kind of stress fracture, it's not giving you early indication, but this device can give it. So enable approaching life to be cared at home. It's very important because we need to reduce admission to hospital. If it's needed, of course, we need to have admission to hospital, but in general, we need to reduce admission to hospital. Improving access to urgent bone diagnosis outside hospital. It's very important because this device can be used by not only by doctors, it can be used by paramedics, by nurse. So it's very simple. It's very easy to use. So paramedics can go to home, especially for elderly people, and make the diagnosis. So for children, for pregnant women, and monitoring bone healing, it's very important to have understanding of bone healing and enable the patient to be quickly informed about recovery. It's also very important how processes of recovery is going on. And finally, reducing hospital admission and associated costs. The technology will be easily reached by the patient community, and this is good for countries with limited access to expensive laboratories or current technologies. So this is the end of my presentation. Thank you for your attention. Thank you.
I wish I had known you 3 years ago. I have terrible osteoporosis. I fell playing. Do you all know the game pickleball? It's like tennis with a net. Yeah. And I stumbled running toward the net. And in my head, I said, don't grab the net. Don't grab the net. Grab the net. I hyperextended both shoulders and broke both my arms.
Oh, dear. Oh, I'm sorry. Yeah.
Yeah. So I wish I had known you then. I didn't know I had osteoporosis until then, and now I have a horrible story. So
thank you. I will be happy to answer any questions. Thank you.
Thank you, Professor. Your speech really interesting. It's a really interesting topic, actually. I just want to have one question. It's about the sensitivity English is not some first language somehow. So I just curious. I'm just curious about the sensitivity and specificity of this technology.
Yes, it's very important question. Thank you very much for your very good question. So I would like to tell you that we achieve sensitivity, which normally we measure sensitivity. For example, if you consider bone fracture. we measure sensitivity not in absolute value. We measure, for example, if you have a crack, you have in bone, you have a crack. You measure this crack in the relative values, because absolute value will not give it. For small bone, small crack is a big. For big bone, small. So it means measuring absolute value is no sense. So sensitivity, for example, to bone fracture is around 5 to 8% the relative crack size, which is really early stage of damage development. Really early stage of development. And the same we have for this reducing of bone mineral density. You have around 5 to 10% this, let's say, diagnosis, early diagnosis. So as I mentioned several times, we're doing early damage diagnosis and early osteoporosis. Why? Because it's going, it's not traditional technique. We are not going like simple like always using the common technique. We're going radically new technology in signal processing, which providing early stage. Therefore, your question is really very important. Take a fast question. This is what we achieve in this technique. And we achieve this for Rolls-Royce engine and for Boeing aircraft. I received 2 Rolls-Royce awards for innovation for developing similar, not the same, similar technique for also because if you have, I don't give that inside in, let's say, aircraft engine. If you have aircraft engine, in aircraft engine you have small blades, small rotating blades. And these small rotating blades, if you have a small crack, it's very usual to have a small cracks. And this small crack could create accident in air because due to this small crack, engine could stop and it could be accident. So we developed this technology to effectively diagnose at early stages small cracks in blades. And we apply again not one-to-one, but we apply a lot of principles which we developed for Rolls-Royce engine. We apply here because you have also involved, we also have a crack and behavior not exactly the same, but very similar. So therefore, we're detecting these cracks like we detected in the Rolls-Royce engine and Boeing aircraft. Thank you.
Hello.
Yeah, come on. Hello.
That's good talk.
Thank you.
Really enjoyed that.
Thank you.
I have a question. So I think from what I can gather, it's not painful to put these things on.
It's very important. You are right. It's not painful, it's safe.
Excellent.
But
But
from 1875, you already use it.
yeah, so like,
Yes. So bring that.
no, that's fine. So when you put these on, you said that one day maybe nurses and paramedics and whatnot can use these things, to check for early fractures and whatnot. So when you put these on, you've got a fracture already and there's already pain there. What's the threshold of how much collaboration you would use? Is it supposed to be a level? Maybe it goes up in levels.
Well, as I think it's very important question is related to safety. What you ask me related to safety. Of course, if patient has pain, we can also make kind of adaptation. Because if no pain, we can have in this device, we have 3 different levels of excitation.
Okay.
So when we have a pain, we go into the lowest level of excitation. But all these 3 levels are safe.
Okay.
So, but still, if the patient has pain, it's better to use the lowest level.
Yeah.
But all this, therefore, we just before doing this diagnosis, we just to make kind of keep the glass some patient like pain or pain and so on.
Yeah.
It's very important. But what is the most important is we place some study which not finishing and not the device using hammer. But we place hammer because hammer has a lot of requirements. First of all, it's your hand. That's what I mentioned already. It's your hand. Today you have today in good shape, you create low level today. Tomorrow you're hungry and create like which is dangerous. But when we have a shaker, we are not even on the shaker. We have a shaker and we shaker is run by controller. The controller is installed level of excitation, within the range. And everything we install will be going to the shaker, so we are 100% sure that we safe controls and very good for it.
But would the pain and the injury caused in time to response, which then would cause edema and swelling, that affect senses as well? If swelling is there and whatnot, would that affect?
Well, as I told you, yes, feeling affect, and the most important, like I'm trying to say in general, like soft tissue.
Yeah.
Soft tissue affected, but as I told you, we have, it's not my invention, it's invention which already exists in the picture. And it's some pictures of the center is real low. And we do by spring, by simple spring, it is the low, and you can attach stringly. It's attached stringly, it's minimal effect on this combination. Of course, you are right. If you have swelling, it's very good issue to primary explanation. If you have swelling, it's like additional, additional problem. Maybe sometimes we have, let's say, a severe swelling, maybe it would be affecting this device. But no, we are looking for early stage, sometimes in early stage of yes, it's very good. It will be additional issue which we will address, but in general, soft issue will be addressed by this period.
Excellent, thank you.
Thank you very much. Thank you for your very good question. Thank you.
Thank you, Dr. Gilman.
Again, can you put in this one? And I would like to thank you very much, and especially to thank organizers for inviting. Thank you.
Dr. Gilman. I have a certificate for you here. Ladies and gentlemen, before we begin lunch, if everybody would move downstairs in front of the gem garden, do another group photo. Thank you. I just want to add one thing. As even I had a speech about I had a speech about rehabilitation. I just want to say that I'm proud of the hospital in which I'm working because they made an excellent progression and effort, and they got because of the distinguished effort from the different medical staff, especially the nurses. They did a very great effort. Now we are accredited for the commitment of the rehabilitation accreditation of the rehabilitation hospital. We were accredited for all our departments in the hospital. So I just want to say thank you very much for our medical staff.
Thank you.
Thank you. Dr. Chakra, I have another certificate for Dr. Chakra. I was negligent. I did not.
Dr. Hall?
Dr. Chakra? No. Oh, okay. Okay, if everybody would mind, we'll go downstairs and photo. I'll present this to Dr. Chakra when we get back.
I think so. It's 10 invitations. So
Still, I would really how you can try to make. No.
proceed.
Yes, you're gonna live there. It's not gonna be staying. You can't give me that excuse. Sorry, but that's just ridiculous. You're not lying. I don't know. Last night was good. We all went out. We did go out. We went to the Bible and it was eventful. Yeah. Yes. Yes. Are you sure?
يكون أفضل لأن مو خلك اللي بينس خلك اللي بيقول.
Okay. Good afternoon, everyone. I hope you enjoyed your lunch and came, energized for the rest of the day. I am, you already maybe know me from my previous presentation. My name is Nagam Abu Shakra, and I am from Jordan. I will be chairing this session in the afternoon. And I am happy to introduce the first speaker, Ms. Nofil Aklabi from Ministry of Health. She will be talking about evaluation of public health education and practice from the perspective of public health academician, postgraduate student, and alumni in Saudi Arabia. Join me to welcome Ms. Nofil. The floor is yours. And for those who are with us online, please, if you have a question, write them in the chat box.
Thank you, dear, for the introduction. I know it's the hardest time to present after the lunchtime, but bear with me, I will be quick. Thank you for the organization, USG, for inviting me, and special thanks for dear Amal for helping me and support me all the time. So I will present my thesis in master. So when I started my master degree, I have this thought that in Saudi Arabia, especially in Riyadh, there is 3 universities that provide public health programs master degree. So I wonder with myself, what the other university will provide. So the idea came to me, and this is the master degree for this simple idea. So my topic is about evaluation of public health education and practice from a comprehensive level. So I included the academicians, alumni, and students in Saudi Arabia. Maybe I can use this. So this is the content I will cover, the rationale of the study, including the aim and objectives. Also, we will go through the methods and the study area and study design and the participants' characteristics. And we will go through the results. My study is a qualitative study. So I did interviews with the leaderships, academicians, and students and alumni. And I will conclude my presentation with some recommendations. So for rationale, as you see around you, public health initiatives help to reduce the mortality and morbidity worldwide. So according to the Saudi Vision 2030, there's a lot of strategics and national initiatives that intersect with the public health goals, such as increasing the life expectancy, also improving the health determinants, and building health cities. Therefore, there is a high demand for a public health graduates that will train and have a good background to help to carry on the initiatives and implementing the strategies. So the aim and objectives of the study, the research aimed to evaluate the public health education and practice from a comprehensive level. So I included the leaderships, academicians, and postgraduate students in my study. So for the faculty and leadership, we want to identify their perspectives of meeting the components of the curriculum of the public health. And for the current students, we want to see their viewpoints about the education programs that they enrolled in. And for the alumni, we want to investigate the impact of, after they earning the degree, what is the impact on their career advancement. So for the methods, the study design were an explanatory, phenomenological, qualitative method conducted through in-depth one-to-one interviews. The sampling technique, I used the snowball sampling to reach out to the participants. So I contacted them to the social media platforms such as WhatsApp, LinkedIn, email, and Telegram. For the data collection methods, I used a semi-structured open-ended questionnaire, which collected from the literature and adapted with my professor to the local context. So for the analysis, we developed analytical themes to interpreting the qualitative data by using deduce. And for the ethical concentration, of course, we obtained the IRB approval, and also we ensure the anonymity of the participants. And for the data management, most of the interviews were conducting virtually because I did this research during 2021. During the COVID pandemic, so the most of the interviews were conducted virtually, and few of them were in person. So the study area, we have King Saud University, which is providing a master in health promotion and education, which is one of the one of the aspects of public health, and also we have Al Faisal University, providing 3 majors in public health, such as mass gathering health, which is used for Al-Hajj and Umrah. And also we have biostatistic and epidemiology and health policy. And for King Saud bin Abdulaziz for health science, which my university, which provide the 3 tracks, master in public health and biostatistic and epidemiology and health system management. So as you can see here, we have the sample size. The total were 39 participants, 20 of them were students, 12 of them were alumni, and 3 were faculty members, and 4 of them were leaderships who were program directors. So the results. Here, the participants' characteristics, which is the sub-majors they enrolled in public health. As you can see here, the highest numbers were from the biostatistic, epidemiology, health system and management, and health promotion and education, and the least of them were from health policy. Here, the backgrounds of the students before seeking a public health degree. So as you can see here, most of them, maybe the pointer is not working. No, I don't think. But as you can see here, we have public health specialists and health educators were the most of the students and alumni. The background of them were public health and health educator. As you can see, we have a diversity of specialties, but the most of them were public health and health education. Here, the participants' organization, most of the students and alumni were already working with the Ministry of Health. As you can see here, we have the current students and MBH holders. Most of them were working with the Ministry of Health, and the least were working with the private sector. Here, the qualifications of the faculty and leadership. It's their experience in teaching public health in Saudi Arabia. Most of them have experience teaching public health abroad, but I precisely focus on their teaching in Saudi Arabia. So it varies from 2 years up to 15 years of teaching public health. Here, the themes and sub-themes emerging after interviewing the students. First of all, I want to see their motivation of studying public health. So most of them, as we all, seeking a good opportunities and seeking a promotion in our job. So most of them were seeking promotion and career opportunities, and a few of them were motivated to work with the community and leave the clinical fields. And for the downside of the sub-themes, the Saudi Commission for Health Specialties restrictions the students' preferred majors. So if I'm a health educator, I only have choice to continue my master in public health. So this is limit the students' choices. So they choose public health as a master. So for the themes, the other themes is the availability and facilities provided to the student. I want to see the support they have from their universities. So the majority faced a shortage of technical supports, such as providing SPSS to analyze data. And although it was conducted in COVID-19 pandemic, but most of them received the support they need after contacting their professors and the university itself. And one of the major themes that appeared in one of the university is King Saud University. There's the policy in the university, they have segregation between females and males students. So females thinks, the students claimed that they think that there's a favoritism for males over females regarding that the grades and the exams. And for the final themes that emerge, I want to see their point of view about the content of the curriculum. There was a conflict opinion. People who have public health background, they thought that it's repetitive and they don't have any upgrade for their knowledge. But those who have different background, such as medicine, pharmacist, other specialties, they think that this public health program is beneficial and they gain a very good knowledge from it. So it's a little bit tricky. Here is the alumni responses. I want to investigate the careers advancement. Thankfully, most of them received promotion and they received opportunities regarding their career advancement. And for the knowledge applicability, one of the themes that I want to investigate, if they were able to apply their knowledge after obtaining the master. And most of them were agreed that they have the opportunities to implement the research skills that obtained. And as a positive opinion, the public health master is aligned with the Saudi Vision 2030. And those who have a downside and negative opinion, they didn't have the certificate from certificate classification from the Saudi Commission for Health Specialties, and that leads they remain in the clinical field and they didn't apply their knowledge. This is common themes emerged among students and alumni across the university. They lack time management because they were working and studying at the same time. Also, the organization approval, few of them faced a challenge to obtain the approval from their organization. And also those who have background, those who have different background than public health, they faced a challenge to understand biostatistic and epidemiology courses. And for accessing to national data, all of them agreed that they lack the access to national data regarding their research purposes. So they didn't have any support providing them with national data. And for the counseling regarding career, they lack the counseling to prepare them to the work environment after they graduate. So, and there's an emerging theme, which is the lack of field experience. except for Al Faisal University, they already have a practicum courses that provided the students to apply their knowledge during the study. Here, the faculty and leadership responses. I want to ask them about the student commitment. And unfortunately, they claimed that the students were poorly committed because it's a full-time program for a part-time students. And the students' educational background limit the students' performance, and those who have public health background, they usually do better than those who haven't. So, and for the research budget and assistance, there is a shortage for research financial and support from the institution itself and outside. And for public health majors, there were a lack of diversity. As you can see, I present you the universities that are providing public health degrees, and you see it's limited for a whole country. So, and for the last one, about public health during COVID-19, most of them agree that the public health pandemic and virtual education, it impact the quality of the education. So it's limit the education to somehow, they agreed that it's impacting the quality of the education. For conclusion, finally, we arrive here. So as I mentioned before, the emerging themes were lacking of field practice, limited facilities and resources, and lack of recognition from the Saudi Health Commission. So it's very hard for the students to study a whole 2 years, and then they don't have the opportunity to apply their knowledge. So it's a waste of time for them. And also the shortage of research and finance and assistance. But regardless, the leadership and faculty and alumni, the participant whole, acknowledge the importance of the public health profession and its alignment with Saudi 2030 vision. For recommendation, of course, we recommend increase the practicum courses and community involvement, and also provide opportunities for research and access to the national databases, engaging the community with the program through partnerships, and also open summer courses for the students and collaborations with public and private sectors, and provide allocation of large budget for public health practice. As you know, public health in general didn't receive that amount of finance comparing to healthcare. It's a little bit confusing, because public health you will implement and maintain a health for a long time and prevent people to get sick. So as a final, my study was a qualitative study. There is a need to further investigation. It's the first kind of study to done like this, qualitative, and sit with the leadership and with the students. And we need a further investigation to understand more about the impact of quality of education on the practice of public health. And this is my LinkedIn profile. And if you have any questions, I'm ready to do it.
Thank you so much for the presentation and for sticking to time. Do you have any questions?
Thank you, Dino.
Thank you.
Thank you for the valuable and informative information you have provided. I'm public health expert as well. I would say, as you have conducted a qualitative study, it should be great work. I don't have a question, just comment.
Thank you.
Please focus on public health.
Yeah, please do.
As COVID gave us like alarm.
Yeah.
We're here. So please, as you mentioned earlier, focus on public health as nurses, radiologists, etc.
Hi, hello. Could you know for your wonderful speech about topic? Yeah, I just have comments about that because as I discussed in my presentation, and I emphasize our colleagues that we need to focus on public health. And I think my call would be like because public health and preventive medicine is very important to our healthcare systems. And I think making your research as an evaluation. So the only way is to improve and focus on public health is try to raise the awareness from the graduates, from the alumni, and they start because they are the only one who they are already in the field. They already studied, they know the importance of the programs of the public health and the implementation of our healthcare system. So I think this is our goal, and this is the goal for people like you, the health professionals, to try to speak out about the importance of the public health and try to take a step forward, take initiatives to improve certain aspects in public health because we have a huge domain in public health. So this is my recommendation and advice, and thank you so much.
Thank you.
Any more questions? Thank you so much. Our next speaker is the Mr. Faisal Al-Utaibi from Saudi Arabia. He will be talking about Saudi Arabia's safe nurse staffing from table to implementation. Welcome, and the floor is yours.
Assalamu alaikum. Good afternoon. First, I would like to thank the organizing committee for having us in this wonderful conference. My name is Faisal Al-Utaibi. I'm a specialist at Saudi Patient Safety Center, and I graduated from University of Nottingham with a quality and patient safety improvement master degree. I'm a certified professional in healthcare quality by National Association for Healthcare Quality. I'm certified also in a KPI professional from Institute of KPI. So during this session, I will be talking about Saudi Arabia safe nursing staffing from table to the implementation, which I believe it's considered as a success story by doing a joint effort and collaboration between all the health care entities that will lead to address a global and national issue to the patient safety. So during my time, I will be talking first about the nurse staffing level and how it affects the quality of healthcare. And then I will be talking specifically about the issue in Saudi Arabia, and then by providing some best practices that we align with. And we will talk about the project from the Saudi Patient Safety Center, which was led by the Saudi Patient Safety Center while joining by other entities. And then we will provide you the result that we have reached to, and then what is going to happen next. So first, I couldn't stress more enough than what you have already discussed during the 2 days about the role of nursing in the healthcare system. Speaking about they are in the core of the healthcare system in every setting. They are getting involved. They are the first one who get encountered with patients. So they are in a place where they can raise any safety threats, can prevent any error, can notify us, and even if we have an issue in the bullet end, we can stop it by a nurse as a good catch. So they are in good place to try to invest in patient safety. So shortage of nursing could lead to lower staffing, increase of use of temporary staff or overtime staff, which will cause a problem to the cost. So we try to decrease this nursing staffing by an aim to saving a cost. However, sometimes we rely on the temporary staff and overtime staff. So nurse staffing level could be measured by two ways, either nursing to patient ratio. Basically, we calculate the nursing number divided by the patient or room occupied by patient during either shift or 24 hours. The nursing hour per patient days, it's calculated by either the number of nursing hours during a shift or a 24 hours divided by the patient bed days for the same period. A huge amount of evidence that is linking or the association between the adverse event and death related to the staffing level. Looking at the negative side, we can say that lower staffing level could be associated with a higher rate of death, and also lower staffing in nursing could lead to higher rate of failure to risk a patient. Lower staffing level associated with a more missed care. However, missed care cannot be measured. It's only relying on the reported cases of missed care. And even a couple of studies has been conducted to link the linkage between the missed care cases and lower staffing level. Looking at the bright side, when people have appropriate staffing level in nursing, that could reduce the central line associated bloodstream infection, the CLABSI. And we know by evidence that 1,000 cases of CLABSI could lead to 150 deaths. So by reducing CLABSI, indirectly, we reduce a death. Appropriate staffing level in nursing could reduce a patient fall. And by the evidence, 1,000 case of fall, it will lead to 50 case of death. And so indirectly, we are trying to reduce the death cases or the death rate by having appropriate and adequate nursing level. The same with the pressure ulcer. Again, by evidence, a lot of literature has been conducted by increasing the staffing level in nursing that lead to reduce the pressure ulcer. It's also decreased the mortality rate or the mortality within 30-day admission. So we have an issue, we have to create an intervention that will lead to improve the patient safety by addressing this issue. So the California Nurses Association start to lobbying for mandating nursing to patient ratio in 1992, and this legislation has taken place and was introduced in 1999. However, it started implementation in 2004, and this is the first legislation around the world that is mandating the safe minimum staffing level in nursing to assure patient safety. In 2001, the legislation introduced in Victoria, Australia, to mandate nursing to patient ratio. And in Scotland, in the UK, they try to introduce their staffing level act, which is only about a recommendation, taking care about the process and system of staffing plan. Not exactly, they are setting a numbers that people should comply to. Looking at the issue from the national context, do we have the problem in Saudi Arabia? Unfortunately, we don't have enough data to say that we're having a problem or we are not aligned with everyone, but we are relying on two sources of data. First, the patient safety culture survey, we are the one who is measuring it, and we have the sentinel event that's reported to the Saudi Patient Safety Center. Starting with Saudi Patient Safety Center, it was first reported to the Saudi Central Board of Accreditation for Healthcare Accreditation. So Sibahi was responsible to get all the sentinel event reports and analyze it and start to initiate national priority. So by reviewing the report from 2012 to 2015, we found that 22% of the sentinel event was caused by shortage of staff. Again, the same analysis was conducted from 2016 to 2019, and we found that 32% of the issue was related to staffing. So again, from 2020, we were responsible about the Sentinel event. However, we didn't analyze the data in a way because it's like a short data. However, we try to make a correlation between the result of the patient safety culture and the result of the Sentinel event. And we found that the patient safety overall grade was influenced by staffing. So people who grade their hospital as a poor, fair, good, they all, like in the Sentinel event, they have an issue with staffing. The same with people that are not reporting patient safety event, they have a similar problem with staffing. For the first 3 measurement cycle, and Dr. Badr will talk about more about the patient safety culture. However, for the first 3 cycles, we found that staffing is one of the lowest domain in the safety culture in the national level. So this is stressing on the point that we have an issue locally as well as globally in terms of nurse staffing that need to be addressed, and we need a strategic intervention to address this issue. And by Ms. Noof, she speak about the Vision 2030, and we know that in the healthcare system in Saudi Arabia, we have a vision. We have 4 objectives. One of them, and the most important one, is improving the quality of services. So what kind of initiative that we should create or start making that will lead to progress in this objective? So here where Saudi Patient Safety Center take the lead and try to start creating urgency as a way of changing management. So we try to create urgency for this issue to be addressed because it will result in a promotion of patient safety. We try to review the best practices, and our aim is to establishing a framework on how to create a staffing in nursing that will promote patient safety. First, we were influenced by the 2 position statement that was released by the International Council of Nursing. One is talking about patient safety, and they are stressing about staffing level. It could be an intervention that will lead to promotion of patient safety. Another one is evidence-based staffing level, and they're relying on California intervention. So we try to collaborate with them, taking their recommendation and do it on the national basis. So again, we created a task force team locally to start seeing what is the recommended nurse to patient ratio, and to see, is it doable, visible, according to our resources, is not taking the recommendation and to try to apply it. Try to studying the context that we're trying to apply to. So we try to get representative from each entity. We're speaking about Sibahi, the Saudi Commission from Health Specialty, speaking about from the healthcare facility itself, from Ministry of Health or Ministry of Defense, and all sector was collaborating together to address an important issue in the patient safety. So on the occasion of in 2019, on the occasion of the 4th Global Ministerial Summit of Patient Safety, which was held in Jeddah, Saudi Arabia, so we released the first white paper, nurse staffing level for patient safety and workforce safety. So it's not only about patient safety. If you address this issue, it will lead to another gains, which is workforce safety. So we publish it as the only recommendation. This is the recommended staffing level. We don't enforce anyone to start applying it. We are reviewing the best practices. We try to summarize it, discuss it to you, and give you the recommended nurse to patient ratio. After that, we didn't stop. However, this is the white paper. You can access it through the SPSC website and through the ICN, the International Council of Nursing. You can find it. Also, this is an example of the nursing. Mostly, it's relying on California work and the MOH report, and recommended by the task force team and the ICN. So then we didn't stop. In 2020, we start to work nationally with different entities, Sibahi, Saudi Commission for Health Specialties, and Saudi Nurses Association. We try to make it more than a recommendation. So we come up with another white paper. It's called Safe Staffing Nurse Midwife. We include the midwife here to patient ratios, guideline for regulatory decision making within a Kingdom of Saudi Arabia. So we move from a recommendation to a guideline. You can rely on this guideline when you are doing nurse staffing plan. Again, this is include the midwives, how nurse, administrator, or executive should be part in the board and being advocate for the staffing level and trying to get the budget for the staffing and building the staffing plan based on the needs, not on the budget that is allocated for them. Here, we like elaborating more and being more specific in the domain. If you compare it to the one before, here we just combine together the medical and surgical. And in the version 2 or the second one, we try to segregate the adult medical unit, adult surgical unit, a pediatric medical unit. And so we trying to elaborate more to become a guideline that healthcare facility will rely on. Here is just all of these nurse and midwives to patient ratio. And is not about only recommendation and guidelines. We are trying to make it as a practice, try to creating a system. So these recommendation, this guideline was supported and endorsed by CBAHI. So for the people who doesn't know, in Saudi Arabia, CBAHI is a mandatory. The standard of CBAHI, people should comply to, is necessary. So these recommendation and guideline get the support and the endorsement from CBAHI. And now they are trying to prepare to release the 4th edition of CBAHI standard, and they send it for field review for entities and healthcare facility. And now we find a chapter that wasn't exist before, which is safe staffing level. So all hospital now is required to comply to the standard by assuring they are having the safe staffing level. So from a table, that's something interested that we think that will make a progress toward our objective, which is improving quality. Now it's becoming a system and becoming a standard, which will be released soon within a couple of months. People will try to put a budget to get the accreditation and trying to hire more staff and skilled nursing for complying to this standard. And the whole chapter was relying on this guideline. What the Saudi Patient Safety Center is planning to do correlation study or investigation between the Association of Nursing staffing level for those hospitals will comply with the standard, and for those who submitted our sentinel event and adverse event. Again, we're trying to unify the patient safety indicator like fall, ulcer, hospital acquired infection, VTE. So once we unify between all the healthcare sector, we're gonna have the data. We can study the correlation or association between the nurse staffing for those either comply to the standard or doesn't comply to the standard with their data as an adverse event or the patient safety indicator. Here is my references, and by this I conclude my presentation.
Thank you so much for the presentation. We have a couple of questions.
Thank you so much for this presentation. Are you ready to do any correlation studies between staffing level and competencies or required skills?
Even in these 2 white papers, we didn't come across like in deep about competencies or the skills of nursing. We're talking about a number. Further, we're gonna, of course, focusing on competencies.
And how so many numbers now? They are not will not do the same.
Sure. Even if you go to the SPC website and read those white paper, it's just touching a little bit about the competencies, the skills of nursing, the education. But however, we another white paper or recommendation about the competencies. You're welcome.
We have another question.
Hello.
Hi.
That was a great presentation. Really appreciate it. And I think that it's a real eye-opener, you know, with how things are with the staffing levels and how you're trying to integrate change and trying to make it better and finding ways to do that. Do you think that when within healthcare that I've come across, when trying to implement change is not an easy thing to do?
Yeah.
And do you think you'll get many
resistance?
Well, that's one word. Challenges, difficulties in trying to implement that change, or do you think you'll have more people that are on board with this change, and more people recognize that this is what needs to be done, or not so?
Well, talking nationally, there was a collaboration and everyone is welcoming, because everyone like CBAHI, Saudi Patient Safety, Saudi Commission for Health Specialty, we all accountable to achieve the second goal of the transformation or the vision of Saudi Arabia. So everyone wanted to do our progress or to be part of this intervention, talking about the entities. So everyone is welcoming and buying in for this intervention. However, when we apply it as a standard, still it doesn't go for being a standard. We will find a resistance, challenging of financial challenges from the facility. They don't have enough budget to hire more staff to achieve this. However, we didn't reach to this standard to be complied fully by healthcare facility. However, there was a huge collaboration between all the entities. Everyone want to be a part of this progress in this goal and promoting patient safety and addressing a critical issue. But I believe, from my opinion, there will be a challenging to comply to this standard.
I have every faith. Good luck.
Thank you. You guys sound very interesting. So, but I have one question. Do you think this will affect the equality of nursing? Because they will get more number just of what kind of issue?
Again, what I'm afraid of is that we're bringing nurses just to fulfill the standard, regardless of their competencies, quality of nursing. However, by a default, Sibahi in their 3rd edition, they have a couple of standards in the nursing chapter talking about the competencies of nursing. So we have it already by default, regardless, we don't have it as a chapter for the competency of nursing. We still have a 3.3 standards talking about the competency of nursing. So the people or hospitals should be compliant to those standards before we're talking about the staffing level. Now we are having a designated chapter for the staffing level of nursing. I didn't read it, to be honest, but I see this the table there, and I see it as a chapter in the table of context. It might be first talking about the competency, or they leave it in the same in the nursing chapter. This is still an issue. Yes, we believe it, but now we're addressing an issue, and it's talking about the white paper about the skill mix and competency of nurses. However, it's not included in the standard in safe staffing level because it's only talking about the level, the ratio. But in the nursing chapter, before and now, they are having some standard hospital need to be compliant to. You're welcome.
Sorry. There's a statistics that show in the USA by 2025 is going to be like 148,000 shortage of the staff. Is there Saudi like statistics official and nurses Saudi staff by like if you short 2025, 2030, for example? That's the first question. The second question is the nurse to patient ratio. We just create like acuity tool in our hospital project to identify like the criteria. How will identify these nurses will hold 1 or 2 or 3 patients based on the patient condition? The third questions, did you work on the workforce like staffing strategic plan in the future for the Saudi like staffing nurses in Saudi Arabia?
You mean those task group?
Yes.
I wasn't involved. Okay. For the first question, yes, we know that by the Saudi Health Council, they released a paper about the current status. It gives the expenditure, the resources that we have, what we are afraid of in the future. Of course, the population is going to increase, and we need to set something in the as overcoming the coming issue that we will face it in the future. We know the resources that we have it. They measured number of nurses to 1,000 population. Maybe this is near to the statistic that the people in the US rely on by saying on 2025, we will have an issue with the nursing because you will consider it on the increase of the population. So we have a paper from the Saudi Health Council talking about the current status and the resources that we have it. So why are we addressing this? Because we are assuming in the future something will happen. Again, this standard is updated every 3 years. Again, if we see an increase in the population and these are not a safe staffing level, we're gonna have another safe staffing level to address the issue that we have.
Some criteria?
Yeah, of course, there is a patient factor, a nursing factor, different factor, but I don't have time to explain everything. I'm just presenting the work. Yeah. You're welcome. Sure. And you can find it online by SBC website. Yeah.
Okay, thank you so much.
You're welcome.
Yeah. Why did it change?
So, thank you, Mr. Faisal. We are now going to have Dr. Badr Al-Harbi. He is an emergency medicine physician. We will know more about the Saudi health system, and he will be talking about assessment of patient safety culture among nurses in Saudi hospitals. تفضل.
Good afternoon, everyone. Thank you. I would thank the organizing committee, the attendance. I'm very happy to be here between you. I'm Badr. My background is emergency medicine. I'm a George Washington fellow. I work as the head of culture improvement in the Saudi Patient Safety Center. So to start with, patient safety as a top priority. I think we all agree on this. The frontliner will say patient safety is a top priority. The leaders will say that the patient safety is a top priority. Even the governmental leaders will say that the patient safety top priority. But do we really walk the talk that we are saying that the patient safety is really a top priority or not? Before 1999, there was no clear focus on patient safety. And I expect that most of us know about this landmark report, Terror is Human. And one of the things that we all agree on, the first mission for all health providers is to do no harm. So Terror is Human, this report was released in 1998 by the Institute of Medicine, and it really shocked the community that really the healthcare is not that as safe as we think. And that report even pushes the Bill Clinton at that time to release multiple orders and steps to reduce the medical errors. So they found that around 44 to 98 die every year because of medical error. And this was in 1998. Remember before how many new intervention we have, how many complexity now we have, no medications, chemotherapy, etc. So this was in 1999, and a lot of patient safety experts, they claimed that this is an underestimate. 2021, WHO said that 1 in 10 patients is subject to adverse event. More than 134 million adverse event is due to unsafe act or care that occurs in our hospitals. So the outline of this lecture, we'll talk a little bit about patient safety culture. We'll talk about the Saudi Patient Safety Center role and efforts in measuring the patient safety culture in the previous or in the last 4 years. We'll talk about why do we care about patient safety culture in nursing field exactly. And lastly, but not the least, is the assessment of patient safety culture among nurses. So if we are talking about patient safety culture, most of us know this definition. It's the product or the product of group belief, values, attitude, perceptions, competencies. And if we all agree that organizational culture in general, not only the patient safety culture, the simple definition is the way we do things around here. We know that hospital continuously strive to improve patient safety and quality, but one of them very important step to have a positive patient safety culture is leadership support. We know that leaders play a major role in driving a safety culture of whatever organization that we have, whether it's healthcare sector, oil sector, whatever sector we have, leadership, they will play a major role in driving the safety culture. So this can take 1 hour, but James Rees in 1997 said that the component of safety culture to reach to high reliability organization at one day, to have an informed, reporting, just, flexible, and learning culture. So why do we need a safety culture?
what is the benefit from having a safety culture? The health foundation assessed linkage between the patient outcome and the safety culture, and they find clear positive linkage with good safety culture that reduces the readmission, length of stay, and medication error. Also, strong patient safety culture has also been shown in multiple studies that it's associated with higher employee engagement on work place safety, and we know the new concepts talking about the joy at work and etc. Also, other studies showed that there is clear association between patient safety events, improved patient safety culture that will decrease the patient safety events. More and more talking about well-respected organization, WHO, the Global Action Plan 2020-30, they calls on government to adapt a global approach for establishing a safety culture across the health system. SIBAHI, as Mr. Faisal explained, is the accreditation body in our country. They mandate the hospital leader, one of the standards to mandate the hospital leader to conduct safety culture measurement yearly. And this is what we did in Saudi Patient Safety Center. Over the past 4 years, we have been measuring the patient safety culture at the national level. Patient safety movement, they release actionable patient safety solution. The first paper was in culture of safety, and they agreed that the 5 components of patient safety culture is to create trust, accountability, to ensure the accountability, to identify and safe condition, to strengthen the system, and to assess and continuously improve the safety culture. So talking about the SPSC effort in the last 4 years, when we started this national project, we thought that, and we agreed that we cannot improve what we don't measure. So let's measure the patient safety culture across the kingdom, across the country. Then we will have a lot of intervention, improvement packages, etc. So we choose the HRQ. I think it's one of the well-respected organization, and the survey of patient safety culture has been used in more than 92 countries all over the world. Mr. Faisal was talking about staffing and work-based domain. The HRQ survey, it's a 10 domain survey that included more than 32 items. Every and each domain have 3 or 4 items to cover that domain. So here is the journey of the patient safety culture measurement in the last 4 years. We started 2017. It was like a pilot study. Only 19 hospitals was there. It was paper-based. The total participants were around 40,000. In 2019, 250 hospitals. The number of participants almost doubled, reaching to the last year, 2022. We have more than 450 hospitals registered. The hospital who were engaged and taking the survey. By the way, we have the Saudi Patient Safety Portal that we are collecting the sentinel events and measuring the safety culture annually at a national level. So all of these hospitals, they have their designated username, password that they can use for measuring and analyzing the data. We release 392 facility reports, so each hospital has their own facility report, and we have a national database report that you can Google it also in the Saudi Patient Safety Center, writing a hospital survey and patient safety culture version 2, you will find this national report. Writing staffing ratio, Saudi Patient Safety Center, you will have what just Mr. Faisal explained about the safe staffing ratio. And after each cycle, we release a national recommendation based on the result, based on the lowest 3 scored domain. So for example, the last year, the lowest scored domain was staffing and work-based, then response to error, then hospital management support for patient safety. So we believe, and we have identified that they are the 3 areas of that we need to work on it at national level. The 3 top scored domain or positive culture response was teamwork, organizational learning, and communication about error. There was one question in the survey: how many patient safety events did you report in the last 12 months? And it's only asking about patient safety events. It's not asking about sentinel event, major events, etc. And what really surprised us that around half of the participants, around 48.5 of the participants did not report any safety events over the last 2 months. And this clearly correlates with the low score domain response to error. So people, they feel scared. There is a clear blame culture in the healthcare system. So what is the importance of patient safety culture among nurses? This was the most difficult slide. I believe as a physician, I can't do my work without a competent nurse. Also, I believe that the patient himself will not survive without having a competent nurse. So this did show us why nurses are important. We know that they are the primary caregiver to the patient. They really have a complex and high-risk task, administering medication, a lot of major safety events like falls, like medication error. Those are the common famous safety events. Almost always, the nurses are the first to recognize them, and almost always, nurses are the first to recognize whenever things are going wrong in the patient care. Talking where's the money about the patient safety culture among nurses. So if we talk about the assessment, we took the nurses results. We have 5 categories of nurses: midwife, nurses, technician, and we have their results just to have this assessment of nurses among Saudi Arabia. The top 3 domains or the highest positive cultural response among Saudi Arabia was the teamwork. This is only showing the nurses' response. Organizational learning and continuous improvement, hands-off and information exchange. Whereas the lowest positive cultural response was staffing and work-based. The second lowest score domain was response to error. As I mentioned earlier, there is a clear blame culture. And the third lowest score domain was reporting patient safety events. What about the patient safety event reports? The question that I told you before. In nurses, 49% of nurses did not report any safety events in the last 12 months. Here we can see the 10 domains. Nurses are on the blue. We have physicians, other clinical services, supervisors, supportive services, and we can see what is the difference between them. And clearly we can see that the response to error in nursing was higher than all other specialties. The number of participants in this national project, again, nurses were the majority of responded from the nursing field. Around 17,000 nurses participated in this national project. Looking at the patient safety rating of positive rating of patient safety, again, nurses were somehow in the middle. Patient safety events reported, nurses were the third. If we compare this to other clinical positions and specialties. So to end my talk, I just want to remind us about the great comment from Lucian Eve, one of the patient safety experts. He said that the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. Thank you so much.
Thank you so much. Let's see if we have questions. Yeah, we have one.
Thank you very much for this highly effective information. I remember I was writing my thesis for both masters or PhD. My 2 supervisors, 2 different supervisors, nationality, qualification, country, they told me to focus on patient safety. Since then, I realized that it's very important topic. I'm not public health, so public health, as I said, we're lost. We focus on everything, but nobody think about us. However, where do you rank the patient safety in, let's say, in the GCC as every results can be applicable from Saudi Arabia to other 5 countries or from any country of the GCC? Where do you rank the patient safety globally in the GCC?
Difficult question. So, yeah, so if you are talking about patient safety culture, or you are asking about patient safety in general. So, patient safety culture, I have somehow some answers to you. Saudi Arabia was the only country who were included in the OECD report. So OECD has a report that could have all of the OECD country regarding patient safety culture. You can find in their website, and there is a clear comparison between other countries. So we can see, or we can tell you that in Saudi Arabia, we really need to work in response to error in comparison to USA, UK, and other countries. And for example, a teamwork domain, we are doing better. And this is in patient safety culture. But just to answer your question, they always say that patient safety is the elephant in the room. Yani it's very difficult to measure patient safety. People look at patient safety from different perspectives. I might be biased because I work in the Saudi Patient Safety Center trying to improve the patient safety. So it's very difficult to answer where did I see. But what I can tell you for a fact that we have a long journey to improve patient safety. If we look at the projects that we have in GCC country, the improvement, the focus on patient safety, I would say that we are a little bit far away from the developing countries.
BS in the
BS?
BES in the
No.
Don't have like full idea about it, but I did some. There is an organization, they rank the countries in terms of incidents report systems, the accidents.
Pero mañana me deben depositar quizás, mañana o el viernes.
How are you doing that?
I think it's from Zoom.
Skills.
Not much understanding. However, they rank the countries in terms of the adverse events or adverse events. Yeah. As far as I know, they stopped doing the ranking in 2018. This is why I asked.
Yeah, but trying to measure patient safety from the adverse event perspective, it really depends on the reporting culture. So if we are not reporting in Saudi Arabia, it seems that we are the best country in the world because we don't have adverse event. Even if we rank that, so one of the suggestions in the country was to make a KPI in our country, Saudi Arabia, on the sentinel events. So this, we were fighting at the Saudi Patient Safety Center that we don't want to include sentinel event as a KPI, because me as a hospital leader, I'll try my best that we will not report because this is a KPI. At the next stage, we will have like Medicare and we will have a payment regarding this KPI. So measuring patient safety from that perspective, I challenge that idea. You can measure it from, I think, and from the quality perspective, efficient, timely, as you all know. But measuring it from one perspective is very difficult. It's very good questions. We have to learn how to use it. Vives, I'll have a comment.
I have a comment in regarding to measuring or assessing the patient safety from a perspective of only seeing patient safety event. So if you go to OECD website, you will find quality indicator. Underneath, you will find patient safety indicator. There is only one indicator. Code per 1,000 population, which is the patient safety event reported per 1,000 population. You can see for all those countries who reported to the OECD, there is inconsistency of providing that. So I will give you 2010, okay, and we will 2013, then 2017. So how you can rate, there is no consistency of providing that. However, I agree with Dr. Fedor that it's not the right angle to see patient safety from the report and patient safety event, because it only gives you the reporting culture.
not the patient safety. Looking, for example, in the US, the HRQ developed patient safety indicators for post-operative PTE, etc. We have a different that is relying on coding and the Medicare relying on this for the investment. This is a good way of measuring patient safety. However, it's a critique picture and saying there's an issue with the coding. They are not covering all the codes, or they are covering something that is not in the safety. Whatever you are using to measure patient safety, we will critique. However, we see that patient safety event is not the right thing to measure patient safety, but you can develop an indicator, and this is what I mentioned before, that we are now in the phase where we are trying to build patient safety indicator, and we try to benchmark with 1 or 3 countries. Thank you.
Excellent. And just to connect this, so the patient safety indicators that you can them will be like automatically uploaded. But again, I mean, get to each organization to report the patient safety indicators.
They will show us they are safe.
Yeah, exactly. Is there any plan to do this electronically, like the key triggers, or now that now we are sounding in the process of refining all the
Yeah. We ask the hospital to provide us for the hospital indicators. Sometimes it's subjective to measure the indicator, but if we look, for example, for the OECD HRQ, they're only relying on ICD codes. So whatever the physician put as a diagnosis, the system will extract it and will release it as an indicator. So there is no way of manipulating. However, until now, we didn't know that there is a hospital that is relying on measuring any patient safety event by using ICD codes. They can give you a definition, what is the denominator, what's the denominator, by being subjective. This is will be included, this will be excluded. Sometimes they can manipulate by number. But if you're relying on the ICD's code, which is only put in by the physician, the system will extract it automatically. Here where you can give an honest and accurate idea about the safety within your organization. Yeah.
You know, this practice, I can share like what we did in the BTE project. When we relied only on the ICT and registered coding, we got less number than when we did an actual data collection of digital diagnostic. So I know that it's really time consuming, takes time to collect this data, but it's more.
Yeah.
So I think we are in the right way to get this reported when we can highways.
One more question. Just one question. In my country, Jordan, has a problem in benchmarking internationally. There is no center for data collection, center for the hospital to collect all the data and to generate benchmarking nationally. Because all the hospitals have on data and confidentiality, privacy, a lot of things we have challenges on this event. Second things we face financial. So with all the countries now seeking quality, seeking patient safety, okay. But when we come to resources, we face a problem. I don't know if you face the same problem in your country as a financial and benchmarking nationally or not.
Thank you for your question. Regarding the first part, benchmarking, I think we didn't face problem about benchmarking because we are the center that we are receiving all data from hospital. They access our patient safety platform. They get the link for the survey. They start to participate. So we have all of the data. And that's why Saudi Arabia was the only non-OECD country that were included in the OECD report of patient safety culture because of the data size and the methodology that we collect the data. Jordan, they are very active. They are now reaching to us at the center. I think in the next couple of months, we will have a meeting through WHO to show Jordan how did we do the portal, how did we do the what was our methodology. So maybe in the next 2 or 3 months, you will find it something or somehow changed in Jordan. We will try to collaborate and work with Jordan. And by the way, I'm the head of culture improvement section. This is my email. If you have any question, any potential work that you want us to work with, you can directly contact me. Regarding the second part, the financial challenges. So at the beginning, yes, it was like paper-based. We didn't have enough financial support. But in 2020, the centers officially on the ground of the healthcare system. We have our own budget. So I would say that in the last 2 years, we were lucky. Alhamdulillah. Thank you so much.
لا ما في داعي للاسم، بس ندخل صورة على تصير المستر هنا قاعد بس اللي يطلع. ايوه.
Our next speaker is Mr. Muhammad Amin Midar. He will be talking about description of the use of Facebook by virtual nurse friends in Tunisia.
Thank you. Which one I use?
فيها ضمان وفيها
Okay, thank you. Good afternoon, everyone. Are you waking up? Sir Carl, are you waking up? Thank you. That's what I want. Good afternoon, all. Here is Mohammed Amin from Tunisia. I'm a CRN working in Saudi Arabia in ER department, and I really have the pleasure to be here in the UCG in this conference, and I appreciate your presence here. Today, actually, if you saw my title, it's the description of the use of Facebook by the virtual nurse friends in Tunisia. It seems a little bit weird, صح? Facebook, we will talk about Facebook after talking about the stroke, the patient safety, the healthcare, and it's really good. So I will talk about Facebook. It seems weird, huh? So my question is, anyone has Facebook account here? I will send you an invitation. Other who have Facebook? Okay, so it seems like 3, 4, 5, not more, which is that we will talk about. Here is my plan. We will have a small introduction, and then we have some material and methods that I use during my research. I will give you some results and I will discuss it. One recommendation, which is the most important part, and then we will have a small conclusion. Let's start by the introduction. The interpersonal relations are no longer take place simply face-to-face, but today, I think when we have the break or when we go for lunch, we take our maybe laptops, our phones to check our messages, especially we are not in our country, so we need to check our families by Facebook, by Snapchat, maybe by Instagram. So we need to check. We are spending a lot of time under this screen checking the social media. So the question is, this social media, this internet, these applications, especially we will talk about Facebook, is that useful in the nursing science or not? That's my question.
This wave of virtual networks and its technologies, it have completely changes our way of life. We spend more time behind a screen to search for information, share patients, distribute our creation, and communicate with other friends. And by the way, sometimes, especially me, for example, Ma'am Amal, when I was on contact with her to do my registration in this conference, I don't know her face to face. Even I don't know her background. But today I'm really glad to know all of you. For nurses, being on Facebook means being unique and singular. Ma'am, you have already account Facebook. What you can do on Facebook? Post the news. Sir, what you can do on Facebook? That's good. Here, I want to hear Egypt, ma'am, what you are doing on Facebook? Did you post some photos? Did you post today photo that we take all together? Did you post it? That's the point. You will. You will. So on Facebook, we can make comments and express preference for a particular event like today, and expend social capital and provide and promote information. And we can, like ma'am, she can post photos and videos. The number of Facebook users in Tunisia, it's almost 55%, so which is more than the half of the whole population. Mainly in Tunisia, there is 3 social networks occupy the internet scene. The first is Facebook, that it was founded in 2004 by Mark Zuckerberg of Harvard University and became publicly available in 2006. Despite all the interests of Facebook, none of the professional platforms offers functionality for exchanging and communicating in an efficient scientific way. Actually, I know on Facebook, even me, I am following the UCG page, but sometimes, are we sure about these pages or no? Are we? I think no. Okay, UCG, it's a real page and we have contact with and we do the registration. So we appreciate this, but other pages, for example, there is one page called nurses, Saudi nurses, Tunisian nurses, Jordan nurses. They will post some news or some information about nursing. Is this credible or no? Can we take it as a real statue or a real photo? We can't. Relationships with co-workers can be a significant challenge brought up in conversations in multiple ways. Facebook, it might be a trap. That's why. So take care from this Facebook. It's really dangerous. Each one of us has always been looking for a real friend, means of communication that allows us to express ourselves and to exchange our thoughts with others, not only physical, but even social, moral, and spiritual. So here, Aristotle, my friend, what he said, he is not a friend who is the friend of all, but I am. I hope this. Friendship requires too much trust, sincerity, intimacy, and time to be shared with dozens of people. Actually, I came yesterday from Saudi Arabia. It takes to me maybe one day to know all of you, your nationalities, your backgrounds. So actually, now we have contact with each other. I can ask for your Facebook, Sir Carl, and we will be on contact. That's why. A friend is not just someone with whom I speak or write. I will message Sir Carl, but I need to meet him to know his background also. Each of us is always in search of real friend, means of communication which allows him to express himself and to exchange his words with others, with the aim of survival, not bodily, but social, moral, and spiritual, like mentioned before. On Facebook, it is possible to be a friend, but sir, if I send you a request, what you will need to do, you need to accept it, okay? So you need just to press I accept. So he can accept me as a friend or he can decline me. So the objective of this research is to describe the reality of Facebook used by nurses. Our material and methods. This research is an analytic descriptive study with a quantitative approach. My sample size was 214, which are nurses and even nursing students. This research was done in University Hospital Farhan Hashab Sahlul Sus between December 2017 and May 2018 using a quiz or questionnaire.
some of the results, there was 111 students and 103 nurses. And like we can see, there is 62.1% of they are males and 37.9% of them are females. 55.6% of the entire population are between the age of 20 and 30. So here the age is playing really a big role in our research. If, for example, Doctora, the question is for you. For example, if you are not updated to something in the medicine and you need to check it, what you will do? You have a patient already and you need to check something. What will be your first source of information? Okay, she's using the internet. So here is the first one. For example, if I am your neighbor and I am a nurse, and for example, you have a small injury, and you know that I have the material to do the small dressing for you. So you will came to me. So even the nurse, the doctor, and the internet are sources of the participant on their health situation. The doctor is the first one with 45.3%. The internet, the second source with 14.3%, and the nurse is the third one with 14.5%. Facebook, it seems important for 41% of the participant, and it is very important for 35%. The frequency of temporal use on Facebook, like she said, what we can do on Facebook, we can share patients, we can post photos. So 14.5% of them, they are spending more than 3 hours on Facebook, which is a long time, صح? 3 hours on Facebook or on Snapchat or on any social media, Instagram, and actually it's useful. We are not getting real information. We are not sure about these informations posted there. Facebook status can be refreshed frequency per day is 1 to 4 times for 54.1% active users, while 32.8% are passive users and never update their status. Like we can see, the virtual and the real are playing a big role. Now we are real friends, we are real colleagues, so we can contact each others, and I'm sure about your all backgrounds, and I know you already, I met you. But what if you are contacting someone that you don't know? So you don't have faith in him, you don't have faith about the information that he is giving you. So the majority of nurses' friends on Facebook, with a percentage of 62.8%, are actual friends that they have met in real life already, like we do. I use one scale, if you know, the Bergen Facebook addiction scale, and I found this result. A percentage of the population, 26.2%, were neither addicted nor independent of Facebook, according to these items. And there is only 22.8% of nurses that have an average intensity of Facebook use. Here we have another item, he is entering the scene, which is the social capital. And then we will have a correlation between the self-esteem and between the Facebook users. So there will be a correlation. According to this scale, the nurses have an average social capital 28.9%. Here is the self-esteem. 30.3% of nurses, they have low self-esteem. Here is the question. Why these nurses, they have the low self-esteem? Here is the correlation that already I talk about. So if I am using the internet, I am using the Facebook as a nurse. Is that having benefits, or is that touching my self-esteem or not? So this correlation, what it showed me, the more the participant use the internet, the lower their self-esteem. Is that can be real? Yeah, it is. So again, the more the participant use the internet, so he is spending a lot of time using the internet. Sometimes he is ignoring his patients. They are calling him. They are please, where's the nurse? Where's the nurse? No, he is checking his phone. He is checking his messages, his posts, and his stories on Instagram or on Facebook or on Snapchat. So his self-esteem is touched. That's why it's decreased. Another correlation. The more important Facebook is for the participant, the lower their self-esteem. It's almost the same, but it's particular for the Facebook. Other third and last correlation done, the more experience is the nursing field increases, the more time spent per day on Facebook decrease. What does this mean? So we are busy as nurses. I'm talking about, it can be all. We are busy. So for me, I'm working in ER. When I get my phone, I put it on the table. I'm working 12 hours. Did you have time to check your phone while you are on shift? No, you don't have time. Even you are going from bed 1 to bed 2, from this patient to this resource patient to this dressing. So you don't have time to check, even sometimes to take a break. So your self-esteem will be low because you are doing your real job as a nurse. That's what I mean. So the purpose of using the internet is to learn about a health problem in order to better understand the comments communicated by the health professional. Facebook, it has caused a real revolution in our communication possibilities and undoubtedly the news risks generate. Our nursing participants, they have at their disposal the new ways to express their selves, to protest, to satisfy, and to support, to debate even. The virtual friendship, it can be real. صح? When I send some to Sir Carl, for example, an invitation on Facebook, we will get, let's go to drink coffee outside. Let's go to talk. Tell me about yourself. I will tell him about myself. So here we will be real friends. That's the difference between the virtual and the real friend. The friendship movement on Facebook is inauthentic. It is no longer simply a feeling, but rather a set of actions that attests to friendly relations. The maximum number of people with whom we can have sincere and strong relationships is around 150, no more. Okay, I'm a sociable person, but how much you will have friends? You have faith on all of this person? No. Facebook literature, it has highlighted self-esteem and personality as psychological antecedent of addiction. So here we start to talk about addiction to this Facebook. I post something, let me check if Miss Amal, she saw it or no. So this start to be like addiction. I want to check. I will ignore my patient just to go and check who are the viewers of my post or who are the viewers of my status. So the University of Gothenburg in Sweden conducted a study on panel of 1,011 people of an average age of 32.6 years. It seems that those who use Facebook the most tend to have a lower self-esteem than those who don't. So among the issues raised in our study that require the involvement of the virtual nurse at home. So here we are talking about the home nurse, is summarized in the complications of the daily life of patient. That's why the application of therapeutic patient education, it make the patient autonomous and independent to self-manage complications. Most important part for me, and if you remark that I'm always asking about what is the recommendation of your research, ma'am? What is the recommendation of your research? So what I can get to do as a nurse, what I did learn today. So as a recommendation, what I did, to facilitate this approach of the virtual nurse at home, we have created an Underweed mobile application. Actually, it's only on Underweed. So under the name Virtual Nurse, this mobile application has non-profit because the patient can contact the nurse without any cost. And it's only he downloads the application from the phone like Play Store. Thanks to this application, the patient, he can call the nurse answering his needs easily in a few simple clicks via their phones. And to contribute to the success of this initiative, we have also created a website so that patients have access to information on the approach of the virtual nurse, its missions, and the means of communicating useful and rapid information, and just make sure that it's useful information. The impact of a website depends on the interaction with other media spheres on the one hand, and on the other hand, with other economical, social, religious, reactional, educational, and family bodies. Otherwise, let's have a small conclusion. Still no sleepy, sir? I hope this. The increased use of information and communication technologies at home is a potential response to the challenge posed by chronic disease management. That's why the offer of home care, thanks to virtualization, therefore becomes a privileged anchor point for the promotion of health. In order to increase the efficiency in terms of continuity of disease management and reduce complication in the daily life of patients. Facebook is seen and used by a significant segment of the population. Let's not talk about this research. It's actually 214 participants, but actually even us, even the presence here, you are using social media in your life as nurses, as paramedics, as doctors, like all you answered before. So this wave of networks, it has taken hold and given grace in particular to multiple online activities. This original study, it was done only in Canada, and I was the second one in my studies in Tunisia. It describes to us the use of the social network Facebook in general. Further research should be considered to deepen and enrich the real and virtual communication of nurses and learners. Last slide. The use of Facebook, it increased the communication. It's okay, that's the positive thing. And the social interaction, and for others, it's weakening them. It's touching their self-esteem. So the dimensions of the portrait relating to the use of Facebook of friend in nursing, it characterized by the connection time, the rate of engagement, and cyber-addiction. So like I said before, it starts to be an addiction. So just as an advice, I think I'm the youngest one in this room, huh? Yeah. Okay, as the youngest one, I will give you a small advice. Facebook and the social media, it's really have a good benefits. It's okay. I am on it. Yeah, we are posting photos, but otherwise, take care of the social media, especially Facebook. Don't trust any pages or any committees. It's actually, it should be professional. It should be in a scientific way. Okay, and thank you very much.
Thank you so much for this interesting presentation. Do we have questions?
Sir Carl, sure.
Hello.
Hello. Thank you.
I like how you focused on social media with Facebook, as I've been using myself, and I do agree with you. There's a lot of pages on there which I wouldn't trust either. When I was at university, when I got to meet the people, and they made a group. It kind of was helpful in terms of study days and stuff like that. So I think you're right about that. Meet the person,
yeah,
get to know the person a lot more. It's virtual nursing that you mentioned. How secure the Android app? How secure is it? So if someone is going to go on it because they want some advice, how secure are their details on that platform? How secure are how confidential is it in terms of data?
Actually, I'm sorry to say this. Actually, it's a good question, but I'm sorry to say this. It's not secured.
You're breaking my heart, but I appreciate
it. Sorry for that, but it's not secured. Today we are in 2013. So there is hackers. There is, 23 or 13. We are 2023 or 2013. So there is hackers. There is a lot of information. There is a lot of increase in the technologies. So we are not sure about the information that we are getting even from internet. No. Yeah, we are not all, huh? So we are afraid of the one we are getting. But since if you are actually, and even with this application only, you for example, I have headache or I have some pain in my body, I will not rely on only on this application. The nurse, he have limitations. For example, if I don't have the right to answer all the questions of the patient, the doctor, he need to be the one. I can't, as a nurse, say to the patient that the pH in the VBG is very high or it's very low. So this is not my job description. This is for the doctor. Otherwise, this application, there is some limitation. So I will just do my job description as a nurse and answer the question with my limitations. You got it?
Got it.
Thank you.
Thank you.
If I may add, also it has some medical legal implications.
Yes, sure.
We are emerging in the telemedicine, but still, how legal, as you said, I can't answer or diagnose a patient on WhatsApp or social media.
Sure.
And when we answer the patient, it has some consequences and it's documented. So we need to be careful.
Ma'am Amal, if I still have 1 minute, I want just to share with you. Less, okay. So I will share I have one resident working with me in the hospital in the ER. And as we know that we talked before, the speaker before me, she talked about the importance of ER department. She's a resident. I just want you to be here. Two minutes. It's okay. It's okay. It's okay, my dear. Otherwise, we were talking about the PEA. Maybe someone don't know. So as a nurse, I will just write in Google, what's the abbreviation PEA? It's the pulseless electrical activity, صح? But she was a resident. She's still not a consultant or a specialist. She don't know the information. She doesn't ask me because she think, or maybe she think that I am a nurse. I don't know, but I know. But how I know? By asking the others, صح? So what she do, she just go to Google, she write PEA abbreviation. Other thing is appearing, it's not medical even. Other thing, so she rely on Google or what this website or what this things that she's looking. That's the risk of the internet. So she get the wrong information by wrong looking. You got my point? Tell me, Doctor.
I also have a comment about the accuracy and reliability of the information on Facebook or social media. But sometimes it is also information for me.
Yes,
I go to the Ministry of Health website or page on Facebook, and they issue press releases. They will tell us what the minister did. So yeah, sometimes if the page is reliable, then it can be source of information.
That's what I mentioned before. The UCG, I just start to know it. What is the UCG and what's the 12th International Nursing by Facebook, which the one I'm talking. So I'm really appreciating being here again. Any other questions? Thank you so much.
Thank you.
Take your time.
Now we invite Dr. Jose Francisco Sanchez Cuellar, a neurosurgeon at the Centro Occidental Lisandro Alvarado University in Venezuela. He will be talking about wrong level in spinal surgery.
Questions? Right. Okay. Yeah. Please. Hi. Good afternoon. My name is Jose Francisco Sanchez Cuellar. I am neurosurgeon from Mexico City. I am very thankful for the invitation to the Congress. Today, I will talk about a situation that could impact negative in the evolution of the patient, which is wrong level in spine surgery. I work at Angeles Universidad Hospital in Mexico City in the neurosurgery department. Here is my team formed by neurosurgeon, anesthesiology, and clinical neurologists. We are in charge of treat patients with different neurology and spine diseases. Let's start. This is demonstrative clinical case. Male patient, 63 years old, from Guerrero State, Mexico. Elemental teacher, laterality right-handed, and marital status is married. Without relevant pathological history, current condition, the patient has thoracolumbar pain, BIS 10/10 points. After the erroneous vertebral biopsy, the symptoms got worse, adding a marked functional limitation for a walking and a decrease in muscle strength in both lower limbs. physical examination pertinent, muscular atrophy in pelvic limbs, 3/5 in bilateral L4 myotomies, with paresthesia in bilateral L3, L4, L5 dermatomes. The patient does no longer use a wheelchair. In the image, you can notice hypointensity in T1, hyperintensity in T2, with a decrease in intervertebral space in inflammatory change in T12 L1, typical findings of spondylodiscitis. Here in CT, let's observe and play T12 L1, osteolysis, and thoracolumbar kyphosis. And now, after the ground level biopsy in T9, T10, the MRI shows that there was an extension of the inflammatory process of the left psoas, muscles, and pelvis. Diagnosis: vertebral destruction syndrome secondary to T12 L1 pyogenic spondylodiscitis, bilateral psoas muscle abscess with extension to the pelvis. So now, let's go with the second surgery. You can observe in the video T12 L1 laminectomy and drainage of pyogenic spondylodiscitis. After the correct surgery, we found out of the existence of Staphylococcus aureus sensitive to vancomycin, meropenem, and dicloxacillin. Here is the patient 4 days after surgery with improvement of thoracolumbar pain, fever, muscle strength, and an inflammatory process. This is another case of ground level spine surgery. The first image shows an MRI with medullary compression in the C3, C4, and C4, C5 level. Notice that postoperative MRI and CT reveals that around the compression surgery was done, this time in C4, C5, and C5, C6 level. Let's do a brief review about this topic. First of all, we need to speak about medical errors in the operating room in general. What is an error? According to Cambridge University, an error is a mistake, especially one that causes problems. In surgery, an error refers to surgery performed on the wrong person, wrong organ, or limb, wrong side, and specifically in orthopic, wrong level spine. Surgery in wrong place, also called wrong side surgery, has a low prevalence. Some of the most common risk factors are incorrect position of patients, do not use surgical marks, surgeon fatigue, emergency surgeries, inadequate radiological visualization, morbid obesity. Statistically, the prevalence near 50%, 84% require compensation. There is a high economical remuneration. The most frequent spinal segment report is the lumbar spine. Let's say the surveys in the first, the half of American neurosurgeons admit had made a level error in their career. In the second one, in Canadian neurosurgeons, there was a prevalence 10 over 10,000 cases. So now let's focus on how to avoid those errors in the operating rooms. Here you have the following protocol. All this, anesthesiology and nursing staff identify surgical site before administering anesthesia. Patient participation in the verification process. After it, compare patient identify with patient bracelet, operating room programming, medical records, use universal protocol, 3 R's protocol, and tie out. Specifically, the recommendation to avoid errors in level spine surgery, my team follow seven steps in all surgeries. First, mark the surgical site 1 day before the procedure. In fact, in this paper, it is shown that MRI can be done with capsules of cod liver before surgery and MRI. Second step, the consent form with the site and vertebral level is signed by patient before surgery. Third, check the level with a metal marker before surgery. For example, my team used preparative marking with CR. This is the most common technique. For mark in the level ink on the patient skin where the incision will be done. 5 step, make sure that the whole team is fully involved in the checklist. 6 is very important to observe the sacrum in lumbar spine and C1, C2 in cervical spine. Also, in some cases, we use navigation via IOR for better precision. And the last step, postoperative SRI or CT have to be done. These 7 steps I talked about before decrease the risk of ground level spine surgery. The checklist can be applied in different health centers where spine surgery are performed. You can follow my job and my social media accounts. See you next time.
That was good. Thank you so much. Any questions? Any questions?
Hello. Just a question. Good topic. Thank you.
Yeah.
So my question is, when you get patients in your area of work in neurosurgery, are there ever any misdiagnoses with the nerves or sensory areas of the spine, like the dermatomes or myotomes, in terms of when you're preparing and whatnot the patient?
Not very good. Yeah. So let me also. There is diagnosis.
On the spinal nerves or sensory areas of the spine, like the dermatomes or myotomes. Mm-hmm.
Okay. Yeah. So,
I don't. That's good. We have to go with the let me do what I do. That's fine. Yeah.
Excuse me, I'm touching out. So let me just until we figure out what the question is. We will have a coffee break. The coffee is outside. You can pick it and have it here. But we will continue, and we only have 2 speakers left. So 2 speakers were not able to join. They will join maybe online tomorrow. So please stay and don't leave for the coffee break. But you can bring your coffee and drink it here. Okay.
Hello.
Yeah, please, can I have your attention?
I just remembered one story I want to share with you. Is it possible? There was a talk about physical violence, right? And we already mentioned that
There we have to have regulations, we have to understand the patient needs, explain the thing before we jump on that, okay? So I had one story happen to me in Saudi Arabia before. Because sometimes there is exceptions. Okay, I'll let you know about it. I was walking in the ER and it was very crowded at the time, in Taib, the King Abdulaziz Hospital in Taib. And it was very crowded at that time. You cannot imagine how the ER at that time was very busy. Then suddenly, a lady, she came inside to the ER, okay, with a wheelchair. There was a lady in the wheelchair, she was her mother. Then she came to me straight away and she told me, have a look at my mother. Like that. Please, have a look at my mother. And even without passing through the triage, she just came directly from the street inside the emergency room. So if this was you, okay, what's your solution?
Care provider.
Yeah.
That's the thing. It depends on the mood. Yeah, it depends on the mood.
Got you.
I mean, to be in the line, to be in the line. Yeah.
Hospital policies, like how can?
Yeah, she runs the policy, and why she's waiting here? Okay. Another one that.
Actually, the same incident I came across, and it was not very far last year. And my action was that, first of all, I have just asked the details of the patient, and I go through my patient from the watcher, and I just.
I will get you know what.
We will have a co-pilot, as a emergency physician, we'll have a co-pilot with the patient.
Excellent. Excellent answer. Because you know what happened after that? I told myself, I will not talk to her. Her mother was covered. I asked her to take off the scarf. Then you know what happened after that? She was gasping and she arrested in 1 second. We did PCR and she was not able to revive. She passed away.
Sad story.
Sometimes, no. It is. If it was someone else, maybe he will tell her, please go to the triage. Please go back. No, it's very crowded. Give me more information. Do this, do that. The best thing is just to have a look at the patient. She gasped and she passed away.
Thank you, Dr. Sahar, for sharing
Thank
this
you.
story. We have to move to our next speaker, Dr. Fu Nogin. She's a MD, MPH, University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. She will be talking about medical tourism, gains and burdens in developing countries. Over to you, Dr. Fu.
Good afternoon, everyone. Before I begin my speech, I would like to say appreciate to everyone, including the UCG and other health professionals who really contribute to today's conference, even either online or face-to-face. Because I've learned a lot from you. Thank you a lot. I've come to here with the topic about medical tourism. I think it's really familiar for you about tourism and also the term medical tourism. But I just want to provide a deeper view of understanding yourself so that we have the broader and viewpoint after my presentation. So somehow you can use it live or have a quick recommendation after, or when we go back to the work of our country, hopefully that somehow, we can contribute to the system so that medical tourism not only in developing other countries as well, to have a better efficiency to manage everything, every problem that involved, even in the host of region countries. So before I begin, I would like to take an example. For example, if I live in Australia, I'm an Australian citizen, and I want to go to Vietnam, which is a developing country, and I want to go for a tour, like to sightsee, to go visit some attractions. So what do you think that's the purpose of my tour? To be tourism, or would be like other purposes? I think that is tourism purposes. If I put one person who goes to another country, you don't just like going around and see the sightseeing, to experience the activities of the population, community as well. So you could go to the sauna, try to enjoy yourself, entertainment. So it's not only tourism anymore, it's the wellness purposes. So if you go for a dental care, or if you go for treatment, if you go to the medical tourism. So medical tourism is hard to define, which is like if you apply for a visa, you go to another country. Usually you will go visiting the traveling visa. It's easier to apply, easier to grant. But if you go for medical treatment or medical care reason, it's harder for you to apply for visa. Even though when you go to developing countries, especially Vietnam. So most of the people, when they go to Vietnam, they would like to get the visa easier and more approachable to go and time saving, they will go for travel visa. So that's would relieve the rate of traveling. The percentage of people who go to Vietnam of all the developing countries reason traveling. But it's like they would go for other purposes. So I would like to move to the next one. Okay. The content of my outline is really short. It's only a definition and concept of medical tourism or other related terms. An introduction of how I got you topic and the method, and also the key conclusions. And I'm not coming here to provide a solution, but I'm just coming here to provide understanding, so that somehow that we can share the things, okay? And then somehow when we get to country with your work, we will have that idea to contribute to develop that system in terms of individuals. So let's talk. There's not much about me. I'm a junior researcher, also a junior lecturer as well. So it's not much like to tell it, but it's a long way to go from a graduate to health professional, to be a health professional. Is just like all of you here, we have go through the question, and too much and carry on. Anyway, so mostly I would my major is principles, infectious disease, but I come here with medical tourism to contribute the project of health, more rather than particular disease or principles. So this is to say a sentence that Hippocrates say. I will remember this art to reason, and that once limited understanding by our researchers life and chemistry drug. And I think it's really great for all professionals in terms of how different healthcare contexts. Right, when we go patients, not only problem with patient, like a disease or health. So medication at home, honestly, so if we go to definitions, health tourism, medical tourism, people usually mix up between these two. And when they mix up between these two, it's really important to identify problem because we have set out program for each category. We go for a different approach to effect. So the health tourism is more a broader definition. So when we say organized travel outside one's local environment, accident enhancement or restoration of an individual's well-being in my body. So basically, it would cover all the definition, the concepts when we travel for the health or wellness. So basically, health tourism would cover. So when it comes to medical tourism, there are so many definitions. I have to look to 50 research and they're all different visual concepts depending on purpose of their papers. So I just come up with the most related definition that will go along with my title today. So the medical tourism is defined as when consumers elect to travel across international borders with intention of receiving some form of medical treatment. I would say consumers, I would say patients, because we call the tourists as well. Tourists are not patients. So when we go to this definition, then consumers are used in the broader context. So the key concept of medical tourism is the willingness to travel, the willingness to click at all processes within the new global market, health travel. So basically, it's just like consumers are willing to go to another country. In this particular title, is developing country to take a whole process like medical treatment. So the method of my review is literature review. So I use the two main keywords, medical tourism, development, to make them more focused. Because when you look for medical tourism, it's Google Scholar, just like Google, you would like find a lot of reports on a lot of research. But when it comes to public health and preventive medicine context, there are not many papers actually used to make a clear understanding and how much difficult that developing countries must face in terms of tourism burdens. And then after that, I will review the results. So it will fit my criteria. And I would say I would take the 10 years back or maybe 10 years after, because they're more updated, they have more clearer understanding. So I would go to the recent trend, the introduction go to three main points. The recent trend to conduct the literature review, the recent meta suggests the burdens or the gains of medical tourism. And again, reasons to make. So medical tourism is a growing trend. In the past, people from the West usually go to the East, for example, like Vietnam, Malaysia, Thailand, in the past, people from the East go to the West, a best healthcare services. Because like in the past, we like healthcare system and services countries in the eastern areas, right? Usually we still in the process of developing knowledge understanding experience. So people with like more advantaged financial situation would go to the West to seek for the best healthcare providers. Recent time, people travel from the West to the East in the country to seek for the best medical technology for advanced healthcare. So it involves not only, like I said earlier, it involves tourism as well for medical treatment process. So, and it also involves all industry like sectors and service sectors. So it includes medical services, tourism, industry, and service sector. So it would apply to many areas of healthcare system. Not only the healthcare system, but the whole system. So I would say that being a multidisciplinary. And when it comes to the multidisciplinary program, they got unclear boundaries between those categories. So when it comes to the program with the policy, with procedures, how they are managed. So because there are many definitions of medical tourism, it cannot lie in one particular category, the national system. So it cannot just lie in the tourism category. It cannot lie just in the medical system. But it's a mix of everything. So I take some summary paper. 2,000 papers, and they would go on the medical tourism is for in many categories like health welfare, yes, social science as well, natural science. So in a map, it will say very particular developing countries. India is one of them, Thailand, Malaysia, and Vietnam is one of them. But it's not in the map I'm showing here because like there's no official way to Vietnam tourists. I cannot say I will go through it here. But in another paper, that the analysis of they would go from emerging hyper developed countries. So and Vietnam is one of them in a high growth. Yeah. Vietnam is one of those in the middle there, you say. So Vietnam, Philippines, and Indonesia in the high growth. And it's in a high growth exciting destination for medical tourism besides Thailand and other developed countries like Singapore or Korea. So this is the report in a paper, and I trace down the source, the author. National Tourism Thailand. So in 2010, 2013, the GDP of say the income, the profit of medical tourism bring into Thailand. Double, just increase. And see, I just want to show them how much profit that medical tourism can bring to the country. And in a global context, $19 billion was spent in medical tourism in 2018 alone. But it would go like more 50% higher when it comes to 2025 prediction. And for advantages, yes, the gains of medical tourism, they bring a lot of profit, including not just about the jobs or the incomes, also the healthcare facilities. There will have to be more healthcare facilities that can fit to the context of the quality of the medical tourism and provide better services for students and policy. And also that we have to apply advanced modern technologies. Either that we have to be developed medical ourselves, but also we have to take it in, to learn from it, train it, to learn from other people. And also have our professional experience in training. Have sent our professional to go overseas for training, improvement of their experience. So that's a good one. It's a good, it's a good question. What's the advantages? So it would somehow improve the key indications of the system. So what is the key indication I'm talking about? The key implications is a big what to say, it's a big element any healthcare system. It includes all the quality of the medical professionals, the numbers of the increased number of healthcare staff, and it also involved in the improvement of the infrastructure of the rural and the urban areas. But besides the strength or the naturalist and medical burdens can bring to there are burdens as well. So the four burdens we go for the medical tourism are the growth of health disparities, the inequality access to healthcare services. So in developing countries, we have limited resources, so we have to choose the priority to make the intervention, to build a program to prevent. So when it comes to the medical tourism, because like when they solve high-tech and sample region approach, for example, if they go to Vietnam for let's say knee surgery to change my knee. And somehow many people go for the same risk for organ transplant, plastic surgery, then repair, or other, even the medical treatment. We put it for it contributes to another cases, number of expenditures for that particular issue. And for that, every year we have to report all the issues that occur in the system, including efficiency, non-medical disease, and sometimes, the number actually say that the country is the number of the courses, and we have to take a look at again what is actually important. We need to prioritize to prevent those health issues, and we have to put more investment, including the human resources, yes. The other resources into finance, yes, to somehow like to improve the situation. So if we go for to contribute to those issues instead of the actual issue, for example, infectious disease, measles, tuberculosis, still problem there, and IBMS. So it would go to the wrong, say to another impact for So and after that would lead to inequality access to the healthcare services. More people will be more approachable or more advantage situation would have the more better access to healthcare than the disadvantage situation. So it create inequality access to the healthcare system. And it also lay the burden to the vulnerable disadvantaged communities who are really need to be taken care of, to be prioritized because they have many issues, including all communities and non-communities. The patients in the community safety, yes. Because like when it comes to medical tourism, because we don't have the the system actually access to the quality of all the healthcare services, health professionals that actually provide the healthcare service for the medical tourism in most developing countries. People just go to that particular hospital or clinics where they're it's really nice, really good plans after that. actually it's a good, which is like a trick or classic advertisement. So the quality is not sure, is not sure. Also the quality of the healthcare professionals. So if we lay the burden on the patients and the community, the patient here understand that and use this. Yeah, at the back of the okay. It's much louder. So if it comes to patient and community safety, when it comes to the patients from overseas, it's not only the patients, but the community that are actually involved in that. For example, we'll say infectious disease. If you come to another country for medical treatment, usually you would say, if you go to the hospital, if I live in Australia, I go to Vietnam, if you go to the hospital, if I have an infectious disease that's like hepatitis B or C, and before I go through with the core care, so that I need to report to inform that I have any infectious disease that I can actually read a program to the healthcare professional or other patient as well. But actually, would you be glad at? Because like it will involve with the confidential of the patients. So if you go to another country for plastic surgery, you need to declare if you have any infectious disease program, but we don't want to declare that. So it would lead to the safety, the whole community involved. And also it would go to ethical violation. What is the ethical violation? Say, the ethical would in fact not only the patients from other country, but also the people in other developing country. For example, I would say a little bit deeper in the next slide. And also I would say the reverse course. And also I would say a little bit more information about this reverse course in the next slide as well. So the growth health disparity, as I said, the healthcare staff in the public sector move to the private sector to contribute because they will have their higher income if they go to the private sector. So, and it will lead to the shortage of healthcare staff in the public sector, and it produces equal healthcare distribution between public and private sector. It also can affect the disadvantaged and vulnerable communities who really need the qualified and experienced healthcare staff to take care of them. In terms of patients and community safety, because we don't have the clear boundaries for the categories of medical tourism, so it would lead to the complications for regulatory and the management of medical tourism in our country. We don't have the procedure that to assess the patient or to ensure the quality of the treatment for the patient itself. And after the recovery, any complication go after that, we can't ensure that. And if they go back to their home country, like for example Australia, it would lead to the burden in Australia as well, because it would bring the complication to the health system of Australia. So it's not only a fact the health system of the developing country, but also it's the reverse effect in the origin country as well. So it also threatens the ethical standard and the safety of patients community, because we don't have the clear boundaries, we don't have the clear policy to actually accept the quality of the the quality of the healthcare system or the healthcare services. So we could go to threatening to the standard of their ethics for all the patients community. Well, ethical violation is a big problem. Malpractice, yes, every one of you must understand that already. But illegal organ transplant is a really big problem, because in the terms of demand and supply, it will go to supply, you need the transplant, then somehow people will be provided to you, and it go to the course of ethical and human standard violation. So I'll just go quick. This is the report from a paper in China 2006 alone, only in 1 year alone. So 8,000 illegal transplant and other illegal transplant as well. So you see, this provide the ethical violation in the country. Reverse course, yes. A lot of cost limiters. So in conclusion, I would say quick because time's too quickly. So the conclusion is that we go to the unclear policy and regulations, we don't have a good management system. So we go to the cost, the health disparity, violations, safety, and also the challenges that leaving behind for the whole health system of developing countries. But also it would affect other developed countries when people come and move from developing countries. In conclusion, yes, there are opportunities in medical tourism, not only for developing countries, but also for other countries as well. But also there are risks. So between opportunities and risk, we have to take both, but we have to manage to minimize the risk as much as possible, then maximize the profit that can actually impact and bring back to developing countries. So that's it for my presentations. It's not like a big or heavy research that I can bring up to you. It's just a slide program about medical tourism that actually occurred in Vietnam, in other Indonesia, Malaysia, Myanmar, and other developing countries. So I hope it does make sense to you somehow. And thank you so much for listening.
Thank you so much. It was really interesting. So let's see if there are questions. Here is one. Sorry.
Hello, hello, hello. So medical tourism has grown quite substantially from what you showed us. I'm just wondering, with COVID, now that it hit and it stopped people from traveling to different places, and we have restrictions and lockdowns and all that stuff happening, did that have a massive impact on medical tourism? And also, has it picked back up again since then? Would you say like where it was before, or even grown higher?
Yeah, that's a really good question. There's no official report, but I've checked like a report from the the tourism committee. What is actual tourism thing? Would say that before the COVID-19, Vietnam is not much of the high competitions all the time, other countries like China or Korea or Singapore. But somehow they say that because of COVID-19, we have a really good impact in the international health profession community, community, because we have done a really good job with like somehow with COVID-19 fighting, just like other countries. Yeah. So the report says that after the COVID-19, the number of people going to Vietnam for medical tourism is increasing. And I don't see any other report or research actually that makes the accuracy reliable. Yeah. You know what I mean? So I just say that number is increasing. But it would go again with the unclear boundaries of medical tourism. Yeah. Actually, that is the exact number of medical tourism, or just the people go for the health tourism, for example, spas. Yeah. So somehow the tourism just go with the number. I'm just concerned about the accuracy and reliability. Just like if we go to dental care, medical tourism, because dental care is a mix between medical tourism. If they actually have like, you have to take your tooth out, yes, it's medical tourism. But if you just want to whiten your teeth, it's not medical tourism. See? So because it's no boundaries, no exact definitions for it. So the number is just like a number. It's increasing, yes, or increasing in the number of tourists to Vietnam to seek for all the purposes besides tourist.
Can I ask a question? Yes.
Thank you.
So in Jordan, the medical tourism decreased, and one of the reasons is that there were complicated process about getting the visa. So is it like in Vietnam easy for people to get visa and doesn't accept people like from different nationalities?
Yes, it's easier for you to get a visa. I think it's only going to take you a month, or if you know the agency company, it can get you even, faster. But if you declare that you go to Vietnam for vacation, the visa will come for you easier. We will be granted to you easily, faster. Yes, if you declare that you go to Vietnam for the medical treatment, that's the problem now. You have to declare which kind of medical visa that you are seeking for, and how, like, you have to declare that all your diseases, health problems, and then you have to take like the medical history of record of you from your home country to provide it with your application to make sure that you actually go there for medical treatment. And how long would you be there? That's enough. And also the cost, then you will take care of the cost yourself or someone else or other organization. You have to provide evidence that you are capable of taking care of the cost yourself if you go to Vietnam for the medical treatment. So most people, when they go to Vietnam for any reason, they would go for either diplomatic if they are working at the consulate, or they go with the travel visa. It's easier, faster. Or with, for example, Dr. Nana, if you like to go to Vietnam for a training purposes, yes, it's easier. But if you declare to go for medical tourism, it's another, yeah,
challenge. Yeah. Thank you so much. Yeah. Okay.
Actually, I was wondering, when you started your speech, you said I'm a junior speaker, right? I don't think so. No, your speech was very informative, and it was really interesting, and your slide was a very beautiful background. I really liked it.
Comment. Even just looking at the slide is so relaxing, especially at the end of the day. So thank you so much. It was really interesting.
You've got black enough these. You've got.
Last, our last speaker is Ms. Rahila Hashimi. She will talk about the significance of implementing international patient safety goals in outpatient care setting at Mediclinic Al Noor JCIA Hospital. Assalamu alaikum. Good afternoon, everyone. First of all, I'm very grateful for UCG for providing me the opportunity, and for the organizer, and for all the participants. But unfortunately, most of them, they are not here. Okay, so I think so that not much left for me to talk, because most of the topics are covered. So the topic of mine, before that, I'll just go a brief introduction. My name is Rahila Hashmi. I'm working in Mediclinic Middle East, and I have done my MBA, MSc, and my thesis was during my MSc was the significance of implementing international patient safety goals in outpatient care setting at Mediclinic Al Noor Hospital, JCIA, Abu Dhabi. So before starting this presentation, I would just like to have a small questions, like what we think, why we are starving for the quality. Is safety is not sufficient to go with the patient care? Do we think that once we are talking about the safety, hospitals are really not sufficient enough to give you proper care of the setting? So the thing is that safety and quality, what's the difference? Why it's not sufficient for us just to go with the safety of the care? And though we have provided a lot of the standards set for our employees, everything regarding the safety, why still it's need day-to-day care, that still patient's care is still a big challenge once it's come to the quality? So the simple answer for that, safety is the setting when there is a lack of harm, but quality is the setting when we are providing the safety care with the efficient and effective care within very minimal time.
And it's not just easy to say that safety is just dealing like a patient is coming and they are going home without any harmful effect during the hospitalization. But the canvas is very broad in that you can look up to the finance and you can look up to the future of the healthcare in the population setting of that. So the background, despite the intention in many private hospitals to improve patient safety and quality of care, there is a lack of efforts from the understanding medical staff, perception of the patient safety culture. The need for human factors and system engineering expertise is persistent throughout the healthcare organization. Patient safety culture is an effective strategy to decrease the incidence of medical errors in hospital. I'll just give a brief story saying somewhere I read. This is the ICU's clinical setting with 7 beds. And this was the time when CCTV cameras and artificial intelligence was not very advanced. And maybe they were finding a very mischievous finding, like bed number 7, suddenly every weekend, there was a incident that patient was suddenly starting collapsing or some of the gasping kind of conditions by 3 a.m. in the night. It was happening a very specific time. It was happening with a specific bed, and a lot of investigation was going on. But unfortunately, because advancement of technology was not that much, so still the system was showing the failure, and they were not really able to capture what was the point of the failure once the equipment were the same, set of standards were the same. And luckily, one late night, one of the maybe shift supervisor, when he was making the round, he had just found that one of the housekeeping staff, he had just plugged off one of the equipment, and maybe there was no beep, so nurse can get alert off. So they were catching, by the time this story was like, they were just finding it's something mischievous, something ghost things are in the clinical setting. So they say that what is IPSG actually? IPSG is a second name, it's a ghost detector in your clinical setting in the advanced. So by using IPSG, it's not that you are involving your higher clinical staff. Even your housekeeping, you cannot ignore. You have to give them training from the very day 1 in the hospital. They must be trained with the policy, with the set of standard, even for example, hand washing, for example, slippery floors. So this is the importance of the IPSGs, and this is the beauty how IPSG is playing a very important, crucial role in any clinical setting. Hospitals with a positive safety culture would be characterized by open communication among their staffs, continued training for the patient safety practice, and encouragement to feel freely reporting medical errors. Luckily, in the Mediclinic, we have a very beautiful system called Total Patient Safety Care, TPSC, where we are giving, and our culture is a reporting culture. So the international patient safety goals are important guidelines at the international level to promote specific improvement in the process of providing safe and high quality patient care. International patient safety goals helps confirm correct patient identification, encourages effective communication between patients and medical staff, improve the safety of high alert medication administration, and ensures safe medical procedures. Patient safety is an important element of an effective, efficient healthcare system where quality prevails. According to WHO, even within the between 2019 up till now, there are 134 millions AER reported. Among them, 2.6 millions were found in a state of death. So if medical field is not coping with the IPSGs and they are not going with the set of standards, and there is a lack of reporting system, it can go in a very devastating state. Correct identification, even there are the set of the system, and the hospital where the identification system IPSG1 is focused, one of the very important, still we are facing the challenges, especially in the Mediclinic last 3 months. Even that's my study, that even our staff daily we are updating them. We have a tutorial and we have a weekly system. There is a clinical education. Still our TPSC is showing one of the highest tool of the AER, which is reported. It's patient identification. And what what is the reason behind? Maybe we can look that staff is too busy, especially the front desk staff. They are too busy, even though they are checking the patient identification through two identifier system, and there is a valid identifications tool like ID or passport they are scanning, but still there is an error happening in category of IPSG1. Patients are identified using two patients identifiers, not including the use of the patient's room number and location in the hospital. Patients are to be identified prior to being examined to consider special circumstances for which the hospital may need to develop specific process of patient identification. Moreover, IPSG1 is not at the front desk. Every station of the patient from the start of admission till discharge, whichever patient has to cross or whatever procedure they has to go, they must be identified through the barcode system from the first name to last name, and not only the date of birth is sufficient for that, but though included in that. IPSG2 effective communication, as it was told very clearly this morning by the prof, but what is effective communication? Effective communication is not the safe communication, but the communication which is delivered to your receiver. And it also starts from the front desk and it goes till the discharge. It involves even the patient care, patient pre-op plan. While staying in the hospital, they must be very clearly told, and the language must be clear. In Mediclinic, we have a system of interpreter. For example, if the language barriers are there, we have a very sophisticated system where our patients are well informed through the interpreters, and there is no ambiguity during the time of admission or pre-op setting or anything. Effective communication is not inside the hospital setting, but when you are doing the referral to the other hospital. For example, if your documentation within your systems are not done well, we can imagine that upon transfer to the other facility, how much time is going to waste from the patient. And not only that, it can cost hospitals, it can go to the burden to the finance, since you have to repeat your scanning, your radiological things, and maybe some of the diagnostic tool, just because your system was not updated at the proper time. So this is the beauty of effective communication, how it's going to help in the finance also. And IS bar is a very important tool where identification, situation, background. I have heard during one of our speakers this morning, they were just mentioning that when I think that there is something like language is not clear or something. So during IS bar, this is the point they have focused. When language is not clear and verbal order has to get, you have to read back. And this read back is not only simply you are reading back, you have to read back loudly, and there should be second witness available there. And there is a time limit for that verbal order. Within 24 hours, you have to clear with the authentic physician to make it actual order in the system. IPSG3, safety of high alert medications. So one of the biggest challenge in according to the ECRI, the latest report of 2023, there are top 10 strategies, and among them, one of that is the patient's medication prescriptions error and medication administration error. So when medications are part of the patient's treatment plan, appropriate management is critical to ensure patient safety. High alert medication that pose an increased risk of causing significant harm to patients if used in error. That's why we have a policy cross-checking the medication, read back system, and checking every patient's system from the pharmacy along with the barcode system. Non-safe practice can reduce the potential of the harm. It can involve any of the following processes such as prescribing, ordering, dispensing, distributing, preparation and administration, labeling, etc. Independent double check in handling is one of the safety measures. Errors can occur when staff are not properly oriented to the patient care unit, when contract nurses are used and not properly oriented or trained. Look-alike, sound-alike medications are stored with a proper labeling and with a Tolman method. IPSG4, of course, safe medical procedures. Actually, how important it is, even working in a very advanced hospital setting, we cannot avoid that errors cannot happen. I myself is one of the victims. I have went for one of the surgery like 6 weeks ago. It was just recently. And even I have gone through the counseling for pre-op assessment. It was very clear for me, but I experienced that when I entered to OR and that the site was left side and they were just reading it right side. And it's a very modern hospital. So though I was just listening to them, and of course they have used this strategy, they asked me, so I rectified, no, this is not the right side, this is the left side. So imagine if patient is non-medical and the language barrier is there and no one is focusing on this, so it can go on a big disaster even. So patient safety has to be one of the highest priority when patient has to go for an operation, and organization should develop guidelines to ensure that surgery is error-free. Correct site surgery is an encompassing word, means the right type of the operation is performed at the correct place of the body of the correct patient. Timeout, of course, should be done for all the invasive medical procedure. The timeout applies to any location in the organization where there is procedures are performed before starting the procedure, which involves the entire operative team. So this is the same thing, timeout should be done for all the invasive medical procedure and should be done for at least procedures that investigate or treat diseases and disorder of the human body through cutting, removing, altering, or insertion of the diagnostic therapeutic scopes. The timeout applies to any location in the organization where these procedures are performed and done just before starting the procedure, which involves the entire team. IPSG 5, of course, reduce risk of healthcare infection. Healthcare infections, if not reducing, it can go beyond the limits and it can affect the cost of the hospital. It can affect the days of the stay in the hospital, and even after discharging, if still infection is not within the limit, it can affect the lengthening of the procedure of the patient's disease. So all the healthcare facilities should have infection control procedures and policies, and staff should take every precautions to avoid spreading the infection. Proper use of PPEs, personal protective equipment, for example, gloves, masks, gowns, aseptic techniques, hand hygiene. The most important way to reduce the spread of infection is hand washing. Of course, frequently hand washing with soap and water, or if unavailable, just with the alcohol-based hand sanitizer. So at Mediclinic, we have infection controls committees, there are infection controls members, and there's randomly checking of the policy, and we have an update system of that. IPSG 6, reduce risk of fall, as it was told in 2 or 3 speech this morning, that how fatal it can be if we are not looking. A patient, for example, if even coming for ophthalmology clinic, and he is just with the, for example, some of the installations during the time of the triage for the, some of the solutions just for the, it's installed, and you can see that if patient is really sitting there and patient is not properly informed how this medication can make the eyesight blurred, and they start walking, how dangerous it could be if they have head injury. So a patient who came just for the simple eye checkup, how dangerous the thing can go beyond this, control, if we are not in the proper communication with the patient, and if hospital is not provided with the accurate system of for example, your hallway are very clean and your staff is well trained how to educate the patient. So IPSG is very important in that sense. Falls account for a significant portion of injuries in hospitalized patient. The organization should evaluate the patient risk of falls and take action to reduce the risk of falling. The evaluation could include fall history, medication and alcohol consumption review, gait and balancing screening, and walking aids used by the patient. The method which were used in this study is a research study design. Descriptive study design was used. Source of data was the clinical staff of the outpatient. Time period of study was since the number of the members were just 50 and time periods were just 3 months. Study type was used quantitative cross-sectional study, and sample size was consists of 20 nursing staff and 10 physicians. Sample technique was used, non-probability convenience sampling technique, and for selecting sample, a convenience sample of non-probability sampling method was used. So total of 10 physicians and 20 nursing staff with 50 questionnaires were used during this study. In phase 1, baseline data was collected from literature review, and phase 2 data collected in form of questionnaires which were responded from the participants. This is the responses from a table from the participants. So the result was total of 30 participants were included in the study program, from whom only 26 participants has completed the questionnaire. Data analysis completed from the 26 participant male and female staff, physician, nurses, paramedic. Main data analysis include total 1,326 responses. That's 51 questionnaire with 26 participants. So moderately, it was 8% response were agreed, and 0% were disagreed, 2% were slightly agreed, 1% neither agreed nor disagreed, 1 slightly agreed and disagreed responses, same 0.2, while 0% for total disagreed. So the conclusion is that result shows that there is an agreement among participants on high applications of each of the international patient safety goals variable. This indicates that the medical staff working at outpatient department at Mediclinic Al Noor JCI Hospital recognize the importance of the IPSG International Patient Safety Goals variable. The patient identification and communication was having the highest impact, and still these two are the recently big challenges in our hospital we are facing with, followed by safety of the medicine and surgery, and then infection followed fall hazards reduction respectively. And they say that safety has to do with a lack of harm, while quality has to do with efficient, effective working. These are my references. Thank you for listening, and thank you for your time.
Someone, any questions? Any questions? Everything is already been said. Thank you. Thank you. Thank you.
Did you?
She's mine. So with that, we conclude the second day. Thanks everyone for attending, and thanks for the speakers. I really enjoyed this sharing this session. Everyone was on time, and now we invite you to receive the certificates for the participants. So, yeah. Yes. Yeah, we would like to thank everyone for joining. Thank you for those who joined us online. And today we concluded our sessions. Tomorrow, I think there will be more sessions online. Now we will, handle the certificates for the participants, and we will ask them to come and receive the certificates. So, excuse me if I pronounce your name. Because Shahid Al-Qahtani. Al-Qahtani. Maybe some of the participants already left. She has